I call on the Chair of the Committee, the member for Fong Lim.
Thank you very much, Madam Speaker. Madam Speaker, this final report of the Legal and Constitutional Affairs Committee represents the best efforts of the committee to address the terms of reference provided to the committee on the 14th of May 2025 to inquire into voluntary assisted dying, or VAD as we commonly refer to it in the Northern Territory. The V.A.D. inquiry was challenging on innumerate fronts. It was challenging in terms of subject matter, it was challenging in terms of scope, and in terms of its timeframe for delivery. It's a great credit to all of those involved that the work presented in this report herein is of significant quality. It is seldom the case that reports such as this are able to capture and represent all perspectives and materials gathered and submitted. For that reason, we encourage interested parties to engage with the source materials of our inquiry in conjunction with this report, those being the many hundreds of submissions and the many hundreds of hours of witness testimony, in order to understand the breadth of the data collected and the positions presented. Notwithstanding the aforementioned, I am pleased to present this final report on VAD in the Northern Territory to the Legislative Assembly and the public at large as testament to our collective commitment to progress resolution of VAD for Territorians. In doing so, I express my gratitude, first and foremost, to my fellow committee members across the aisle and within the government, and likewise to the committee secretariat for their diligence and their respective efforts towards completing this extremely challenging inquiry. Finally, I thank again the many hundreds of Territorians who have contributed to this process and whose contributions will undoubtedly enrich our understanding of what is involved in finishing up well. Madam Speaker, VAD, voluntary assisted dying, is an extraordinarily complex topic that evokes emotion, tension, and challenges us all. It is literally questions of life and death that we are interrogating in discussing voluntary assisted dying. Ultimately, conversations about voluntary assisted dying are not just ones about fairness, they are ones about competing rights and competing tensions within our system and within our society. They are about the tension between the rights of individuals versus the rights of society, thinking about the common good, thinking about prioritising the needs of the one over the many. And sometimes lost in the debate in discussions surrounding voluntary assisted dying is that these are also questions of a tension between equity and economy. Voluntary assisted dying is more than just an arbitrary concept. It is, in practice, something that requires support, structures, funding, rules, governance, compliance, all of which are an essential part of creating a framework to assist people with what we once referred to as euthanasia. Euthanasia itself is a work derived from Greek terms, and it speaks to the idea of a good death. And voluntary assisted dying, the modern nomenclature for euthanasia, is in some ways an imperfect expression of the idea, but it is the journey towards providing people with the option to have a good death and equitable access to voluntary assisted dying that has driven this inquiry. Now, it's important to recognise that this is a journey that has been a long time in the making. This is a journey that did not begin 4 months ago when this inquiry commenced, but indeed starts in the Northern Territory context some 30 years ago. One could argue reasonably that the pursuit of a good death is something that goes back even further than that. But in the modern context, as many Territorians will know who have been around for decades, the Northern Territory was the first jurisdiction in Australia, and indeed internationally, depending on how you define it, to legalise an assisted death on compassionate grounds for people who were terminally ill. The Rights of the Terminally Ill Act, passed in 1995 when I was finishing high school, and I can recall the fervour surrounding it at the time, and it's remarkable that that fervour hasn't dissipated, and all these years later there are still passionate advocates for the rights of the terminally ill, both in a legislative sense and in relation to the underlying subject matter. Now, the rights of the terminally ill warrants mention as a precursor to discussing today's report because it really provides the foundation for the discussions that we are having. Some 30 years ago, the then Chief Minister, Marshall Perrin, took it upon himself to introduce to this House a bill to legalise voluntary euthanasia. He did so at considerable political cost and demonstrating great courage at the time. That bill ultimately passed, as we know, by the slimmest of majorities, and not across party lines, but on the matter of a conscience vote. The final vote being one from then MLA Wes Lanhupoy, who, in his final assessment, determined that whilst voluntary assisted dying, or euthanasia as it was at the time, was not something that he envisaged his constituency or representatives, or perhaps the broader Aboriginal public, would want to avail themselves of, it was not something that he felt he should stand in the way of for the remainder of Territorians who were expressing with some clarity a desire to have legislation in the space of voluntary assisted dying. That bill was substantively about euthanasia and voluntary assisted dying, but it also represented a point of maturity and growth for this Parliament. It represented that this Parliament had the capability and the capacity to work across party lines for the greater good of Territorians. That bill signalled to the Commonwealth Government that this was a jurisdiction that was emancipating itself, that had achieved self-government in 1978, that had stabilised its polity and its representative democracy, and had the maturity to be able to prosecute complex arguments and come to a determination for what was right for Territorians. As we history students will all know, though, that bill did not endure. The Rights of the Terminally Ill Act was challenged the year after it was enacted. Only 4 Territorians ever were able to avail themselves of the opportunity to have an assisted death. And in 1996, the Kevin Andrews Bill, as it is colloquially known, a bill by a member of the then Howard Conservative government, a backbencher bill, interceded to stop Territorians and indeed subjects of any of the territories from being able to legislate in a number of spaces, but most notably in relation to euthanasia. Territorians were then, by and large, and continue to be, aggrieved by that decision, by the federal government usurping the will of the Northern Territory and the will of Territorians. That was a step backwards in our constitutional journey and our capacity to determine our fate for ourselves in relation to all of our affairs. Some 22 years or thereabouts had to pass before finally, in 2022, the Commonwealth Government was able to amend that error and pass the Restoring Territory Rights Act. That legislation was driven by members of the territories in the ACT, as well as our federal representatives in the Northern Territory, and it provided the foundation for Territorians to once again determine for themselves their own futures in relation to voluntary assisted dying. Many people assumed that there would be an immediate correction and that governments would seize the opportunity to act with haste to remedy what was an abrogation in many people's eyes of the rights of Territorians. That is not entirely how things played out, as we are aware. In the background, states of the Commonwealth, from the start of 2017, had all started to make the determination that voluntary assisted dying laws should be considered and enacted as a matter of equity and as a matter of fair access to healthcare across all states. That process began in 2017 in Victoria, where the first voluntary assisted dying legislation was passed. The passage of that bill was a rollercoaster affair. It was something that was achieved under Herculean pressure. The efforts underpinning it were not to be underestimated, and the protagonists behind the bill really paved the way for every other part of Australia to be able to gain access to voluntary assisted dying. Victoria first, followed by South Australia, West Australia, Queensland, most recently New South Wales, and then the ACT, whose legislation, whilst enacted, has still not come into full effect. Each one of these expressions of voluntary assisted dying legislation has developed iteratively, and each one of these bills has learnt from the last, to the point where now Australia has broadly coalesced around the Australian model for voluntary assisted dying. Now, from the outset of this inquiry, old hats to the Territory would put it to members of Parliament across of all stripes that we should simply resuscitate the Rights of the Terminally Ill Act, scrub out 1995, insert 2025, and Bob's your uncle. The truth of the matter is, this is a much more complex matter in this day and age than it was at that time, when there was a simpler regime for accessing an assisted death. For all intents and purposes, the Rights of the Terminally Ill Act decriminalised the process of assisting with a death for a terminally ill person, but lacked any of the checks and balances that are embedded into all subsequent legislation across Australia. So the process that Australia has settled on broadly for voluntary assisted dying is undoubtedly more burdensome and cumbersome than the Rights of the Terminally Ill Act was. However, it is also much more rigorous and contains checks and balances in process and procedure to ensure that what we have is something that provides Australians equitable access to voluntary assisted dying, but that we don't end up on a slippery slope argument to abrogating rights and devaluing human life. The Northern Territory government in 2023 and 4 chose to finally act on the Restoring Territory Rights Act and commissioned a report of independent experts to inquire into voluntary assisted dying and how to progress the matter for the Northern Territory. That inquiry is the basis for the inquiry that the Legal and Constitutional Affairs Committee has undertaken. The 2024 Independent Expert Advisory Report contained within it 22 recommendations for how to progress the agenda for Territorians. Our remit as a committee was to, in the first instance, interrogate the parameters of that report and to consider whether or not it could be refined, was fit for purpose, whether we might be able to add value to the equation to ensure a possible practical legislative implementation of voluntary assisted dying in the Northern Territory. We, by and large, set out on our journey not with a view to challenging the 2024 report or to codifying the 2024 report, but simply to add a body of knowledge to the 2024 report's findings, particularly with respect to the views of Indigenous Territorians and Territorians who live in remote and regional areas. The challenge had been made that in the past, consultations outside of major urban centres had been limited and that there was an opportunity for greater consultation to be done in areas outside of major cities. The terms of reference for the inquiry, therefore, were fivefold. Firstly, to provide a consultation paper to stoke the conversation again. Now, with respect to the consultation paper, we provided a 50-page document for Territorians where we simplified the issues and broadly considered the main questions of access and eligibility and process, and we did the best we could to distribute that information to Territorians across languages, in multiple mediums, in multiple forms, to provide people the opportunity to be able to be grounded in the major issues surrounding voluntary assisted dying. The second part of our terms of reference was perhaps the most important and value-adding, and that was the direction to consult extensively with people in the remote Northern Territory, to gauge views from people who may not have had the opportunity to fully provide views. The third part was to evaluate existing VAD models across the country and to some extent the world, to establish where we're up to, where we might go from here. A fourth part of the terms of reference was to consider specific challenges for the Northern Territory, noting that we have unique geography and demography and economy to consider, and that, as we are all aware, one size does not fit all, and the Northern Territory is measurably different than the rest of the states and territories of Australia. And finally and uniquely, we were charged with the responsibility, if appropriate, and if suitable support was found for voluntary assisted dying, to provide drafting instructions for model legislation. Now, that final direction is extremely unusual by the measure of parliamentary inquiries. It is a rare thing to be afforded the opportunity by the government of the day to prescribe what model legislation in a space might look like. And the government is to be credited, in my opinion, for providing us with the option to not simply make recommendations, not simply provide testimony and evidence, but actually to say, this is what the VAD law should look like in the Northern Territory if we are seeking best practice and to make it work for Territorians. That final part of the process alone is many, many months of work. And the totality of the terms of reference that we were provided was, in my opinion, a huge ask of any parliamentary inquiry, let alone within 4 months. I emphasise that point to once again reiterate that it is a great credit to all of the people involved in this inquiry, the committee secretariat and committee members of the government, the opposition and the crossbench, that we have been able to provide anything and submit a report of any quality, let alone a report of significant quality. The protagonists involved in the inquiry had to work collectively, coherently, albeit in an extremely high-pressurised, challenging space, discussing extremely sensitive matters under impossible time constraints. Nevertheless, we have been able to produce something which is a document which we believe will progress the agenda of VAD for Territorians in a meaningful way, beyond simply paying lip service or, quite honestly, playing politics with the issue, which, again, I reiterate, with no pun intended, is actually a matter of life and death. Now, my priority as the chair of this committee has always been to oversee a process that has been rigorous and a process that has been transparent, but not necessarily to advocate for an outcome one way or the other. I myself am not interested in dying on a hill for the issue of VAD. What I'm interested in here is demonstrating that this Parliament was able to take something challenging, as our predecessors did in 1995, and deal with it with maturity across party lines for the greater good of Territorians. And that is exactly what I think we have, by and large, been able to do. Now, what does rigour and transparency look like in the context of this inquiry? Well, in the first instance...
Pardon me.
Bless you, Madam Speaker.
Oh, thank you.
In the first instance, what rigour and transparency looks like is keeping Territorians abreast of what we are doing. We were provided terms of reference mid-parliamentary sitting on the 14th of May, and the committee wasted no time in meeting immediately to clear our calendars for 4 months, essentially, and try and establish a timetable for how to deliver this process. And that included doing things that are not often done in this Parliament, and that we did not to grandstand, but that we did to keep Territorians apprised of our work. Interim reports were presented to allow Territorians to know that we were working on this continuously. The first interim report, submitted in this Parliament in July sittings, outlined work that had been completed to date and the blueprint for the inquiry going forward, to give people confidence in the process that we were seeking to follow. The second interim report tabled at the start of September, similarly at the conclusion of all our hearings and consultations, outlined in detail exactly where we'd been, exactly who we'd spoken to, and the parameters of our consultation, including the details of specialist advisors who we had procured to help guide our deliberations, noting that none of us are subject matter experts in this area. So those interim reports were part of the process, as were regular engagement with media and providing media releases to allow Territorians to know where this journey started, where it is up to, and where it goes next. That should be, in our opinion as a committee, the gold standard for how committee inquiries are conducted, particularly when they are substantive inquiries with heavy weighted subject matter, as is the issue of voluntary assisted dying. We've also prioritised at every stage the full and timely disclosure of submissions and of evidence. We have iteratively released for public viewing all of the 400+ written submissions that we received, whether they were manifestos and thesis length or simply 2 lines of somebody wanting to have their say. And all of that evidence is extremely important. Now, as I pointed out, the reality is that all of that evidence will never be able to be captured in its fullness inside a report of 200-300 pages. But it is important to recognise that everyone who had a say here counts. And I say to everyone who provided a written submission to this committee that we heard your submission, we read your submission, we considered your submission. Because the fact is, we were asking for the opinions of Territorians, not for a check-in-the-box exercise, but because we are genuinely interested in what Territorians have to say on this matter. Some of it is extremely intelligent. Some of it is slightly bonkers. But all of it is really important. And that is why myself and my fellow committee members took the time to wade through the materials, to say nothing of the committee secretariat, who similarly have been drowning in VAD-related materials for months and have surfaced with a report. Now, the other thing we did to give our process rigour was not exclude the prior voices that established the parameters for the VAD agenda. To that point, from the very outset, the committee took a number of private briefings with key protagonists. The former chairs of the 2024 Independent Expert Advisory Panel were top of our list, and we are extremely grateful to the former Administrator, Her Honour Vicky O'Halloran, and also to Duncan McConnell, SC, for taking the time to help guide our journey and cooperate with us at every turn to avail themselves and to support our process without at any stage detracting from our efforts. Other key people provided significant private briefings to us in the background, including some of the key advocacy groups for voluntary assisted dying. And we took those meetings deliberately because we wanted to hear from everyone that we could reasonably hear from within a time-limited period. And so we heard from Go Gentle, and we heard from the voluntary euthanasia societies and advocates. And at subsequent junctures, we also heard from key opponents of voluntary assisted dying to ensure that we did not silence the voice of Territorians. To that point, all of the submissions that we received, the committee worked through carefully to determine in relation to what should be available to the public, what should be redacted, what should be kept confidential. And in the main, the committee has sought to provide transparency, provided that people's interests were not going to be personally affected, of course, redacting people's names and so on and so forth in submissions, names and addresses. For the most part, we've allowed people to have their say. Whether what they have to say is rational or not is for everyone to judge for themselves, or reasonable or not is for people to judge for themselves. But we wanted people to be heard, and we wanted to ensure that we provided transparency in this process insofar as reasonably possible. As I alluded to earlier, we also took the opportunity to appoint key subject matter experts as advisors. The first of those advisors was a medical, clinical subject matter expert. And so to Dr. Tanzil Lamba, on behalf of the committee, I express my gratitude for helping us as people without medical clinical insight to work through challenging questions that only a subject matter expert is able to guide you with. It's a credit to her that she was able to do so dispassionately, notwithstanding that she herself was a member of the 2024 Independent Expert Advisory Panel and of course has a personal view on these matters of her own. But her input was key in helping us to understand the finer details of what is involved with voluntary assisted dying in practice. The other core group of advisors that we appointed that have provided, in my opinion, immeasurable value to this process and really differentiate the work that we have done here from some prior work is the legal advisory team that we were able to appoint from the Queensland University of Technology. Now, QUT's team was headed up by Professor Ben White, and for anybody who knows anything about voluntary assisted dying in a research or academic sense, they will know that Professor White is the Australian gold standard academic on these issues. Professor White was ably assisted by Dr. Madeline Archer, Catherine Waller, Dr. Katrine Delvilla and Denisha Tyler, and that group of people from the Australian Centre for Health Law Research were able to provide us with the practical legal guidance we required to turn the committee's policy positions and deliberations into quantifiable, executable legal drafting instructions. The drafting instructions for model voluntary assisted dying legislation are appended to the final report in Appendix 3. And to a large extent, they have attracted a lot of the attention because they are, in essence, the distillation of a blueprint for how to go forward from here. And it's extremely important for the sake of legislators, Parliamentary Drafting Council, our legal department within government, that we're able to provide succinct and clear guidance on what we believe as a cross-party committee is the best way forward. But having said that, they are not the full totality of the story. And so today, in the main, I won't be focusing on the drafting instructions, but on many of the other materials supporting that, including the report itself, the recommendations, and the underpinning data. My focus today, in sum, Madam Speaker, is to provide clarity. Clarity for Territorians and clarity for parliamentarians. Clarity on why LCAC, the Legal and Constitutional Affairs Committee, has made the choices that it has made. The what, if you like, of what we have done here, but also the underpinning logic of why. Because in isolation, simply reading the drafting instructions, detailed and well produced as they are, does not necessarily provide the totality of the picture of how VAD could or should work in the Northern Territory. And without being impolitic or impertinent about it, in the time since the report has been delivered, the sequence of questions that myself and fellow committee members have received from many, many, many people, the general public, our own colleagues, bureaucrats, advocates, lobbyists, all demonstrate to a large extent considerable misunderstanding of many of the issues surrounding voluntary assisted dying in practice. And so what we are looking to do here is talk about things in a practical sense and explain the choices we have made for the benefit of everyone involved with a view to progressing the agenda. Because here is the nub of the issue. In principle, support for VAD is one thing. Do you support VAD, yes or no? That's a much less complex question to ask, but a fairly imperfect one that doesn't actually progress the agenda for us meaningfully in isolation, without consideration for broader factors, without consideration for the practical, timely, without considering practical and timely implementation and how we will achieve that. If we're not careful, what we do is risk endorsing, supporting or providing a legislative solution for voluntary assisted dying in the Northern Territory that prohibits Territorians from ever realistically accessing it anytime soon. And so we've tried to make the tough choices on the Kerle questions, and today I'm going to help explain why we've made the choices that we've made. Now, that broader consideration that's required is first and foremost signposted and signalled within the terms of reference, within the table of contents, if you like, for the report. Going straight to the contents, you get a sense for what the priorities are and what the issues are in a broader sense here. It's not just about eligibility and whether somebody should be over 18 or under 18. There is a broad landscape and ecosystem of intersecting issues here. And so for that reason, our report begins with a background to the inquiry and explanation of the conduct of the inquiry, which to some extent I have highlighted today. And then it progresses immediately to considering the intersection of VAD with existing NT healthcare, because VAD doesn't operate in isolation. VAD is another component of healthcare that has interdependencies and interactions with, most notably, palliative care, with aged care, with primary health care, with interpreters, with telehealth. There are a range of interdependencies here, and to think about VAD simply in isolation does a disservice to the whole agenda. And so we have tried, within a confined space, to consider challenges to healthcare delivery in the Northern Territory to situate the VAD conversation. We have thought about remoteness. We have considered the issue of cross-cultural challenges, noting that 30% of the Northern Territory is Indigenous, and we are the most culturally and linguistically diverse population in the country. We are ethnically, religiously, racially more diverse per capita than anywhere else. You simply can't ignore those factors when you're thinking about healthcare. You simply can't ignore those issues when you're thinking about burden of disease. And burden of disease, again, is something that plays into understandings of VAD. And as many have heard me speak about in this chamber in relation to other matters, we discuss at some length health workforce shortages. The fact is, we have a shortage of healthcare workers, whether we are talking about doctors, or nurses, or allied healthcare practitioners, or patient care assistants, or translators, or liaison officers, or Aboriginal healthcare workers. So we have a strange system with a finite amount of staff. We don't have standalone service delivery in a range of areas. We don't have a specialist standalone paediatric setup or cardiology setup. It's important to recognise that this is a new component to the healthcare system, and if we want to introduce it, it has to work alongside what we have and not come at the cost of what we already have as well. And so we consider the interface with existing health services. We consider aged care services. We consider mental health care services. We consider disability services. And we consider Aboriginal medicine belief and practices as well, noting our unique demography. Now, that's a lot of content to cover in 20 pages in one chapter, but it's indicative of the scale of the task here that we've been tasked with. And again, our report in the main is geared towards providing practical instruction for how to move a legislative agenda for VAD forward. But to do so in isolation would be negligent and, in the committee's considered opinion, deleterious. We move on from thinking about intersection of VAD with the existing NT healthcare system to then thinking about the phrase that we landed on that resonated most profoundly for Territorians across the width and breadth of the Territory. Finishing up well. Finishing up well. We found time and time again that there was resistance and baggage associated with the word euthanasia, which is now a dated word for some people, beloved by some, hated by others. We found all manner of resistance towards the nomenclature VAD, or voluntary assisted dying. Some people simply didn't like the terminology and felt that it itself detracted from the compassionate and decent side of what providing a good death was all about. But when we talk to people, particularly in our remote consultations across the Northern Territory, about providing people with help and choice to finish up well, people nodded their heads in profound agreement. The fact is, we are all, for all of our differences, human, and no one anywhere particularly wants to die a bad death, a painful death, a lonely death, an isolated death, a death, embedded in suffering. And to that extent, we considered what it means to finish up well. What medical treatment provides in this space, what pain relief provides in this space, palliative care, palliation, palliative sedation. We considered a natural death and the testimony we'd received from so many places about people who stoically want to die unaided by assistance, even with great suffering. And extremely pertinently for this inquiry and this place, we considered finishing up on country, which was of profound importance to huge numbers of Indigenous people, wanting to connect to place, wanting to have the opportunity and the provision and the support to be able to not die in a hospital bed in an urban centre 1,000,000 miles from the place that you are connected to culturally, spiritually, practically. And finishing up on country, as a result, had to be mentioned with care and detail in our report. End-of-life choices vary, and we had to explore to some extent palliative care, of course, but also the idea of withdrawal from treatment, because the brutal reality of it is that Not every community in the Northern Territory is New York City. There are profound capacity deficits, service deficits, workforce shortages across the Northern Territory. And it's simply not possible to provide the full suite of services and opportunities in many places. But I return to the fact that, by and large, people don't want to die a painful death, and for the most part, they would prefer to be surrounded by loved ones in a place where they feel that they would wish to pass on. But it's an unreasonable expectation for most to be asked to withdraw from treatment, to finish up on country, unaided with assistance and any of the tools of modern medicine to help you with pain relief, to help you to pass on in a peaceful manner. And so we had to wrestle with these extremely challenging questions, these extremely sensitive matters. The committee members represented all sides of the political spectrum, and we all have personal beliefs, we all carry to some extent political baggage, we all to some extent had to work together for the greater good, and it's been challenging, but again, a testament to the entire group that we were able to find consensus positions in the main. And nowhere is that truer than in relation to our fourth chapter, service delivery models. Now, in some ways, the signature piece of the 2024 Independent Expert Advisory Panel report was Recommendation 2, which suggested that the Northern Territory should have a fully centralised VAD service delivery model. So in practice, what we're talking about is, in the interest of providing clarity about where the lines of healthcare end and where VAD starts, in the interest of prioritising cultural safety, in the interest of not confusing people interacting with the healthcare system, that we might have a fully standalone, separate VAD service. And when you dig into the nuts and bolts of what that involves, we're not talking about one doctor and one nurse on standby. There is an architecture surrounding the provision of VAD, the VAD Navigator service, centralised pharmacy services, review boards and governance, so on and so forth, all of which I'll come to in due course. A key deviation for this committee was to, on balance, decide that the best way forward for the Northern Territory in terms of providing equitable but also realistic and fast, or at least timely, access to VAD was to lean on instead what is broadly considered a community-based model, what is in fact utilised everywhere else in the country to a large extent. Now, I'll provide just a small amount of definition to that before I speak about it at length later. The Northern Territory has some 1,400 doctors, give or take. We have, per capita, more doctors than anywhere else in the country, actually. Something like a metric of 5.2 or something versus 4 point something or the other for the rest of the states and territories. But we know, because of our unique demography and geography and burden of disease, that that's still not enough doctors. That's still not enough doctors to manage our specific healthcare challenges. And so the idea that introducing a couple more to stand alone separately from all of that would be able to manage this process for a finite number of people who might avail themselves of the service at a considerable cost is unrealistic and not a pragmatic outcome in our view. And on the basis of that, we have advocated to deviate from the 2024 report in suggesting that we should be utilising the full network and tapestry of our service providers, including private healthcare practitioners who provide primary healthcare some 2/3 of the time. In essence, we want to basically make use of our existing structures, and we want to make use of our existing network of healthcare providers to allow people embedded within the healthcare system already who choose to participate with voluntary assisted dying the opportunity to do so. We subsequently moved on in our report to purposes and principles, which are often glossed over and not actually articulated clearly. What is the purpose of this report and the underlying legislation? What are the principles that underpin why we are doing this? I'll come to that in detail shortly. From that point onwards, the report becomes technical and substantive and gets, if you like, into the guts of some of the things that we turn our minds to usually when we think about VAD straight off the bat. Eligibility requirements, broken down into voluntariness, medical conditions, residency, age, capacity. Request and assessment process, the actual process that is followed now for VAD, the flow diagram, if you like, of what happens and then what happens next and what happens after that and how many days do you have to do this and where do you get the drugs from, whether, all of that business. And so we will go through the assessment process in relation to requests, formal requests, the use of interpreters, the use of telehealth. The administration of the VAD substance is a not insignificant issue, which is the focus of our 8th chapter. And that issue, let me be clear, this is the kind of thing that won't be in the report. That issue single-handedly almost derailed the Victorian effort to enact VAD legislation. At the 11th hour, questions about, hang on, safe storage and supply, where is this going to be? Who's going to have the lock and key? How is that going to operate? These are the real nuts and bolts questions that you need to consider when you're considering legislation for VAD, implementation of VAD, realistic and timely access for Territorians to VAD. There is then, of course, also the question of what happens after a person dies. There are questions there to be resolved as well, including the notification of death, interactions with the coroner, and so on and so forth. We consider at some length health practitioners' qualifications and training, and for the most part land in the same place as the 2024 report and standards around the rest of Australia. Noting, however, that we simply don't have a ton of doctors, but nor do we have a ton of nurses. And so relying on structures that are important and leaned upon heavily in other parts of the country, for example, like nurse practitioners, is less of a priority for us than it is for other places. Put simply, our position was to land on doctors making decisions and then to extend that to doctors and nurses having the opportunity to help with the administration of VAD, if and when required, particularly on location. There is also, of course, the issue of self-administration, which has a number of curly questions attached to it, which we will go through shortly. A critical deviation then, again, for this committee in relation to past work is in relation to non-participation by healthcare workers and entities. Our committee has broadly been of the view that choice is absolutely paramount in discussions about VAD. The choice to be able to access VAD as a patient, the choice to be able to conscientiously object if you don't want to be involved in the process as a healthcare worker. That's not to say that we want to frustrate the process, but in the context of competing rights, that we should be prioritising choice at all times. The choice of an individual to choose to not be involved with the process on whatever grounds they see fit. The choice for institutions to be able to also determine that VAD, if legislated for, is not something that people will be forced or compelled to have to deal with. What we're trying to provide is choice, help and choice for people to finish up well, and choice for people to be able to participate in assisting people with voluntary assisted dying if they so choose, but also the protections in law to be able to withdraw from the process if they choose not to participate. Accountability offences and protections are the kind of thing that you don't think about on the front end, but creating VAD legislation necessarily means that you have to think about all manner of other legal structures and intersections with the legal system. The review board is, again, a point of departure from many other states and territories. We have landed on a consensus position where we have suggested that we should make use of our existing resources, tools, structures and mechanisms. Now, when you look at the VAD data across the country in terms of the number of people that have availed themselves of voluntary assisted dying, you see that the numbers are not in the thousands, they're in the hundreds, and that's in states and territories with populations of millions. If you reasonably extrapolate to the best of your ability from that data set, all of our evidence suggests that we would expect reasonably no more than 10 to 20 people a year to avail themselves of VAD in the Northern Territory. Now, 10 to 20 people doesn't, in our mind, in the first instance, as a matter of expediency, time, equity, justify setting up huge and expensive separate structures. And that is part of the reason why we have suggested that our review board, unlike any other review board, should be chaired ex officio by default by the Chief Health Officer of the Northern Territory, embedded within the Northern Territory Department of Health, not a totally standalone separate statutory entity that will require time and significant resources to be set up and be supported in perpetuity. We recognise, of course, that that means that there is a complete and perfect separation from the health system or from direction from the government of the day or the minister. But on the balance of all available possibilities, we think that it is a constructive way forward. I note also, just to foreshadow, though I'll come back to it, that these are matters we interrogated extensively with the Department of Health in our discussions with them in public hearings on both the 5th of August and again on the 5th of September. And I want to actually take this moment to thank those witnesses from the Department of Health who spoke to us at length and were extremely honest and clear-cut with us about the practical, pragmatic reality of VAD, about what it would take in relation to implementation, about what it would cost, what the true cost would be, and what would be required to not set also the health system up to fail on poor delivery of voluntary assisted dying. I can remember them off the top of my head. I'm grateful to Chris Hosking, the CEO of the department, Dr. Paul Burgess, the Chief Health Officer, Dr. Kayam Vella, a clinical subject matter expert and palliative care physician, and Dr. Jeremy Chin, the Chief Medical Officer, as well as to Dr. John Zorbas, the head of the Australian Medical Association. Those 5 individuals in particular took considerable time to report to us, both in person and in writing, to help us understand what was possible in practice. Because as a matter of equity, they all felt that people should have access to voluntary assisted dying in some form. And as a matter of equity, that is essentially the position that this committee has landed on as well. But as I say, as a matter of practice, we had to really dig into that. What was it going to cost? How are we going to do it? What is the best way forward? How can we make best use of what we have? So returning to Chapter 12, Accountability, Offences and Protections, we've had to consider the composition of the review board carefully, and I will go through that shortly. Appeal mechanisms. There must be appeal in law, rights and procedures and options for people to be able to take VAD outside of the medical process and outside of the healthcare system. And so the natural fit for that in our jurisdiction is the NT-CAT, the Civil and Administrative Tribunal. And we know how overstretched the NT-CAT is. We understand adding additional workload to it in this regard on complex matters that may not be entirely within their subject matter expertise or wheelhouse adds an extra layer of challenge. But we deem it to be the appropriate forum to make the subjective determinations when there are appeals processes. What if somebody doesn't quite meet eligibility requirements or residency requirements? Or what if there are problems in the formal assessment process or in reviewing documents or testimony or witnesses? None of which, of course, precludes the fact that all rights under law should still exist in terms of appeals with the Supreme Court. Creating this kind of legislation also necessarily requires you to create new offences and contravention provisions, because if you misuse or abuse the processes of VAD, it is necessary for there to be measures in law for remediation and justice, as it were. And finally, there are a number of miscellaneous provisions which we have had to address, including one that wouldn't necessarily turn to mind, which is the public education component of all of this. Very little is known or understood about voluntary assisted dying in practice by a great number of protagonists. And so it is important that whatever happens moving forward with this matter, that the government of the day continues to maintain clarity of communication with all Territorians. Many of our witness transcripts will validate that we are having an iterative discussion with Territorians about VAD, much more so than just saying, what do you think about X? Because to some extent, the question would come back being like, I don't know anything about X. I haven't really heard much about it. Tell me about it. So it's going to be extremely important for us to take into mind public education and implementation and the package of materials that were required to progress VAD meaningfully as well. Madam Speaker, I turn my attention at this time now to the goal, if you like, of this legislation. And the goal of this legislation, the goal of this report, has always been to progress the issue. That has been the fundamental goal, to progress the issue for Territorians, not to be determinative in any specific prescribed way in one direction or another. And so to a large extent, the focus has always been on the drafting instructions, the blueprint, the recipe for how to bake the cake. But the thing is, the drafting instructions are a distillation of the inquiry. They do not represent the totality of the inquiry. They do not even represent the totality of the report. On the contrary, the report has separate and specific recommendations that are detailed, a significant number of them. And those report recommendations are what I will now turn my mind to with a view to elucidating the broader issues. Madam Speaker, the report contains embedded within it and spread across the entirety of the report 80-odd recommendations. Now, the weight of my remarks today will not be to focus on those that are self-explanatory. A number of recommendations are simply put self-explanatory and do not require contextualisation. However, a great number of them do require more clarity, and so it is not my intention today to read out chapter and verse the report and submissions and data, much as I'd like to do so, but rather to provide context and establish the underlying logic and highlight the interdependencies between a great number of these recommendations, which are the next level up, as I say, from the drafting instructions in terms of explaining the what, but not necessarily always the why of how we proceeded. And I would simply say, Madam Speaker, through you to the House, that with great respect, Territorians have been waiting many decades to talk about this issue and for progress on this issue and to be heard on this issue. And so, without belabouring points, I will take my time to explain to Territorians today how we think we should move VAD forward. The report, as I say, has many recommendations, some of which marry up closely with the drafting instructions, but some of which are separate to the drafting instructions and live a level above those drafting instructions and are every bit as important to making sure that VAD in practice will work in the Northern Territory. Recommendation 1 seems harmless enough, but I can't not mention it, and that is that we recommend that the government draft legislation as per our drafting instructions to progress the agenda on VAD. So straight away, what we are saying to all of you here is that we have comprehensively looked at these issues as a committee of 5 across parties. We have delivered to you a report for the first time in living memory for some that has no dissenting reports. We have a unified position on what we think will work, challenging as it was to have to sometimes figure that out. It is comprehensive, the report, as are the drafting instructions, and more importantly, they are context-specific. They are not a cookie-cutter taking a bill from another jurisdiction and then mucking around with it a bit and then seeing if it will work. We are talking about creating bespoke legislation that is consistent with VAD legislation across the rest of the country and the Australian VAD model, but that is unique to the Territory, recognises our unique burden of disease, demography, geography, limitations, capacity deficits, workforce shortages, fiscal position, all of the above. So our starting gambit is to say that this committee determined, yes, there should be draft legislation to move this agenda forward. Now, why did we make that determination in the first instance? Because in the first instance, we believe that there is more than 51% and less than 100% support for VAD. We can't measure that, nor were we tasked with doing that. It was not the job of this committee to run a referendum on VAD to say X% of people are for, X% of people are against. That is now going to become the job of all parties involved with VAD going forward, to determine within individual communities and constituencies the extent to which there is support for voluntary assisted dying of a specific type, of a specific model, pertaining to a specific bill. And so I would encourage, personally, and I believe I speak on behalf of the committee, all parliamentarians, to be canvassing opinion on voluntary assisted dying, not just in principle, but with some reference to practice. And in the absence of a better framework to articulate that practice, an excellent starting proposition would be Appendix 3, the drafting instructions for model voluntary assisted dying legislation in the Northern Territory. Seek opinion not just on whether people are a yay or a nay, but if what is embedded in here is something that they're on board with. The second recommendation of the report, again, at face value might look glib, might look like a little bit of a nonsense throwaway, but it's not. It's a very carefully considered thing that we've said, which is that we recommend that the government name any forthcoming legislation the rights of the terminally ill. Now, we have said that not just paying homage to Marshal Perrin or people who have come before us on this issue, but because we think that the history and the legacy of this issue should be recognised, and it should be embedded within our thinking for voluntary assisted dying moving forward. The fact is, in other places, the nomenclature voluntary assisted dying rather than euthanasia or terminally ill has taken over to provide for the possible expansion, development of voluntary assisted deaths. But in Australia, there is real clarity about the fact that voluntary assisted dying should be available not to people with dementia, not to people who lack decision-making capacity, not to people who are exclusively suffering from mental illness, but to people who are, for want of a better word, terminally ill. There is specific nomenclature for that, which is, in the legal term, having an advanced and progressive condition. We'll come to that shortly. But we think that it is actually significant and important to take back to the public that what we are looking to do is not resuscitate the 1995 Act, but to pay respect to it and to recognise that in the Northern Territory, we believe Territorians should have access to finishing up well through their implied and, in some ways, perhaps expressed right to, their right as a terminally ill person to avail themselves of a good death is in essence what I'm trying to canvass. So I would encourage whoever goes forward with this process to consider the importance of maintaining the focus on terminally ill persons and their implied right to a good death. Our third recommendation is an extremely significant and substantive one, which is not mirrored in the drafting instructions at all, because it doesn't, in truth, have a place necessarily in any forthcoming legislation. And that is the recommendation that government review current palliative care services and that government develop a palliative care strategy that is broader than what it has now, recognising the absolute mountain of evidence that we have that says that there is an increased need for palliative care services following the introduction of VAD. Now, if you look carefully at the testimony from September 5 and from August 5 with the Healthcare Department, you will see the clearest expression of that from our healthcare practitioners, saying that we know that we already have significant limitations in palliative care. We know that we already are stretched on all of those fronts. We know that there are many places who cannot avail themselves of palliative care properly. To introduce this, we know, will place additional strain. And so you will find robust questioning from myself of those parties to work out just how much more do we need? Just how much more will this cost? What is the real cost and workforce impost of introducing voluntary assisted dying? And again, I thank the witnesses for their clear and honest testimony. The fact is, estimates range between 10 and 30% of additional impost. Now, that level of extra effort in the healthcare system in palliative care is not something that will happen, readily or easily at a time when we are constrained fiscally. But it is a necessary thing to turn your mind to. And to give it some context, we know full well that in other states that have implemented VAD legislation, one of the common refrains of mistakes we made, things we should have thought out beforehand when we were going through the VAD process, was the extent to which they should have had both discussions concurrently about VAD and about palliative care, because Victoria probably has the best evidence of just how slammed they've been in palliative care since the introduction of voluntary assisted dying legislation, but the same could be said across every jurisdiction in the country. And so it is extremely important that as we develop this, we also turn our minds to equitable access to palliative care and appropriate resourcing of those services in a place that has significant capacity deficits and significant healthcare challenges. Recommendation 4 is the recommendation that we have made explicitly and clearly that VAD in the Northern Territory should be provided via a decentralised service delivery model, consistent with the VAD Australian model. Now, what this is about not letting the perfect be the enemy of the good. If we were flush with cash, and if we were flush with population, and if we were flush with healthcare workforce, then I would be the first one to say, in the interests of maintaining complete confidence in the healthcare system for everybody and separation from aged care, palliative care, primary health care, we should have completely standalone division of VAD. Build the building for it. Put the standalone workforce in it. make that the place where all these discussions can be had. But that is just not realistic. And to be clear, that's not specifically or entirely or necessarily what the 2024 report has suggested. They have simply made a clear statement that a centralised model would be the ideal and their preference, without necessarily specifying what components should be centralised and what components should be decentralised. Our thinking, as expressed in the report to some extent, but more obvious through the hours of testimony and witness hearings and lines of questioning we pursued, is that certain core components of VAD must be centralised, like the pharmacy service, like the VAD navigator service. Certain parts must be funded to succeed and maintain suitable separation, even with Chinese walls, as the expression goes, within a law firm, in relation to the review board. But there are other components of the voluntary assisted dying process that should be decentralised. We should be making use of our network of primary healthcare providers, not just in the public system, but in the private system. So that means, for practical purposes, the very many private GPs we have across the Northern Territory have the option to be able to opt in and become accredited providers of VAD services if they so choose to do so. Now, we're not suggesting that there shouldn't be, in the interest of equity, a state-based service provision of VAD. But where that is, how that happens, and exactly how that's most equitably achieved, it's too much straight out of the gate to put that entire burden on the health department. It's important that you are able to, at some point, access VAD services through the state-based health system. But we believe it's equally important and does not compromise unduly the integrity of the VAD system to utilise our existing mechanisms and focus on a decentralised service delivery model. Essentially, we've made decisions not being bean counters, not because we don't care about equity, not because we don't want people who are Indigenous or out in the bush or on a cattle station to be, it's not that we think they shouldn't be able to access VAD, we absolutely do. We just know, statistically speaking, that the majority of our, let's call them 20-odd cases a year, are probably going to be able to avail themselves of systems and services in urban centres initially. And as we have seen elsewhere, these things develop iteratively over time, right? There has been some change in VAD legislation, although I would add to that point, individual states have found it hard once they do something to then reopen the can of worms and then prosecute a better VAD system. What's tended to happen is that one state has gotten this in place, and then the next state has had a better think about it, learnt a few lessons, and improved upon a few things and tweaked things, and so on and so forth. But it's still all within a tolerance of sameness of the Australian model for VAD at this point. And decentralised service delivery is also a part of that. Recommendation 5 is about the purposes of VAD, and they are quite often not articulated expressly, and it's really important that they are, because the purpose of VAD legislation is, in the first instance, to provide a lawful, legal, authorised, safeguarded process for voluntary euthanasia and for good deaths. The recommendation we have is about making sure that people have a legally authorised option to hasten their death, that we establish a lawful process, that we provide legal protections for healthcare practitioners who are in the system, that we ensure that there are safeguards, that we ensure that there is a review board to oversee the process. Madam Speaker, at this point I seek leave to table a paper entitled The Right to Die, Euthanasia and the Law in Australia by Bartels and 𝙏𝙈𝙀𝙎𝙏𝑆,
The question is leave granted, or all of those opinions say aye, to the contrary no? I think the ayes have it.
Thank you, Madam Speaker. I, as many of you know, am partial to quoting the data, the science, the literature, the evidence. There's a mountain of things that I would like to bring to the table today, but that I am not going to introduce into the debate at this stage. But this one piece of literature I think is extremely useful for everyone in the House to have a flick through. And it's because it's not recent. It's because it's from 2010, and it's because from as far back as 2010, it provides a clear expression of the fact that people have been trying to get voluntary assisted dying legislation up and failing. So this predates any of the Australian setups being able to provide voluntary assisted dying legislation. It also documents the Territory's journey and the Commonwealth's intervention to nix that journey to provide voluntary euthanasia. And one of the key points that it makes contained within, which people often who are outside of healthcare practice are shocked by, is the following. That I'm going to read directly from the article here, just briefly. Under the heading, Ineffectiveness of the Criminal Law Prohibition and Risk that the Law is Brought into Disrepute. This is under the section in this paper regarding the euthanasia debate and arguments, if you like, for providing a legislative framework for VAD. I'll simply read two sentences. Quote unquote, another key argument in support of legislation is that the criminal prohibition is ineffective in practice in preventing the occurrence of euthanasia. Over the years, there has been incontrovertible survey evidence that active voluntary euthanasia is being performed in Australia, with approximately 1/3 of the respondent doctors reporting that they had at some stage provided such assistance. There's then a footnote with reference to another 10 pieces of literature, just in the Australian context, about doctors' practices and attitudes regarding voluntary euthanasia from 1998, about the slippery slope argument from 2002, about attitudes and practices of medical practitioners from 1994, about 1/3 of surgeons in New South Wales admitting to being involved in euthanasia practices in 2001, end-of-life decisions in medical practice, a survey of Victorian doctors from 2007, as well as the book from Magnuson, Angels of Death, Exploring the Euthanasia Underground by Melbourne University Press in 2002. Now, this document I table for the benefit of everyone in the House so that we can apprise ourselves of the fact that our legislation, if it is to exist, must exist for a purpose, and that primary purpose is to provide a legally authorised framework for euthanasia, for voluntary assisted dying, for a lawful process, legal protections and safeguards, without which these practices occur and are known to have occurred, and there is empirical evidence to suggest so across all cultures, all peoples, all countries of the world. Recommendation 6, Madam Speaker, of the report is about the principles that underpin voluntary assisted dying. Again, the purpose is one thing, the principles are another. And the principles that are embedded here will not be to everyone's liking. The principles that are embedded here reflect the nomenclature of human rights acts to a large extent. And as all of you in this House will know, the Northern Territory does not have a Human Rights Act. But the principles as reflected in here are done so because they are the same principles that are mirrored in other Australian VAD legislation. I have personally argued that I believe harmonisation and consistency with legislative frameworks where possible around the country is always our best possible position to maintain, wherever that is possible. And this recommendation takes essentially that idea and puts it into practice by saying that every human life is of fundamental importance, that people's autonomy is extremely important, that end-of-life choices should be respected, that people should be provided with high-quality care and treatment, that registered health practitioners should be able to conscientiously object and be shown respect for their culture, their beliefs, their values, their personal characteristics, and within the Northern Territory context, especially that people have the right to cultural safety in relation to VAD. So it is a recommendation that I believe belongs in our legislation, in some form, recognition thereof, irrespective of whether or not we have other protocols governing human rights themselves. Recommendation 7 is really about destigmatisation for some people, which is essentially to say that when people die via a VAD process, that taking that substance doesn't mean they died by suicide, but instead they are taken to have died by the disease or the illness or the medical condition that allowed them to be eligible for VAD in the first instance. And why is that important? It's important not just because of destigmatisation, but because of practical considerations and effects that interact with things like insurance and liability and death certificates, right? So it's important to recognise that when we move into a VAD space, that we provide the protections that are required for people who interact with the system, and this is another one of those. Recommendation 8, Madam Speaker, is about voluntariness and acting without coercion. Voluntariness in this whole process was absolutely paramount to our committee. Absolutely paramount. And if you look at that recommendation, it's 2 parts, which in some ways seem contradictory, but are not, because we understand where the balance of our rights and responsibilities are. We essentially say that people must be acting voluntarily and without coercion, but likewise, that in our context, especially again, a person may voluntarily request family members or other culturally important decision makers to be involved in making VAD decisions in accordance with culturally accepted practices of decision making. Now, those 2 things are not in conflict. Those 2 things are in tension, and that tension is resolved in our drafting instructions at 3.13, where we make it very clear that in the formal request processes for voluntary assisted dying, that it is the decision of the individual person who is accessing voluntary assisted dying, that is paramount. It is that person that must make a choice voluntarily and without coercion, albeit we recognise that they may do so within an ecosystem of friends, family, community, church, culture. All manner of other agents may influence the decision, but the decision remains with the individual in law as prescribed by us in this report. Recommendation 9 will have attracted attention because it is the determination that we have made on the vexed issue of prognosis, right? Now, in Victoria, when this first got up, it was a real challenge and a close-fought thing to get voluntary assisted dying legislation passed at all. And so in many ways, whilst Victoria was first, it is the hardest and most cumbersome jurisdiction to access voluntary assisted dying in. And you can literally Google, VAD, reform, suicides not working, reform required, any combination of those words, and you're going to find a lot of press as recently as a couple of weeks ago suggesting that the Victorian system requires reform to catch up to some other jurisdictions now so that people can actually in practice access VAD without being practically frustrated from being able to access the processes. And there are a couple of critical things that hold things back. And so on this particular first one, it's the issue of prognosis and timeline to death. Now, every Australian state has some combination of essentially saying, in simple terms, you must be dying in 12 months or less. In some places, it's 6 months for certain classes of conditions. But essentially, there is a timeline, a prognosis to death. The ACT, which is the most recent jurisdiction to pass voluntary assisted dying legislation, dispensed with that requirement, dispensed with the 12 or 6 month timeline on prognosis. And after much deliberation, our committee also agreed that we should concur with the ACT position. We did so for a number of reasons, but the first most important one is we spent 4 months looking at this in an extremely congested, manic, high-pressurised inquiry. The ACT had a much, much longer time horizon and did an exhaustive amount of work on the issue of prognosis. And their conclusion was ultimately, in simple terms, that 12 and 6 months were fairly arbitrary and difficult to determine metrics to be able to use in eligibility. So we have not done anything vanguard. We are not ahead of the rest of the country. We are simply keeping pace with the iterative development of voluntary assisted dying legislation across the country, and have decided as a group that people must have an advanced and progressive condition which is expected to cause death, but that there is no requirement to specify whether that death will take place within 6 months or 12 months, irrespective of the condition. It's not a single standalone provision, though. The medical condition must still be causing intolerable and enduring suffering, and it cannot be relieved in a manner that the person feels is acceptable. Again, though, we have allowed for the inclusion of anticipatory suffering, which is one of the Kerle question issues of development in VAD legislation. And so we have noted that we recommend that suffering can also be caused by anticipation or expectation based on medical advice of future treatment or the progression of the medical condition. Now, I'm not going to speak today at any length about slippery slope arguments and the range of other, I think, weak arguments that oppose VAD, because there are actually some very good arguments in opposition to VAD. But the slippery slope arguments on this is the thin end of the wedge, and if we do this, everything will fall apart in our healthcare system, integrity will fall apart, people will be knocking each other off left, right and centre. I simply don't believe that's true, and I don't think anyone in our committee believes that's the case either. And that's because there are very rigorous controls in the Australian model for VAD. Is it more cumbersome than the Rights of the Terminally Ill Act was? Absolutely. But are there better checks and balances to ensure that only people who are eligible can access the mechanisms? Absolutely as well. And so the thin end of the wedge arguments don't really carry water with us, and that is why we think anticipatory suffering is a fair thing to be able to include within advanced and progressive condition and intolerable and enduring suffering. The issue in lay terms here, if you like, for us was, what is the price of entry into the club versus what is the price of drinks once you're inside? We've set this up, if you like, so that Territorians should not be prohibited if they are suffering and terminally ill, in simple terms, from being able to access the beginnings of the VAD process. But then from that process onwards, we maintain a high watermark for ensuring that the people that must make determinations on eligibility, on legal rigour, on witnesses, on documentation, those standards are maintained at a high level, and we have made no compromises in respect of any of that. So in simple terms, there's no cover charge to come in, but drinks are expensive, as opposed to other systems where there's a small cover charge, but drinks are cheaper. As distinct from some versions of this overseas, where basically you can get in for free and drinks are on the house. So we think that basically we've got the right balance to make this pragmatic and equitable. Now, recommendation 10 is the first of the recommendations in relation to eligibility on residency. And again, any histrionics about VAD tourism, I'm here to allay those concerns. Nobody's going to come here first. It's going to take a while for this to get set up. There are other places where this is already working, and there are other places where people will be able to avail themselves of these things sooner. And that is why we've essentially maintained the standard of 2 years residency in Australia and ordinarily 12 months residency in the Northern Territory. Now, what does that mean for somebody who is ill right now and wants to avail VAD services in the foreseeable future? I'm not going to be dishonest about it. The probability is that you will not be able to access a VAD service in practice for, at a minimum, 18 months, and closer to, at best, I would say, as a non-betting man, a couple of years. And why is that? It's because even once we have a bill, even once that bill is passed, which may yet take some months, there is a standardised 18-month implementation window that has been adopted across Australia so that health departments, service providers and the public can all wrap their heads around what needs to be done and how to do it properly. And so I have nothing but sympathy for people who are suffering right now in the Territory and are in an advanced stage with a progressive condition that is going to cause them death. But the reality of it is that it has taken time to get us to this point, and it is worth us getting this right to make sure that if and when VAD legislation comes to this House, it's the right legislation, and that it's suitable for the Territory and for Territorians, and that it means that people will be able to meaningfully, practically and consistently access these services without compromise to the greater community and polity as well. Now, it's important to note Recommendation 10 has a built-in exception, which we recognised as extremely important to make sure that people who have a strong family connection or cultural connection or support linkages for the Territory, i.e. people who might have been here once upon a time but have left, might be able to come back and avail VAD services in this place. Without wanting to be cheeky about it, the straw man that we used for this argument on all occasions was Marshall Perrin himself. We were like, all right, what if Marshall Perrin, who was a Chief Minister here, who was the architect of the initial legislation, who has a long and deep-seated connection to the Northern Territory, but for some years now has resided interstate, what if Marshall Perrin wanted to come back and avail voluntary assisted dying services in the Northern Territory? Would we account for that? Would we allow for that? Well, what we're allowing for is the process for people to be able to apply to the review board at least for exceptions and exemptions. And we think that allows sufficient flexibility to make sure people don't forum shop in our forum, but also that somebody who was connected to a cattle station or lived here once upon a time or wants to be back where their ancestral place is can come back to a place of significance to them for a voluntary assisted death. Recommendation 11 is completely uncontroversial, but I say it because it's unbelievable how many questions I've had when people are like, what will the age limit be on VAD? This isn't something that I think in our exhaustive 30 meetings and deliberations, and traipsing across the Northern Territory, I don't think we spent more than 30 seconds on this because it is a no-brainer for us that only people who are aged 18 or over should be able to access this. Now, that's not to diminish the argument. There are young people who are under 18 who suffer and who do fall into the category of people who may have an advanced or progressive condition, may be intolerably suffering, may also have the reasonable expectation of anticipatory suffering. But the Australian standard at the moment, which we have sought to keep pace with without getting ahead of, does not provision for minors to be able to access voluntary assisted dying in any form, and we maintain consistency with that position. Recommendation 12 is about decision-making capacity, and it goes to the very complex question that comes up time and time again about people who have dementia. Our same line in the sand exists with the issue of people who suffer from dementia as it does with minors. At the moment, no Australian jurisdiction provisions for people who do not have full decision-making capacity to be able to avail themselves of VAD services. Now, we recognise that a person's capacity may fluctuate from time to time, but that is a person with capacity to make decisions in the first instance, who perhaps because of illness is now fading in and out of having full capacity as they progress through the stages of the VAD process. What we have made clear is that all persons must have full decision-making capacity in relation to VAD at all stages of the VAD process. And the stages of the VAD process is something we need to discuss sequentially shortly. But Australia is simply not there yet with allowing people who have dementia and dementia alone to be decided for by other people. That may change in time. I have no personal position about it right now, beyond the fact that as a lover of the law, I believe in the harmonisation and consistency of our legislative frameworks, and this is consistency with the legislative position across the remainder of the country. Recommendation 13, again, makes clear the situation with regards to mental illness. Mental illness is commonplace, mental illness is ubiquitous, mental illness almost inevitably interacts with people who are dying. But mental illness is not in and of itself enough to be the sole basis by which to access VAD. You can have a mental illness and you can have an incurable condition and you can be eligible for VAD, but you cannot, on the basis of mental illness and malaise alone, access voluntary assisted dying. And this is one of those differentiating lines between the Australian VAD model and notably some situations in parts of Europe where people who are suffering have been deemed to be eligible for voluntary assisted dying services even when they don't have a terminal illness. So we maintain the position that people must have an advanced and progressive condition and that mental illness or disability, mental illness is not the sole basis, mental illness and disability, cannot be the sole basis for a decision regarding voluntary assisted dying. Recommendation 14 is where we begin to consider the initiation of conversations by medical practitioners. And this is an extremely important topic where other jurisdictions have essentially tangled themselves in knots by being overly restrictive in not allowing people to have conversations. As far as our committee is concerned, we believe people should be able to access information unrestricted, but that choice should always be protected. So in practice, what we are talking about here is allowing medical practitioners to initiate conversations about VAD, provided that they also canvass all other treatment options and the nature and scope and availability of palliative care services. Likewise, with the next class of people down, other healthcare workers, they may initiate the conversations where they have in fact been prohibited expressly from doing so in a number of other states. We found evidence, in fact, of the same in our own inquiries. Ex-Victorian nurses who were now embedded within our healthcare system, who specifically asked the question, will I be able to talk to people in my facility or under my care about this? I was around when they introduced this in Victoria, and it was a nightmare when we were expressly prohibited from being able to have the conversations and or refer someone and or have the conversation on a specific premise. So we have tried to work through those issues to ensure that there should be no restriction on healthcare workers being able to provide information on a topic. And to that point, we have also defined quite clearly who constitutes a healthcare worker, as well as people who provide health services or personal care services. So registered health practitioners, as well as another person who provides health services or personal and care services. Madam Speaker, the next segment of recommendations pertains to the process of VAD. And the process of VAD will be seen by many to be cumbersome, will be seen by many who are not familiar with the Australian model of VAD to be much, much too complicated and frustrating. But it is the Australian standard now. It is the Australian standard. It is essentially a four-stage process of a first request, a second request, written, formal request for the process, and then administration. It's broken down into much more fine-grained detail and steps than that, and I would encourage everyone to become familiar with the flow diagrams that are embedded within the drafting instructions to understand that better. I'm struggling to find the page now, Madam Speaker, but in any case, people will be able to find those diagrams for themselves in relation to the process that's followed. But recommendation 15 is the first place where we consider that the individual is still paramount, that a first request must be an explicit request for assistance to die, and that that request can only be made to a medical practitioner. So they can make that by themselves and not by somebody on their behalf, and it must be clear and unambiguous. Recommendation 16 is about, the medical practitioner being able to choose to accept or refuse that request. And again, this is where we've embedded that people can conscientiously object because they either conscientiously object to be involved or they're otherwise unwilling. But even when they do, we have made sure that those medical practitioners are still compelled to provide patients with referral information and access to the approved information, the package of materials that would say that I can't help you with this, but here are the materials, here is the number for the VAD Navigator service, here are the people that can help you. So you can't restrict people from being able to access these services, even if you yourself as a medical practitioner choose to not participate in the process. We also make first mention of what are standard timely timeframes for keeping the process moving. In recommendation 16B, we talk about 2 business days, which is to say that, the medical practitioner has to notify the person whether they accept or refuse that first request for VAD within 2 business days. And that is the kind of standard we've tried to maintain throughout the entirety of this suite of recommendations.
Are there any petitions? Member for Araluen.
Thank you. Mr Deputy Speaker, I present a petition from 857 petitioners praying that members of the Legislative Assembly vote against any legislation or motion enabling or advocating for assisted suicide and advocate for better palliative and aged care services in the Northern Territory. The petition bears the clerk's certificate that it conforms with the requirements of standing orders. Mr Deputy Speaker, I move that the petition be read.
The question is that the petition be read. Those of that opinion say aye, to the contrary no. Aye. I think the ayes have it.
Assembly Business Order of the Day number 1, Legal and Constitutional Affairs Committee report on the inquiry into voluntary assisted dying in the Northern Territory. Continuation of the tabling statement.
Member for Fong Lim.
Thank you, Madam Speaker. Continuing from where I finished before lunch, recommendation 17 of the report sets the standard for a doctor who will make an assessment on voluntary assisted dying. And the nomenclature becomes increasingly important for us to recognise in this House as we move forward to explaining to the public how VAD will work in practice. So it's really a 2-stage process, and the first stage is to have what we regard in the Australian VAD model as the coordinating practitioner. So recommendation 17 specifies that that coordinating practitioner must assess whether the person is eligible and meets all of the eligibility criteria. Their recommendation 18 is about the second doctor. And again, this is the clear point about the fact that the VAD process in the Australian model is rigorous and it requires multiple checks and balances in order to make sure that VAD is not used or abused in the wrong way. So recommendation 18 is about the consulting practitioner, again a medical practitioner. And the key thing with the consulting practitioner is, it's confusing, I appreciate, but the consulting practitioner is not a consultant practitioner. There is a difference in nomenclature there. So 2 people who are accredited medical practitioners of equal standing, it doesn't require that the second one is a higher authority or a specialist, a consultant as it were, has to sign off on that process as well to be able to determine whether somebody is eligible to be a candidate for VAD. Now, recommendation 19 is again about making sure that that assessment process involves the discussion of a plan for administrating the VAD substance further down the track. And 20 is about the referrals process and the duties, because it is the case that things happen, things change, doctors who sign into the process may be subbed out of the process, and if and when they are, it becomes necessary to make sure that we don't frustrate the intentions of people who are terminally ill and suffering and are unable to otherwise complete their VAD service. So there is a mechanism within this as well for referrals, as it were, such that a coordinating practitioner or a consulting practitioner are able to refer their work or their role to another person if so required. Now, these are the kind of nooks and crannies of the law that are required that are not fully countenanced by the public when we're just talking about, do you support VAD, yay or nay? Now, it is true that once upon a time, the rights of the terminally ill had essentially set up a standard whereby two separate medical practitioners could make a determination about whether or not somebody would be a fit candidate for voluntary euthanasia. But at that time in that bill, the system was actually more cumbersome in the sense that there was a requirement in the Rights of the Terminally Ill Act for a psychiatrist to have to sign off on whether or not a terminally ill person should be a viable candidate for VAD. Now, even the proponents of the original Rights of the Terminally Ill bill and act would now argue that that was an unnecessary step that we did not need to take. And so, again, it's a clear example of where the world has moved on and the law has moved on and the Australian position has moved on, such that it is now necessary for us to work within the modern paradigm and make sure that we have the checks and balances that are required within the system to provide equitable access to voluntary assisted dying, should we so choose to legislate for it, but also safe access and practical access. Recommendation 21 is about eligible witnesses for the formal request process. So once two doctors have signed off on somebody as being an eligible candidate, there is still a process to have to seek formal request, and that must be approved in an approved form and signed by the patient in the presence of two eligible witnesses. And the person must certify that they're making that request voluntarily and understand the process that they're agreeing to. In 22, the recommendation makes it clear that if somebody cannot sign those documents, then they can do so with someone else's assistance. That person, though, can't be the coordinating or the consulting practitioner or one of the two witnesses. So again, these are the standardised checks and balances now that are embedded into the system. So we have to be able to provision for a mechanism that will allow people to be able to access VAD, but that we know cannot reasonably be expected to be abused. And that is exactly the situation we would face if we were to adopt a more lenient strategy. Recommendation 23 prescribes the eligibility requirements to act as a witness. Again, that somebody must be 18 years old, that they cannot be a beneficiary under the person's will, or one person can be, one person cannot rather, and that likewise the coordinating and consulting practitioners and whoever else should not be permitted to witness the formal request. So clear checks and balances to provide for a safe system for people to be able to be part of or opt out of. On 24, we have provided something novel that is not provided in the rest of Australia. So again, this is a key departure from the standard in the rest of Australia, and that is that we are providing protocols now to be able to do things via video, because we recognise that there are segments of our population that have lower literacy, that have lower capacity to be able to provide written consent. And not only that, we recognise that people who are terminally ill in places that are far-flung and away from urban centres may require assistance to be able to provide robust consent. And so video protocols are now embedded for the first time, which is not something that is provisioned for anywhere else in the country. Now, it may in fact be the case that video consent is a more preferable option to written consent in a number of instances when you think about the Northern Territory context. But notwithstanding, we have provided for, in the recommendations, formalities that we believe should be satisfied, including that any video includes but is not limited to the coordinating practitioner being present in that to witness it, the person clearly identifying themselves and who they are, and the person clearly making declarations to the effect that they are providing their consent. Providing consent is difficult enough when you are very sick and very ill and very remote, let alone if English is also not your first language. And we know that in the Northern Territory, a huge number of people don't speak English as a first language. Some of them are from culturally and linguistically diverse communities. Other people in Indigenous communities may be speaking English as a second, third, fourth, fifth language. And so 25 is where we begin to discuss interpreters that are required to certify materials, and that certification requirements, the interpreter must also be a qualified translator when required. On 26, we haven't adopted an arbitrary timeline, but we've adopted the standardised timeline between phases of requests There is essentially 9 days of what you could otherwise call a cooling off period between making a first request and then making a formal request. So things can't just happen like that on a whim or by accident. And that is a really important cooling off period. And what was brought up regularly and consistently by the committee out in community was, once I've made a decision to start this process, can I back out? Absolutely. At any stage you can back out. At any stage up until administration. You can make a first request, you can have 2 doctors sign off on this, you can arrange for administration, you can have practitioners come to visit you, and you can change your mind on the day. There is nothing to say that people should not have choice in this system. And that's been the guiding principle for our committee on this whole process, that we want to be able to provide for access to VAD, but we want to make sure that anybody, whether they're in an institution or an individual, has the option to be able to withdraw from the process as well, without fear or favour. And that is a really important, unique principle that we are moving further on than the rest of the country, in fairness, including with respect to the notion of cultural safety, which I shall come to later. Recommendation 27 again provides some of the accreditation requirements for interpreters, because one thing that became exceedingly clear while we were out and about is that, just like everything else, we've got a shortage of interpreters. In many places, it is extremely difficult to find interpreters who are conversant with local languages, who are not also family members or connected to people. And so it is extremely difficult to find the right interpreters who are sufficiently and suitably accredited. And that is why, under Recommendation 27D, we have provided for the review board being authorised to be able to overrule the requirements for meeting the minimum requirements when no other suitable interpreter is available. And that's a practical reality. There are going to be instances when you're not going to be able to provide language services, translation services, interpreter services, unless you use people who have some sort of interest in the sick party. And so recognising the pragmatic reality of the paucity of interpreters in the Northern Territory is extremely important. As a tangential matter, it hasn't made it into our report, but we note that standards on accreditation for interpreters and for translators have changed in recent years. And in an effort to raise the bar, we have actually limited the pool in some ways of people available to help out, particularly in the bush, on these issues. Recommendation 28 is again about transfers at the request of the patient, because the coordinating role, practitioner's role also needs to be able to be provisioned to be able to be transferred. 29 is about telehealth, which is something that has gotten, again, really sort of casual consideration without detailed consideration necessarily in a lot of the Northern Territory. Now, if you take the time to go through our many hours of witness testimony, you will find that everywhere we go, we ask questions about, tell us about how telehealth works in your particular place. Is it working? Is it not? And the reality of it is we found that there are significant deficits in the use of telehealth. In some places, the connectivity is just not good enough. In some places, the hardware and infrastructure isn't good enough. In some places, there aren't suitable translators or interpreters, even if you have got working infrastructure. But that's not everywhere. There are a number of places where we learned that telehealth does work exceedingly well. And the medical profession has, by and large, through the Health Department and the AMA, made it clear to us that they would like for telehealth to be provisioned for, to be used in VAD. And in other states and territories across the country, increasingly, there are calls now to allow telehealth to be used as part of the VAD process. However, at the moment, telehealth is not authorised under the Commonwealth Criminal Code 1995 in relation to incitement via a carriage service. So, just the same way you can't use technology to incite someone to suicide through other means, you can't actually use telehealth in this space. Now, it's a grey zone, and the reality of it is that some components of the VAD process are being subtly used in a grey zone in some jurisdictions. Our thinking at this stage is that we have provision for, if and when telehealth is more widely used, we could use it too, but in the first instance that VAD should be an in-person experience, an in-person process as a default position. On recommendation 30 about administration, we make it clear that people must make clear and unambiguous decisions about administration. And on recommendation 31, we recognise something that people really struggle with in relation to whether or not administration must be supervised or not. And the fact is, that's a very difficult question that we spend a lot of time thinking about. And in the Northern Territory context, we came to the consensus position that we want to not frustrate people who may be in remote areas, may be in a cattle station, may be somewhere far-flung, may choose even to have self-administration in an urban setting and not necessarily want a doctor present for the process. And there are additional complexities when somebody is self-administering. You have to think about how they're going to access the substance, how they're going to take it, what will happen after the fact. And that's why there are very clear delineated rules for self-administration versus practitioner administration. And so what we want to do is support people to make choices again. And so a person who makes self-administration decisions may still request to have a healthcare worker present, but that healthcare worker is permitted to assist in the process but not permitted to administer in the process. And that's a clear thing there, because we're trying to offer people the option to have support when they want that support in their final stages. Not everybody has the benefit of being surrounded by friends and family and loved ones, and some people will elect to want to have a healthcare worker present based on testimony that we have from other parts of the country. Recommendation 32 is again about the self-administration situation and notes that you require a contact person. This is the fact that somebody has to accept legal obligations to be able to provide information to the review board about the patient and what's happened. Somebody's going to have to, in the ordinary course of events, potentially collect a substance, return the residual of the substance, notify the relevant authorities. And so we have provided, again, a standardised prompt, 2 working days to provide that information, for the contact person to have to provide that information to try and keep the wheels moving. Recommendation 33 makes clear that that contact person is legally permitted to receive, possess, handle, prepare and supply the VAD substance, but that they also have very explicit obligations to return unused substances, to report the person's death, to provide information to the review board as requested. These are the realities and nooks and crannies of VAD that people need to understand. Recommendation 34 is about the 2 business days again of notifying the review board. And on 35, we consider in detail what a prescription must consider. Because again, pharmacy has been a critical part of this that was almost overlooked in the early stages and became a curly question. And without wanting to derail all of what we're saying, there have been challenging situations in recent times when pharmacy protocols have not been followed perfectly, and it has led to people having to remediate, as it were. Now, for the most part, what we have is a clear situation where VAD has been used safely and effectively across the country utilising the Australian standard. But there are exceptions. And those exceptions are worth knowing about so that we enter this process advisedly and do not make mistakes that other places have made. And for us in the Northern Territory, what does that mean? What that means in practice is that we have probably 2 great hospital pharmacy setups in Darwin and Alice Springs that have sufficient robust controls to be able to house and safely store and dispose of pharmacological substances. And perhaps we don't want dangerous substances in locked boxes in other places that may not be as secure. So we have tried as best as possible to think through these possibilities. Recommendation 36, again, prescribes that we should consider definitions in the context of that space. Who should be an authorised supplier? Who should be an authorised disposer? Written information that should be provided to people to guide them on how to self-administer, to authenticate prescriptions, and, as I say, to return VAD substances along with guidance in that space. Recommendation 37 is about timely reporting to the review board, which is an extremely important part of this process for us. 38 is about practitioner administration decisions, and this is the critical decision again. Some people will elect to self-administer in VAD situations. We know a good number also choose to allow a practitioner to do that. And for that process to happen, you require eligible witnesses to practitioner administration, people who need to witness and certify in the approved form that the person was acting voluntarily, without coercion, and that the administering practitioner administered the VAD substance in the presence of that witness. Certifications also need to be provided to the review board within a couple of days for those processes. On 39, we note again, as with the two doctors making the assessment, the administrating practitioner can transfer their role to another practitioner. We don't want people to be frustrated in the process. We know that we have a paucity of options available for people who may engage in the service, but we need to at least provision for the most practical application of VAD. On recommendation 40, we note that the coordinating and administrating practitioner must notify the review board of the death of the person and that they died as a consequence of the VAD process, again within 2 business days. 41 is self-explanatory in relation to the cause of death certificate. 42 specifies again, consistent with the earlier recommendation on destigmatisation, that the underlying eligible terminal illness, disease or medical condition is what should be nominated as the cause of death. And 43, so as not to, again, unduly burden our coroner, as was the case in some other jurisdictions because of ill-conceived legislation on the front end, that a VAD death is not necessarily a reportable death for the purposes of the Coroner's Act. There is always the provision, of course, for things to be referred to the coroner as and when required, but it is not an ex officio default position. 44 is about the level of experience required by the people involved in this process. Now, nowhere in Australia has trainee medical graduates, involved in the VAD process, but there are other places that have varying degrees of expertise assigned to practitioners, medical practitioners. We have settled on the most common position that is also supported by the 2024 inquiry report, which is that medical practitioners must have at least 5 years of general registration or 1 year of specialist registration, in which case they essentially have the 5 years of general registration as well. Essentially, we're saying that people who are standalone doctors and able to practice without training wheels are allowed to make decisions about VAD. And that means that we can tap into our public and our private system by making sure that we have a decentralised model of VAD service delivery. 45 is about mandatory training. Even if you are a standalone doctor, you still must have completed the authorised prescribed training that the Department of Health CEO will have developed. So there will be mandatory training for people to have completed in order to make sure that VAD is delivered uniformly, equitably and safely. 46 notes that the coordinating and consulting practitioners can't be family members of the person requesting VAD or a beneficiary of the will of the person accessing VAD. Again, critical distinctions that need to be made on the front end. 47 is about providing, notwithstanding, flexibility in administration. Because once the decisions are made, once the difficult decisions have been made by doctors about whether or not somebody is an eligible person, we recognise that it is not necessary for a doctor to necessarily be the person who administers a VAD substance, but rather that an administrating practitioner could be a qualified medical practitioner, a nurse practitioner, or a registered nurse who has practiced in the nursing profession for more than 5 years. We say this because we know that it is nurses, particularly out bush, particularly out in communities, who have the close contact with people in their end-of-life care and potentially in relation to a VAD service. 48 again makes clear that, like with doctors themselves, administrating practitioners must have completed the standard mandatory training to be determined. Now, we have again advised, and we note in our testimony, that we could create economies of scale by working with other jurisdictions to find out what their processes are in relation to training. We don't need to reinvent the wheel on everything to do with VAD. And if we actually want anyone to be able to practically access it any time within the foreseeable future, we will need to be agile in relation to working with other jurisdictions to benefit from their wisdom, their experience, and potentially their training collateral. 49 notes that administrating practitioners, again, cannot be related, cannot be beneficiaries under the will of the person. And 50 notes that relevant persons involved in providing or supporting the provision of healthcare services who conscientiously object can do so. Now, on 51, this is a key NT-based consideration where you think about the people who can conscientiously object from the process. People who conscientiously object from the process are not just limited to a couple of doctors, not just limited to nurses. In the Northern Territory, we have a huge ecosystem of Indigenous healthcare and people who are essentially Aboriginal health workers and liaison officers by a range of different names. And under any of the standard legislation across the country, those people are afforded no specific protections or indemnities. And so we note that relevant persons involved in providing or supporting the provision of health or care services, which is a much broader category, should have the right to refuse to do any of the following: to provide information about VAD, to participate in the processes, to participate in administration, to prescribe or administer substances, to be present at the time of the administration of a substance. I.e., if you are somebody who is uncomfortable as a person who works in the Aboriginal health ecosystem with wanting to participate in this, you can step away from it and you will be entitled to do so on the provisions that we have championed within this document. 52 is about notwithstanding the duty to refer and or inform for conscientious objectors. As we've made clear, you don't have to participate, but you can't actively block somebody who is otherwise terminally ill and requires access to information from getting to that information. So at a minimum, we say that the person must be given information about a healthcare practitioner or service that is likely to be able to assess them, as well as the contact details of the official government state-sanctioned VAD navigator service. 54 is about health or care entities, noting that that covers not just public and private hospitals, not just hospices, but also residential aged care facilities, nursing homes and other facilities. And in the Northern Territory, that's extremely important because if you go out to our places outside of Darwin and Alice, you've got a limited number of providers providing our aged care, our palliative care, our disability care, even primary health care on occasions as well. And some of those organisations are auspiced by entities that do not necessarily want to be involved in VAD. So we have to specify who is who in this very carefully. 55, again, is unique in Australia in that we have suggested in the Northern Territory that we essentially should extend the opportunity for institutional objection and allow it to be permissible, essentially. The committee recommends that health or care entities that object to VAD may refuse to participate in VAD. So for argument's sake, you have an aged care facility that is auspiced by a church out somewhere out bush. If that entity is uncomfortable with VAD being something that they do within their premises, then they are allowed to make that choice. We are not compelling anyone to do anything that they don't want to do. But we make it clear in that process under 56 that that organisation, that facility should make clear to the people residing within that facility, this is not a VAD facility. This is not a place where we participate in VAD-related services. And that is an acceptable compromise in the context of rights for the people on the Legal and Constitutional Affairs Committee. They must advertise their position publicly. They must notify in the health or care entity, notify persons in the health or care entity, including residents and patients who wish to express or access VAD of their position, which we think is a reasonable compromise. 57 is about not blocking people at the door. Now, you wouldn't believe the stories that have come out in other jurisdictions of these things not being thought through, and you having a very sick person inside a facility that doesn't want to do VAD services, and then having VAD proponents, practitioners or advocates knocking on their door, trying to come through the front door, and essentially being blocked. And the scene that that causes and the upset it causes for everyone. So it's extremely important that we make it clear what everyone's rights and responsibilities are in this regard. And in essence, what we have said is that the health or care entity must provide the person with contact details of the navigator service. And the navigator service then can help them. And they must allow reasonable access to the person at the health or care entity by a member or employee of the official navigator service. And in general, not hinder the person's access to information. Information should be accessible to all Territorians. 58 is about not prohibiting or preventing an employer or healthcare worker on-site from initiating conversations. And again, we have gotten testimony throughout our witness transcripts of people who've made clear that previously they were caught in a bind where patients wanted this information and simply couldn't receive it. However, under 59, what is clear is that the relevant steps in the VAD process, the making of a first or formal request for VAD, the undergoing of a first or second assessment, the making of an administration decision, the administration of a substance, those are things that an entity can object from participating in. Recommendation 60 is the requirement to reasonably assist, though, when you've got somebody who is extremely sick, basically can't move around, is in a facility where they want access to VAD, but the facility doesn't provide it. All we have asked for in that instance is for the care entity, the health or care entity, to take reasonable steps to facilitate the transfer of the person to, and if required from, a place where the relevant steps in the VAD process can be carried out. Again, what we want here is to prioritise choice and voluntariness. 61 is where we move to establishing the VAD Review Board in the Northern Territory. And in 62, we make it clear that completed cases must be notified to the VAD Board. 63 is where the powers of the VAD Board are specified. And they are broad powers and important powers, but they must be clearly specified powers at the outset again. To monitor the operation, to review completed cases, to refer instances of non-compliance to potentially the Police Commissioner, the Coroner, the Aboriginal Health Services, any number of parties that are relevant, to collect, record, use and keep data so that we can learn from this process and maintain best practice, to report to the Minister or the CEO of the Department of Health in relation to the operation of the legislation, the board's functions or improvement of the processes, to promote compliance, to set standards and to maintain continuous improvement. 64 notes that, again, there must be information provided at regular intervals to the coroner, including the number of completed cases. We do not want to bury the coroner in each bit of paperwork surrounding VAD processes, but coroners must be informed of the number of complete cases. 65 is about requesting information and the board's power to request information for the purposes of exercising its function from the CEO of the department and from treating practitioners, from contact persons, to maintain integrity in the process. 66 maintains that the board must act independently and in the public interest, and that they are, by default, not subject to direction from anyone, including the Minister, about how they perform their functions. Now, there is a logical tautology, an inconsistency in that, a circular piece of logic in the sense that if you have this embedded within the Health Department, then of course there are lines of reporting and sight that do blur and or become circular. But again, if you refer to the testimony from the 5th of September, you will find that the Health Department, when presented with the option, suggests that it is possible. It would be unusual and not what has been done elsewhere, but it would be possible for us to use our existing health structures, our existing statutory powers under the Office of the Chief Health Officer to be able to administrate a review board with integrity and with separation still from the Minister and from government, as it were. 67 is that the board is to be provided with the resources reasonably necessary to do its job. Set the board up to fail, and you can be sure that governance will fail on VAD, as it has been tested in other places on occasion. 68 is about, on the recommendation of the Chief Health Officer, the membership of the board being assigned by the Minister, which includes people with sufficient experience to do the job, but also sufficient geographic and regional characteristics and spread to be able to reflect the NT community and its diversity. And to that effect, in 59, we have specified a minimum composition for the board, which is to say the Chief Health Officer or another delegated person by the Chief Health Officer, one member who has clinical expertise, including medical or nursing, one member who has legal expertise, but now importantly, one member who is an Aboriginal person in a position to provide and seek advice from First Nations peoples in relation to cultural matters, and one member who is also employed or a representative of an ACHO, an Aboriginal Community Health Organisation. We know that the service provision and model for care in the Northern Territory is shifting and changing away from entirely state-based provision. And so those ACHOs are really important to have some representation in that space. Now, that's not the total composition, that's the minimum composition. And those things may be prescribed and added to in the future by regulations and by the department themselves. 70 is, again, our clear expression of the fact that the Chief Health Officer should be the chairperson of the board. And the reason we made that decision was very, very, very specific, and it's because that Chief Health Officer position already has statutory powers, already uses existing structures, and it is not a huge ask for us to build an adjunct piece of work under the auspices of the Chief Health Officer to manage VAD and the review board, and that is what we think is a pragmatic way forward and a cost-effective way forward and a reasonable way forward in terms of safeguards. 71 provides for a deputy chairperson, and 72 provides that cultural safety must be a consideration in these discussions as well. And I note that the committee had a diversity of opinion on a range of issues, including this, but this is our consolidated position. This is our compromise position on everything. You will note that this is the first report in living memory that hasn't had a flood of dissenting reports surrounding it, and it's because across the political spectrum, The 5 committee members, ably assisted by the committee secretariat, did their best to find common denominator positions in order to progress the agenda of VAD for Territorians. 73 is the nuts and bolts of what happens on that board, the board administration. Inane stuff, but if you don't specify from the outset the term of the board, appointment of the board, vacations of office, conditions of appointments, proceedings, then they're not specified elsewhere. And we recommend those things should be specified in the legislation. 74 is about annual reporting to the Minister and the frequency of doing so. 75 is about how regularly the Minister must table a copy of the annual report to the Legislative Assembly. And that should happen in a timely and prompt manner so that this House is always aware of what is happening in the VAD space as well. 75 makes definitions in relation to 76, the reviewable decisions and eligible persons. 77 specifies that an eligible person can apply to LCAC to seek review of a reviewable decision. Now, that's an extremely important mechanism. We need bodies to be able to have oversight of appeals processes on eligibility and, quite frankly, if and when things go wrong. And so LCAC is the appropriate forum, notwithstanding that anything in the NT legislation affects nothing in the NT legislation rather would affect the inherent jurisdiction of the Supreme Court to hear matters pertaining to VAD. 78 prescribes that the legislation should be reviewed 3 years after its day of commencement and every 5 years thereafter after the first review. And that's consistent with the Australian position again. Again, some people would like there to be just a continuous process of review, but quite frankly, we did not think that that was necessary. We think that we have enough information to set this up sensibly on the front end and for it to be operational within a couple of years, and then for there to be reviews thereafter. The review must consider, though, the principles set out in the legislation, the eligibility criteria, and whether the legislation is operating as intended. We say that because we know that things are likely to change in the VAD space around the country. Other jurisdictions are starting to look at reviewing their legislation, adapting things. It may be the case that by the time we reach a review stage, that we are thinking more broadly about principles, eligibility, operation again, and we may want to refine our processes. So embedding it on the front end is important to say that these are the things you should be looking at when we first do a stock take. There are, I note, a number of reviews happening around the country at the moment in relation to VAD processes, and we've learned quite a lot from them, and submissions have been made by some of those review boards to us as well. 79 is about the creation of new offences. Again, not things that you turn your mind to when you're thinking about do you support VAD, yay or nay. The fact is, when you create a VAD ecosystem, you create a series of opportunities for new offences to be committed. Some of those offences could be extremely serious, some of them could be more minor. Serious offences, though, would include things like the unauthorised administration of a VAD substance, inducing a person to request VAD, inducing a person to self-administer. Those are the horror scenarios that none of us, of course, want to see happen. But you must create serious offences in the legislation to account for those things from the very get-go of VAD. Likewise, to knowingly provide false or misleading information or statements or documents to the review board, those are also offences which must be created. And likewise, we need to create offences for non-compliance relating to procedural requirements by health practitioners or contact persons, for example, failing to return a substance within a timely timeframe. 80 is about liability and exemptions for participation in VAD, and we provide for the fact that a person will not be criminally, civilly or professionally as relevant be liable for assisting somebody with the VAD process, being present or acting in accordance with the legislation. 81 is the same thing but for health practitioners' indemnity, which is slightly different. Health practitioners will not be criminally, civilly or professionally as relevant liable for referring a patient who requests VAD services. 82 is about health practitioners or others, so the wider ecosystem of anything that could be a counsellor, an occupational therapist, a nurse, an Aboriginal healthcare worker, to basically provide them with the capacity to be able to 82, to be clear, is about refraining from administrating life-sustaining treatment. So again, people who would normally be professionally obliged to provide life-sustaining treatment under VAD circumstances, if they believe on reasonable grounds that a person was dying after receiving a VAD substance and that that person does not request life-saving treatment, they would not be liable for not providing that. Think about paramedics, if you like, in that context. 83 is about the fact that notwithstanding all of those indemnities for criminal, civil and professional liability, complaints are still possible. So you can still make a complaint to the relevant oversight body, whether that is the Review Board, the LCAC or the Supreme Court for that matter. And finally, miscellaneous provisions under 84, there are a range of, recognising, for example, that technical errors on a form shouldn't invalidate processes as they have frustrated them elsewhere on occasion, and likewise that the CEO of the Department of Health should be empowered to be able to establish an official VAD navigator service, work out who supplies and disposes of substances, work out what VAD substances themselves are going to be in this jurisdiction, approved information, approved training, approved forms. There is a huge body of work that needs to be done to provide the structure and the framework to be able to provision for VAD. Again, our position is that it would be prudent to work with other jurisdictions to try and license some of their collateral if at all possible. But that will be a question that will be determined under 18 months of implementation, which is the focus of Recommendation 85. It is a standard process across the Parliament at the moment that legislation should be operational for implementation, across the country rather. It's standard across the Australian parliaments that there has been a 18-month implementation period after legislation has been enacted. That is why people ask us, for example, about the ACT, and the ACT numbers are still 0, because the ACT hasn't actually started implementing VAD in practice for patients yet. That will start at the end of this calendar year, at the conclusion of the 18 months of implementation timeframe. And finally, and very importantly still, Recommendation 86, we recommend that the government implement a culturally safe and accessible public information campaign during and after the implementation phase of the VAD campaign. Because one of the most consistent things you'll find in our witness data is people essentially going, quite honestly, I don't really know much about this, can you tell me more? And a lot of our witness testimony is about having an iterative discussion to explain to people what we're there to talk to them about, and them saying, we'd like more information as this develops and changes. So it will be an important job of the Department of Health to be able to maintain communications if they are indeed to oversee a VAD process after the introduction of legislation, which the government has at this stage committed to. Now, the drafting instructions, Appendix 3 of the document, as I pointed out, are the distillation of those 86 recommendations in many ways, and a very clear-cut blueprint. So you can get a digested form of many of these things by simply reading this, but you fail to see the context or the support for the positions. Instead, for the most part, what all of us are working with in and around this agenda and this issue and this parliament is pretty imperfect data. How many people support VAD? Do they support it in my community? What type of VAD are we really talking about? We are fast going to approach the situation now where it'll be incumbent on everyone in this House to seek answers to those questions, to make sure that you are able to say with conviction that I have made a decision on behalf of all of my constituents, or that I have made a decision that is representative of my constituents, or some combination thereof. There are, of course, limits to how much you can test people's opinion, and so running referendums on the drafting instructions is not the suggestion here, so much as to suggest that when there is a bill, that perhaps the bill should be the thing that people are tested on in relation to their yes-no answer. Or before there is a bill, perhaps we may be able to test some of the key propositions, like are people generally supportive of a requirement on prognosis being dispensed with in line with the ACT, as an example. Now, one of the things that I would have liked to have seen in the report, but that is not in the report in any form, is any mention of the limitations of the inquiry and the limitations of the research design. And the great irony of that situation is the fundamental limitation of the research design and the inquiry was time. The absence of time is why we also didn't have the time to talk about limitations and the things that could have been done better. And it is good practice, in my opinion, not just in academic research, but in works like this, to be able to acknowledge that we did not do everything perfectly. We simply could not do everything perfectly. The task that was put before us was significant, and the commitment collectively by the group was to advance the task as best as possible within the time allocated. Notwithstanding, on the 1st of September, the committee did, again, across party lines, all uniformly ask for extra time to present our final report a few months later. But the government asked us to provide it by the end of September, as it had initially intended, and we were able to achieve that. And that is a positive development, I think, and the right decision has potentially been made in that regard. But it has come at a cost, and the cost has been that we have had to compromise on process. We've had to compromise on every part of the process being perfectly executed. The only way that this VAD inquiry was ever going to get done and delivered was for us to multitask things. And so we had to wait until we had a consultation report before we could start thinking about where we would go out and about. We went out and about as best we could, but at the same time we were collecting written submissions, which we weren't able to read before figuring out where to go out and about. Hansard can only work so fast to process crazy numbers of transcripts out in the bush. And so we were waiting on those transcripts of proceedings to figure out what was happening before we could move forward again. Time was the fundamental limitation of the inquiry and the research design. It meant that not all processes were conducted with the rigour that I would have liked them to have been conducted with. Nevertheless, the important point to make here is that in spite of all of the limitations, in spite of a very short time frame, in spite of the pressures of the subject matter and having to do things in a compressed, pressurised environment, we have produced a very substantive, representative data set from across the Northern Territory that adds huge amounts of value. And I don't seek to politicise the issue at all, but I will acknowledge the Chief Minister's remarks in that regard from earlier today, that what we have done is added knowledge to existing knowledge by recognising that, quite frankly, there was never full and complete and comprehensive data collection and consultation done out in remote Indigenous communities, in remote areas. Could we have done more? Absolutely. Would we have liked to do more? Absolutely. Would we like to do more in the future? Potentially. All of this is true. But notwithstanding those limitations, we were still able to get out to a very large number of places and speak to a very large number of people and receive a very, very large number of written submissions. Now, Madam Speaker, I brought along all 400 submissions with a view to talking about some of them, but in the interest of being sporting, I won't. I will note that the written submissions make for fine reading, and the important thing to recognise in the written submissions is this. Some are hundreds of pages long, and some are literally 2 lines long, but every one of them mattered to myself and to my colleagues who sat on this committee. And why I think people should go back to looking at them is because they explain reasonable objections and unreasonable objections, reasonable opinions and unreasonable opinions. There are some people who simply want to say point blank, I don't want it, that's it, that's all I have to say. Fine, there are other people saying, this is great, you should have already done it. Not super helpful, but adds to our body of knowledge, right? And all of those people deserve to be heard, but what we haven't been able to do, again, because of the limitations of time, is provide, for example, qualitative and quantitative metrics, pointing out how many of these things did we get to somehow squish into the final report? How many people actually got heard fully? I don't know if I'm draining power from the building at this point or what's happening, but Madam Speaker, is there any...
Everyone out.
Can I just proceed, or is that a sign from God? No. I'm just going... Okay, great, thank you. The written submissions are worth reading and not as daunting as they look. And there are some very complex, large, dense submissions. For example, submission 6 from Professor White before we appointed him as an expert advisor for ourselves is a long list of academic literature, which is extremely potent academic literature in and around this area. And there's hundreds of pages of that submission. Meanwhile, as I say, other things are one-liners, you know, yes, no answers. But it all matters, and I assure you, Territorians, if you don't see your name in a footnote in the report, it doesn't mean we ignored your submission. It doesn't mean that we don't think what you had to say is valuable. We read all of it. We read all of it, and everybody worked extremely hard to process it all as fast as we could to produce the best work we could within the limitations of time. What you will need now to progress the issue, Madam Speaker, I say to members of the chamber, is essentially survey data of your own. Everybody will have to go out there and test in some defensible, empirically justifiable, quantifiable way what support for VAD is in your community. Because I assure you, if people come out saying they are either for or against this proposition on the basis of whose door they last knocked on and not much else, somebody else is going to skewer you and be very unhappy. And this is really an issue of life and death, and it is actually worth everybody making an effort through whatever means you best can to survey your electorate. That may be through your newsletter, that may be through a phone canvass, it could be a digital survey line, it could be any number of things. But I encourage you all to start that process now, because existing sets of information that we have are extremely imperfect. None of them clearly spell out 99% of people are in charge of VAD, right? All we have is a set of polarised opinions, but we don't have good, robust data to really indicate what the level of support for VAD is across the Northern Territory in all places. And to that point, one of the fundamental things that I take objection to is the idea that all Indigenous people are the same, think the same, believe the same things. It's simply not true. And presented with the opportunity to express themselves, Indigenous people from across the Northern Territory, across the width and breadth of the Territory, as best as we were able to cover it, expressed a vast diversity of opinions. Many people are opposed to VAD and don't find it to be something that they culturally want to participate in. But there are others for whom, the majority I would say in our data set, there is very much a laissez-faire attitude of, maybe not for me, but I don't mind if other people have it, right? And then there is other testimony from people who are Indigenous, who are from out bush, who are from remote communities, who are not only for it, but even have had interactions with voluntary euthanasia in the past. Now that is extremely important testimony, extremely important findings, extremely important data that has not seen the light of day before and helps us understand that once again, we're all fundamentally human. Nobody wants to die a painful death. Everybody wants to be able to have a good finishing up, whatever that might look like. So what we've managed to produce is a substantive, representative data set that adds considerable value to our understanding of euthanasia, voluntary assisted dying, and the rich and nuanced data from witnesses is something that everybody should engage with to some extent to understand exactly what we have found out bush. Tell us the stories of what we've found out bush. Well, again, I'm not going to be forensic about it, but I am going to point out some broad overarching highlights of what we learned in the places we've been to, because this is the rich qualitative data that is new, that really teaches us what it is might be suitable for the Northern Territory. Broadly speaking, we endeavoured from the outset to the committee, that is, to be essentially on the road for a month, and that's a significant undertaking commitment. All of the other committee members have families and obligations. I just have a garden that I'm killing. I had the least obligations, but everybody else gave up precious time from their children, their partners, their families, to be out and about and engage all over the Territory, and occasionally at risk of life and limb. I won't tell the tale, but you know, at least one of our planes, light aircraft, had to make an emergency landing in Tyndall. We were able to cover some, but not all of the Territory, but enough of it for this to be a representative data set. And in essence, whilst we definitely got off the beaten track, we still essentially focused our efforts in and around 4 primary locations, if you like. The first of those 4 primary locations is Darwin itself. And in Darwin, we were able to conduct testimony and hearings with public officials under perfect conditions, which is why we're able to get perfectly time-sensitive Hansard, ask deeper, more meaningful questions, have everything out into the public domain as quickly as possible. And to the very many people who have been reaching out behind the scenes, wanting the information, that is why that information was out first, for practical reasons, not for any nefarious purpose, to hide any other information. Thereafter, again, consultations we did in Darwin involved Aboriginal communities coming to us. So we started our process on day one by reaching out to the chairs of the former independent expert inquiry, but also to the heads of all the land councils, also to the head of AMSANT, because we knew that going out bush and consulting with people in remote and regional areas meant having the cooperation of people out there. And so we extended the olive branch. Now, for the most part, people didn't immediately leap at the opportunity to cooperate with our inquiry. But with time, as word got around, that we were giving this a fair go across party lines to try and gather real information with, a Green, a member of the Labor Party and 3 members of the CLP. We got people coming to us. Representatives from Tarantipi Homelands, Warraminga, Tiwi Mob, they made time to talk to us en masse from the Tiwis. Manangrida actually sent an entire delegation of people to us in the Parliament. We couldn't make it out to them, and they decided this was sufficiently important for them to make it to us. So any suggestion that these consultations were, not credible, I reject. These consultations were imperfect. These consultations were bush consultations. These consultations involved, trying to use, technical equipment in odd circumstances and odd places, sometimes things not going exactly as they would as if we were collecting testimony in the parliamentary committee rooms and chambers upstairs in Parliament House, but they were credible consultations and they were geographically dispersed across the territory and representative of the views of Territorians generally, not just Indigenous Territorians. Then there's sort of a second suite, if you like, of consultations that we did where we learnt a ton of things, which I consider the sort of community hearing consultations. Nuka, Borroloola, Barunga, Goombalunya, Papanya, Numbawa. Each one of those places is a separate consultation, each one of those involving day-long processes, each one of those involving multiple stakeholders. And we are indebted to the people in and around the Roper Gulf region, and in fact to the cooperation again that we received from the Leader of the Opposition in helping us to facilitate some of that. We are grateful for the bipartisan work we've done in this space, and we are grateful for the fact that we've been able to produce a report without any dissenting reports, and there is a reason for that. And it's because we tried very hard, under very challenging circumstances, to come up with a common denominator position. Not a lowest common denominator position, but a common denominator position. A third sweep of consultations, Madam Speaker, and an important one, is based around Alice Springs. Alice Springs is not Darwin, the centre is not the north, and all of what happens in the centre cannot be collapsed into the same basket. And we knew that from the outset. And that is why we spent considerable time talking to people in Aboriginal engagement, at the hospital, in palliative care, as well as to key protagonists in this situation, like the Australian Christian Lobby. We didn't shy away from having the conversations. The Old Timers Centre, the Baptist Church. We gained really, really valuable data in that sweep of things in and around Alice Springs. And then the final sweep of consultations, if you like, geographically, is focused in and around the Barkly, which I'm sure the member for Barkly will be delighted to hear. Tennant Creek, Barkly, Puka Puka, Disability Services, the Tennant Creek Mob, the Cattlemen's Association, Tennant Creek Hospital. I sadly wasn't able to participate in the last day of consultations because I myself ended up in the Tennant Creek Hospital after getting food poisoning at short notice. But I can vouch for the fact that it is a fine facility and we collected data in every conceivable way, including in person, as it were. Now, what is it that we learnt out there? Well, as I said, I really would love to quote aspects, forensically point things out. You could write an entire PhD thesis on the data that we collected, supplementary to the report that's been presented, to explain the rich and nuanced findings of the bush in relation to voluntary assisted dying. But I'm just going to provide some signposts for other people who may wish to explore further going into the future. On the 5th of August, we had an initial hearing, a public hearing, with the AMA, AMSANT, NT Health, which really set up the foundations for our inquiry. What were the plans from our health providers for VAD? Did they have a plan? Could they implement this? What was it really going to take? And what we discovered very quickly was not that they had no idea, but that we were in a chicken and egg situation here, them saying, you tell us what the law is and we'll tell you if we can do it. And us saying, you tell us what you can do and we'll try and make a law that actually works with that. And so it's been an iterative process for us to establish the right set of recommendations and tools to be able to potentially provide a framework for VAD moving forward in the Northern Territory. The testimony from that day is really important, as are the written consultations that come, the written submissions that follow it from the same providers. But equally important for us on that first day, and deliberately chosen, was public testimony from private citizens. And one of those private citizens we spoke to was Miss Judy Dent. And as most people who are involved with voluntary assisted dying will know, in the Northern Territory, Judy Dent's husband was the first person to avail himself of an assisted death as a terminally ill person under the Rights of the Terminally Ill Act back in 1995. And so it was important for us to hear from Ms Dent, it was humbling for us to hear from Ms Dent, and it was necessary for us to hear from Ms Dent to remind ourselves that this is not just a technocratic puzzle, much as I might be making it seem so through my remarks to some extent, but this is about human beings and people and a good life and a good death. Humanity, compassion, the greater good, understanding that people have different perspectives and that they are entitled to have those perspectives. So the 5th of August was an important day in terms of establishing our setup. And then, as I say, in Darwin, we had 2 other extremely insightful sessions, one of which was with the Tarrantippi Homelands Aboriginal Corporation, with a number of significant and senior people on a call with us from the Tiwis, speaking to us essentially in detail about dying on country. If you want to know about what people have to say in that space about dying on country, there is a ton to be learned from that consultation. The Manuel delegation that flew in to meet with us gave us some of the best testimony we had about the positives of telehealth. We had heard in a number of places that telehealth, frankly, didn't work very well, couldn't be used effectively in criminal justice proceedings, and that shouldn't be used in medical proceedings at all. But we learnt that in Manuel, albeit a large and well-resourced community, telehealth does work really well in many regards. And that gave us hope for the fact that telehealth could be part of this equation still, and we shouldn't just write it off completely. So the positives on telehealth and service provision were things that we learnt about through the Manuel process. At the very, very end, we wrapped up our consultations in Darwin on the 5th of September again, on short notice, by asking the AMA and the Department of Health to come and speak to us again about how to meaningfully deliver VAD. And I can't thank those witnesses enough again for their generosity and their honesty in being frank with us about the actual nuts and bolts of VAD and what was going to take to make it work in this place. And so I don't want to quote extensively from this, but it's a question that comes up all the time. So from page 20 of that testimony, I'm quoting from my own words here. I need to, for the sake of the record, just get this here. Notwithstanding that service delivery models will evolve, as you indicate in your written submission, as we have discussed today, what we are looking at, if we have a core centralised service in terms of practical impost, in terms of time and resources, is something in the order of an increase of palliative care that the AMA today suggested would be 30%, palliative care, potential cost impost extra that we require, plus potentially extra help in aged care, which we have not discussed in great detail, noting that we have seen significant deficits in aged care facilities elsewhere, plus the potential for buildings, physical location to be able to provide VAD services standalone, albeit not building a new hospital, plus at least some FTE being a number between conversations we have had now 4 and let us call it 10 people, but less than 10. Is it fair to say that those are the costs and resource imposts that we are looking at to introduce a VAD service in the Northern Territory in the future, notwithstanding that service delivery models may vary? Dr. Burgess, Chief Health Officer, I think that is not unreasonable. I think the missing component we have not really touched on in that list is the review board. Mr. Chair, yes, sorry, I forgot that one. It's on my list too. It's on my list. Dr. Burgess, and the pharmacy service, which might be part of your FTE. The pharmacy service would be logically centralised within our hospital network. I'll stop quoting from there. The point is that the Health Department have been clear that they would like to help provide VAD, but that they cannot do it without additional resources, and that they cannot do it by simply manipulating existing budgets. So if we are going to provide a VAD service, we cannot provide a Rolls-Royce for 20 people a year. It's just not realistic. It's not reasonable. We all know in this place that we have competing considerations when it comes to healthcare. We on the committee believe in equitable access to VAD, and we definitely are proposing that there should be legislation in the VAD space. But that's why it's so important that this is done right, as the Chief Minister pointed out today. We really are past the point where we can just introduce any sort of legislation into the VAD equation and say, we'll just use this one and then figure out the rest later. That's not going to work or end well for anyone, is the honest truth. And now, with the benefit of a report that has multi-party support, I'm hopeful that my colleagues will concur with me that we should work together, but that we should work from the starting position of utilising this report, this set of drafting instructions, this set of recommendations, so that we get the right results for Territorians as soon as meaningfully possible. Now, moving on to the body of stuff that we learnt out in those sort of bush consultations, if you like, Ngqura was the first place we went, and it is a little bit scrappy, is the truth, because we are refining our technique and our consultative process. We're trying to conduct a town hall meeting with a church room full of people. Microphones are going everywhere. We're getting personalised stories, but we still learnt so much that day. And it was an excellent place for us to start our process. The Borroloola Local Authority on the 7th of August is where we first started getting really clear expressions of how angry a lot of older Territorians are about the fact that the rights of the terminally ill was taken away. And we hear loud and clear, it should never have gone, why can't you just bring it back, do something about it? And the Borroloola Local Authority were very generous in squeezing us into their timetable, their timeline for consultations, meetings within their council chambers that day. In Barunga, we had multiple stories across multiple consultations, local stories from traditional owners and senior elders about local clinics and service provision. The Barunga consultations are some of the best ones for us talking to everyday people, not through the filter of other voices, not through representatives of someone, but actually talking to people on the ground who live in the community, have an opinion and wanted to express it when provided the opportunity. Gunbalunya is an extremely important set of data that people should look at, where we met on the school premises and with the principal and staff discussed really in detail some of the very curly questions about VAD. It's where we have some of the most clear-cut evidence of lived experience of Indigenous people, of interaction with end-of-life care and with euthanasia itself. Not in some salacious way, not in some criminally prosecutable way, but in a way that acknowledges our shared humanity and the fact that nobody wants to die a painful death, and everybody recognises that at the end of your life, we are all fragile creatures in need of help. Our consultations in Papunya were the largest facilitated discussion we had, facilitated by none other than Alison Anderson, a former member of this House, who was extremely gracious in running a mass community consultation, which started off with, I think, for want of a better word, outright hostility, and ended with us all learning a lot from one another. Great example of two-way learning, of us having a conversation, translating out to people, and learning about the importance of a communication strategy for VAD going forward. People who didn't have a clear idea of what we're doing, and once they did have a clear idea of what we're doing, had a different perspective on what their take on it was. To be clear, there was overarching opposition to the idea of people in that Papunya community being involved with voluntary assisted dying in its ordinary form. But there was not blanket objection. And there were important discussions that were had about palliation, about palliative sedation, about people's interaction with healthcare out there through somebody who is as fierce and knowledgeable an advocate as Alison Anderson. So at Papunya we learnt a ton again. Numbulwar is one of the few places that I'm not in a position to be able to provide personal testimony because I myself was absent that day, and I'm extremely grateful again to the member for Casuarina, Mr Kota Patel, who on 13 minutes notice availed himself to get on a light aircraft to ensure that the committee had quorum to go and take testimony. And so that's another situation of a place where we've had to be agile, where we've had an imperfect set of circumstances, but under the auspices and careful management of the Deputy Chair and the member for Wanguri, we were able to collect valuable testimony that day in yet another setting. Alice Springs, as I mentioned previously, was one of the most important places we collected data on a number of fronts. We met with the Aboriginal Engagement and Strategy Unit at the Aboriginal Hospital and really learnt about the necessity to provision for conscientious objection, not just for doctors, not just for nurses, but for what you might call healthcare adjunct workers. We had testimony from people who are essentially interpreters, liaison officers, people who engage with Indigenous healthcare through the hospital, who made it super clear to us, I really don't want to have to be, as part of my job, translating information on VAD. I really don't want to have these conversations and present this information. If this becomes a necessary job requirement for me, that is going to put me in an impossible position. And we really understood that first, best and most clearly in the Alice Springs Hospital, talking to the Engagement and Strategy Unit. We then went on to speak to the palliative care team at the Alice Springs Hospital, and the Alice Springs Hospital, under the auspices, or including the involvement of Dr. Christine Anderson, who's a specialist doctor in palliative care there, the Alice Springs Hospital had already provided us a very detailed submission, which was really important in the written submission pack to look at. And we discussed that further in person, and it gave it more light. And one of the key things that we were able to take away from there was the importance of where VAD happens matters. Now, the Alice Springs Hospital and its staff and its palliative care team made clear how hard they'd work to make sure that there is trust in that hospital, that people in the wider Alice Springs catchment area treat that hospital as a place of healing, not a place to come and die. And we want to make sure that that is maintained. And so for the people that were purveyors of healthcare in Alice Springs, including the palliative care team, it was so important for them that if and when there is VAD services, that they don't take place or don't have to only take place within a hospital setting. Now, we wrestled with the idea of whether or not to suggest that they should never take place within a hospital setting. But again, the wisdom of our healthcare department through the testimony provided in public hearings was that don't stop us from being able to do that, but it's important that we have other spaces. In the perfect world, people are able to have VAD services in the comfort of their own home, surrounded by their loved ones, or perhaps back in their communities, surrounded by their family and loved ones, back in country on place. But there are going to be instances where people are too sick to leave hospital and it needs to be done in a hospital. There are going to be instances where we need safe third-party places. And we can't build entire new VAD facilities, but we must provide for neutral spaces for people to be able to access that level of service. And it's a shame and a deficiency of our inquiry again that we were not able to get out to Nhulunbuy and Gove, where we know that there is a very good setup of palliative care existing next to a hospital with access for family and community to be proximate. And we know that that may be a model that the health department, the government may want to look into the future in terms of a best practice model for providing palliative care and aged care in remote and Indigenous settings. Returning to the Alice Springs Hospital palliative care team though, not only did we learn about the where, but we learnt there about the importance of cultural safety, about group decision-making in practice from the perspective of the practitioners, not just the perspective of people in community. We learnt about palliative care in practice, you know, what people really can do and can't do, what the limitations are. We learnt another really critical thing in relation to workforce, which is that PCAs, patient care assistants, which are much maligned in our system. A lot of the time people just think that they're not quite proper nurses who just go and get tea and biscuits. Well, they're a whole lot more than that. And in relation to end-of-life care, palliative care and healthcare, they're super important. And we explored the fact that more patient care assistants would be extremely valuable for our healthcare system. Now, why is that important? Because frankly, they're easier to get, cheaper, and not entirely ubiquitous, but they are not a precious commodity in quite the same way as a nurse practitioner is. So if patient care assistants can be part of helping us work on problems within our healthcare system, then that's a really important finding as well. And one of the other things that we learnt about was it's one thing to have people out bush say, nah, I don't want any of that treatment. It's another thing to have palliative care teams talk to you properly about people's pain tolerances and thresholds. And you know what? A lot of people out bush are seriously hard as nails. And they do say, no, I don't want anything. I will die a natural death. I believe I should die, whether it's because of cultural reasons or religious reasons. Suffering is a part of the human condition. And that's a really important thing to hear from a palliative care team. We then went to the Alice Springs Baptist Church, and I would encourage you all to have a look at that testimony because it's one of the, it was such a good example of legitimate, reasonable, measured objections on religious grounds to VAD. We had the benefit of hearing from the pastor there who made it extremely clear to him that he believed life was sacrosanct and that VAD was not something he would ordinarily endorse for. But when we pushed him on the point, when we asked for him to provide specificity, and I'm going to quote from page 6 of that testimony on Thursday, the 21st of August in Alice Springs at the Baptist Church, Mr. Brown, quote unquote, as a pastor, my responsibility is to meet people where they are at. So if somebody chose that path, i.e. the path of VAD, I would not necessarily endorse it, but at the same time, I would be there with them 100% of the way and help them to discover that God is present within it. I do not think that the church would simply remove, or I hope not, themselves from that space just because it makes them uncomfortable. The church has a responsibility to meet people where they are at from my perspective. There are balanced and nuanced and reasonable objections to VAD from people on a range of grounds, and you will find them if you look at the testimony, and you will find them if you go through the witness transcripts. In that same vein, we met in Alice Springs with a representative of the Australian Christian Lobby. Now, the Australian Christian Lobby is in many regards often maligned and perhaps unfairly so on occasion. And I think this testimony again is worth looking at in that regard because what it offers is clear-cut opposition to VAD, no doubt about that, but it offers a considered, reasonable set of conscientious objections on faith-based grounds. In the competing rights and priorities of the healthcare system, the witness on that occasion makes clear that his priority would be for us to do much more in palliative care rather than to put our efforts into VAD. Now, we as a committee, as I say, believe that more should be done in palliative care, but also that people should have equitable access to VAD. But I think it's important to understand that we haven't just put together a rubber stamp, glossy report without really hearing what Territorians have to say on this issue. And that doesn't mean we've agreed with everything that they've had to say, but we have tried to weigh all of the data and make careful, considered decisions about what might be a reasonable, practicable way forward. The Old Timers Aged Care Centre in Alice Springs, again, was a really good example of two-way learning, where we were asked a very basic question by someone in the audience about, so what percentage of people support VAD? To which we were all slightly flummoxed because we were like, actually, we don't really know the answer to that question. We're not here to run a referendum, and it's important that we collectively all start figuring out the answer to that question. The other interesting thing there was, again, to have somebody actually say, why do we have to call it VAD? What is VAD? I don't even know what VAD is. V.A.D. sounds so insensitive. Why can't you properly call it voluntary assisted dying, given the seriousness of it? And that's one of those things that fed into us trying to understand, you know, why the rights of the terminally ill might be the right nomenclature to use in this regard. And I don't want to take away from the importance and significance and weight and gravity of this discussion, but I will point out that VAD, V.A.D., voluntary assisted dying, was still so confusing that we genuinely have on record testimony from an elderly gentleman who turned up thinking that the consultation was about dying wool, not about dying people. He genuinely turned up to tell us, I didn't realise, I thought this session was about wool dyeing. I actually just want to live for as long as possible. Thanks very much, see you later. So nomenclature, words actually matter. I mean, I'm being pithy with the observation, but in all seriousness, words matter. How we describe things matters. Definitions matter. One of the important things, two of the other important things that we learned from that session were, that was a session where we had ex-Victorian nurses in that facility who basically straight away asked us all the hard questions on, I was there when this happened in Victoria. I remember being gagged. I remember all the angst surrounding whether I was allowed to speak or not allowed to speak, or could refer anything to anyone, or family members saying you're not allowed to have that conversation with my elderly father or mother. Those are the questions that need to be resolved from the front end. And so initiating the conversations is something that we, in our report, have strongly lent in favour of. Our report is not a libertarian report, but we have fundamentally tried to prioritise transparency and openness, and to allow as much of the information that we've collected to see the light of day. And to that point, we want for healthcare practitioners and medical practitioners and people adjunct to the healthcare process to not be inhibited from having conversations, even if that conversation is one that says, this isn't for me, I don't want to be involved, but the minimum expectation is, here is the number of the VAD Navigator service. Here is a connection to somebody who you can talk to. Return to country programs were also something that were discussed in that space. And again, they're really important to understand that there are already, under the auspices of community health organisations, programs in place to help people who are elderly, infirm, and often terminally ill or in the last stages return to country in some form. Not necessarily to provision them to pass on country, but at least to connect to country. So there are some existing mechanisms there for us to work in parallel with so that we don't reinvent the wheel. We simply don't have the money to, quadruple what we do in patient travel assistance or in care flight or whatever it might be. So we have to be agile about thinking how we can provide equitable access. And again, something like a return to country scheme already exists for us to be part of. The final of the 4 major sweeps of areas that we covered, as I said, was the Barkly, Tennant Creek region. And in those places, we learned extensively about the aged care sector, about the significance of moving to ARCHOs, even things like self-care dialysis and the viability of it, and about pharmacy control of VAD substances. That's a clear place where somebody who is involved in pharmacy services has said, we really do not think it's a good idea to have these substances in our community for any longer than necessary. And so it's important for people to understand that even a decentralised VAD service would require centralised pharmacy services to ensure the safe supply, storage, use and disposal of pharmacological substances. So beyond the Barkly Regional Council and meeting with the folks there, we again got to have a look at yet another aged care facility in 𝙏𝙏𝙎𝙏. And that was a great opportunity to talk with a gaggle of nurses and hear their real stories about their concerns about having indemnity from liability if they were to be involved in things, protection for carers, palliative care services as they're provided, and again, visits to country. They were able to provide us with stories of agility in helping people out. In Tennant Creek, in community consultation drop-in sessions that again we were able to arrange, we learnt about disability, dementia and terminal illness from people in disability advocacy. And that was really important to understand as well, because we weren't able to cover, as I said, every aspect and nook and cranny of respondent that we might have liked to cover. But we have a good representative data set and sample, and it is not to be underestimated. It is a lot to suggest that in 300 pages of reporting and with an appendix and drafting instructions, one should still refer back to the source materials. But the fact is, the real meat and potatoes is in these source materials, in these witness transcripts out bush, in these written submissions, 400 plus of them provided by Territorians from all over. We had further consultations on the back end in Tennant Creek as well, with the Cattlemen's Association, with individual people, with the Tennant Creek mob. Some of those transcripts are still not publicly available. And again, I say on the record that that is unfortunate and imperfect, but the necessary, the result of the fact that we have done this under compressed circumstances and timelines. And so I commend again the people who have helped us to output this work, being not just the committee secretariat, but for example, Parliamentary Hansard, who have had to work around the clock to essentially churn out all of these transcripts for us over and over again, for us to try and read, process and publish safely as expeditiously as possible to ensure that today people will have the opportunity to discuss not just the report and the finished product, but to discuss the raw ingredients that inform that finished product and to learn from that, to cite from that, to quote from that. So nothing has been hidden at any stage. Everything has been as transparent as we could reasonably make it. And our priority has been, as I say, to progress the agenda of VAD. Now, this would not have been possible at all without the committee secretariat, and I thank them all for their enormous efforts in trying to meet our timeline. But I also want to thank individually and specifically the 5 committee members, all of whom put in a significant amount of work to making this happen. I am grateful to the Deputy Leader of the Opposition for helping to provision access for us in many Indigenous spaces and for being a willing participant in the conversations and for also the robust discussions that we were able to keep within the confines of meeting spaces. In a similar vein, I am grateful to the member for Nightcliff, whose worldview and mine don't align in many regards, but who was very diligent in trying to prosecute her case and to have a contest of ideas and to maintain, to hold her ground, but also to cooperate with us as a multi-party committee to produce a unanimous report. Above all, though, I really do owe a debt of gratitude to my 2 government colleagues on the committee, the member for Wanguri and the member for Blain. And I single them out not least because they were there for all of it, the hundreds of hours of all of it. Even I must confess, as the chair of the committee, that I missed 2 of the sessions for illness. They were there for all of it. They were there for every meeting. They were there for every consultation. They were there for every hour of every minute of all of the hearings. And they took the time, as with the others, to get across all the materials as best they could, and certainly demonstrated, as is evident through our minutes and through our inquiry testimony and witness transcripts, they were prosecuting the agendas, asking the hard questions, and trying to really dig deep and get answers. So I'm enormously grateful to both of them for their time in that regard, and also separately to the member for Blain as the deputy chair of the committee for deputising for me on those occasions when I was unavailable, because it's not easy to get thrown in the deep end on something like this when you're suddenly the one tasked with trying to build a bridge in a foreign place on a very complicated topic that nobody actually wants to talk about. So I thank again the member for Blain for his sincere effort in that regard. Most especially, though, I want to reserve my real thanks, my final thanks, to those who have generously shared their time and shared their stories with us from across the territory. It is not an easy thing to talk about the death of a loved one at any time, even when it's a historical issue. It is not an easy matter to discuss, the harsh realities of palliative care and end of life. And people did not have to speak with us. There was a better than even chance that we were going to arrive at a lot of destinations with limited notice and suddenly find ourselves eating sandwiches sitting on the red dirt with no one to talk to. And that never happened. And that never happened, not once. Everywhere we went, people came to talk to us. The Secretariat were extremely diligent in setting up people for us to get started with. And then by a combination of luck, design, cooperation, collegiality, commitment to the cause, word got out that, we were available to have a yarn with people if people were interested in having a yarn with us. And we did manage to capture a significant amount of testimony, huge amounts of testimony, quite frankly, in the time that we had available to us. No research process, no consultation, no inquiry is ever perfect. And I freely admit on behalf of the committee, for the sake of the committee, taking ownership of the issue, that this inquiry was replete with imperfections. But for all its imperfections, we have produced a report that is of high quality. We have a large catalogue of evidence now, which people will, at their time and discretion, have the opportunity to be able to interrogate, to understand the totality of what we have learnt on VAD. And I believe that we have satisfied the core goal that was always at the forefront of my mind, which was not to decide on VAD, but to provide progress on the issue of voluntary assisted dying for Territorians. Now, I have, as everyone is aware, erred on the side today of completeness to cover the field. I have done so advisedly, but I'm grateful for the indulgence of my government and my government colleagues, and likewise to the opposition leader, the deputy opposition leader, and members of the crossbench who have been willing today to afford myself as the chair of this committee to make a substantive tabling statement. I have done so because I believe that this is an important issue that Territorians have been waiting 30 years for real progress on. And finally, together, collectively, we have the opportunity to present that we as a parliament can move forward on this issue for the benefit of all Territorians. As chair, I simply want to say again, thank you to all of the people who have participated in the inquiry in any form. I'm extraordinarily grateful to my committee members and likewise to the Secretariat, the Hansard, the parliamentary staff, all of whom have been instrumental in making it possible for us to achieve a result. My final plea in my capacity as the chair of the Legal and Constitutional Affairs Committee, and my duty, as I see it, is to ask the House in earnest and to implore the government of the day, and for that matter the opposition, to work collectively now to ensure that the bill that we hope will come to this House in due course will reflect this final report and will reflect these drafting instructions with consideration for the recommendations of the report more generally. Mr. Speaker, on that note, I move that the report be noted.
Thank you, Member for Fong Lim. Are there any other speakers? Member for Nightcliff.
Thank you, Mr. Deputy Speaker. Mr. Deputy Speaker, I rise to speak on the inquiry into voluntary assisted dying, of which I took part as a member of the Legal and Constitutional Affairs Committee. I'd like to start by thanking every person and organisation that contributed to this inquiry through submissions and by attending hearings. The submissions we received and the verbal testimony we heard, regardless of their stance on voluntary assisted dying, were heartfelt, passionate and considered. The contributions were informed by people's personal experiences, their expertise, their spirituality, their culture and their personal philosophies. It is so vital for the varied experiences and opinions of members of the public on weighty topics such as this to be heard by those who make policy. And I hope all those who contributed feel proud to have participated in this democratic process and know that their voices have shaped the recommendations before us today. I'm grateful to have been able to hear so many of these contributions firsthand, and I feel humbled by the trust and generosity that so many people demonstrated in sharing their stories with us. Some shared experiences of unbearable suffering. Others shared their fears about what voluntary assisted dying might mean for their communities. Still, others shared their deeply held spiritual and cultural beliefs about death and dying. Every contribution mattered. I also want to thank all of my constituents who have spoken to me about this issue and have written, and to the best of my knowledge, all of those who I have heard from have said they are supportive of VAD legislation. I have heard many times before this inquiry commenced and many more times during it that the NT has waited far too long to regain the rights we originally had for people to have choice about a dignified death. It has been on the public record before this began that I am supportive of VAD legislation, and despite some of the flaws and legitimate criticisms of some aspects of this inquiry, which I will address shortly, I am glad that this process has enabled the progression of this issue further towards a legislative outcome. I want to commend the committee secretariat, who worked unbelievably hard to support the committee and were critical not only to the logistics and organisations of carrying out an inquiry of this size, but also to the quality of the final report. And my fellow committee members, I'd like to thank them for their dedication to this inquiry. In particular, I'd like to commend the chair for his dedication. With his enormous amount of work and unwavering commitment to this process, much of this report would not have been possible. I first want to address the report itself, although we've had a very thorough recap from the chair, which I'm very glad we have heard. And I think it's good. I think it's really good. It's another angle if people don't want to read the report, to be able to hear, and it's spoken through the reasoning behind all the recommendations that we came to. So I will first address the report, just some aspects of the report and the evidence and testimony you heard, and the recommendations. Then I will speak to the broader process of the inquiry and its significant flaws, as well as some of the troubling political dynamics that shaped this process and impacted the people who contributed to it. So I am broadly supportive of the final report and the recommendations it contains. Given the extraordinarily limited timeframe we were given to complete this work, I believe it represents the best outcome we could have achieved. The committee has recommended that NT legislate for VAD with strong safeguards, robust oversight, and critically, with cultural safety embedded as a guiding principle in the legislation itself. This would make NT the first Australian jurisdiction to enshrine cultural safety in VAD law, and I believe that this is appropriate given our unique demographics and the particular responsibilities we have to Aboriginal and Torres Strait Islander peoples. However, I want to be frank about some of the areas where the report may not satisfy everyone and where I myself may have some ongoing concerns. One area where we diverged from the 2024 expert panel's recommendation is in relation to the service delivery model. Now, the expert panel recommended a centralised VAD service separate from NT health facilities with dedicated practitioners, care navigators and pharmacy services. We've instead recommended a decentralised model where appropriately trained medical practitioners across both public and private sectors can register as VAD practitioners. Now, I understand some of the criticism that there may be of this decision. A centralised model would in many ways be ideal. It would provide the strongest cultural safety protections by clearly separating VAD services from the mainstream health system. It would ensure consistent standards, strong governance, and reduce the risk that hospitals or clinics become associated in some people's minds with administering death. These are not trivial concerns, particularly for Aboriginal communities, where trust in the health system is already fragile due to intergenerational trauma of colonisation and ongoing experiences in the healthcare system. But we had to weigh these benefits against the practical realities of the NT. The evidence before us suggested that a centralised service would be extremely costly for what is projected to be a small number of users, perhaps 8 to 12 deaths per year or around 100 consultations. Given the NT's already severe health workforce shortages and funding constraints, there were serious concerns that a centralised model would create access barriers, particularly for people in regional and remote areas. We also noted that no other Australian jurisdiction has adopted a centralised model, and all have decentralised delivery work. However, I want to be clear, I do not believe the centralised model should be discounted for the future. If the funding and resources become available, if our health workforce capacity improves, if demand for VAD services is higher than projected, then a centralised model should absolutely be reconsidered. The legislation should not prevent us from moving in that direction if circumstances change. Now, this brings me to a broader concern that has weighed heavily on me throughout this inquiry, that I'm not sure that cultural safety was addressed entirely adequately in this report, and yet I'm also unsure of how it could have been achieved better, whilst also ensuring that access remains unobstructed for people who want to access voluntary assisted dying. How does cultural safety marry up with equity of access? I don't think we came up with a perfect solution, but I genuinely don't know what else we could have done in the time available to us. The report recommends that cultural safety be embedded as a guiding principle in the legislation. It recommends enhanced Aboriginal representation on the review board. It recommends co-design of the VAD service with Aboriginal communities before implementation begins. It allows for video recordings of formal requests as culturally appropriate alternative to written documents, and it provides flexibility around interpreter requirements, recognising the severe shortage of Aboriginal interpreters and the cultural challenges and many interpreters face in discussing death. These are important steps, but I remained concerned about the cultural safety implications of voluntary assisted dying and the potential for it to further damage Aboriginal people's perceptions of and trust in the white-dominated healthcare system. Now, this is not a theoretical concern. We heard it clearly from Aboriginal people and Aboriginal health organisations during our consultations. The fear of the needle administered by non-Aboriginal healthcare workers carries a profound historical weight. At the same time, we also heard from Aboriginal people who want the choice to access voluntary assisted dying. And we heard, almost unanimously, that while many Aboriginal people do not want VAD for themselves or their communities, and many were quite clear about that, they also have no interest in preventing others from accessing it. And this brings me to the question of conscientious objection. On the issue of conscientious objection, I want to be clear about something. I am slightly less concerned about the objection of some religious institutions who I perceive may wish to control the choices of other people than I am with the objections from First Nations people and communities. These objections are fundamentally different in nature and have vastly different implications. First Nations people have experienced violence and genocide at the hands of colonial power structures. Their fears about death at the hands of healthcare workers are serious and rooted in historical and ongoing trauma. As part of their rights to make autonomous decisions for themselves and their communities, they must be able to object to any involvement in the voluntary assisted dying process. This is not about imposing their beliefs on others, and indeed that is precisely what we heard from many Aboriginal communities, which was, broadly, this is what we believe and this is what we want, but we only speak for ourselves. Why would we want to speak for anyone else? That's their choice. That's what we heard again and again. Religious institutions who object to that, on the other hand, seem to me to be seeking to impose their religious beliefs on others by preventing residents and patients from accessing a legal healthcare option. So whilst people absolutely have the right to make personal decisions around their health and body that are informed by their own religious and spiritual beliefs, I do not believe they have the right to obstruct others' ability to access healthcare or end-of-life options. Before and during this inquiry, there was much noise made by groups like the Australian Christian Lobby seeking to, in my opinion, cynically use First Nations people's cultural beliefs around dying and their general distrust of colonial systems to bolster their arguments against VAD. I found this to be extremely distasteful and disappointing. They attempted to paint all Aboriginal people with the same brush and erased any nuance in First Nations people's actual opinions to make it appear as though their cultural objections aligned totally with Christian objections, notwithstanding, of course, that some Aboriginal people are themselves Christian. What I actually heard on the ground from First Nations people was almost the opposite of what these lobby groups claimed. Yes, most people, Aboriginal people we spoke to, didn't want VAD for themselves or their communities, but they were also clear that this was their choice, their belief, and they had no interest in telling other people what to do with their lives. The respect for individual autonomy, the very principle that underpins VAD, was evident in how many Aboriginal people approach this issue. Now, I will return to this cynical representation of some of these lobby groups later in my speech. So even though I was aware of the generally poor state of healthcare in the NT, participating in these consultations really opened my eyes to the dire state of end-of-life care in Aboriginal remote communities and the urgent need for the NT government to develop a comprehensive palliative care strategy. I am genuinely proud that we were able to include this as a recommendation in our report, but I'm also deeply distressed at the current state of palliative care for many remote Territorians. We heard so much about First Nations people's profound desire and spiritual need to finish up on country, but also about the enormous barriers they face in doing so. People are dying alone in Katherine, Darwin and Alice Springs hospitals when they desperately want to be home with family on their traditional lands. Families are being forced to make an impossible choice, continue medical treatment in town or return to country, often without any care or pain relief. This is not a dignified death, and this is not a choice. This is a cruel dilemma created by the massive gaps in remote palliative care services. One medical witness told us that they, quote, have to forego a comfortable death just to die on country. It is an absolute shame in a country as wealthy as ours. Others describe family members suffering in remote communities without assistance because there are simply no palliative care services available. Now, we did hear from many communities and local staff doing incredible things against the odds to provide wonderful care to those at the end of life. But we also heard evidence from many communities which painted a consistent picture of people dying in pain, often away from family or without access to basic end-of-life care. And so here's what troubles me deeply. It feels morally wrong, in a way, to be pushing for one care solution so that some people can have a dignified death of their choosing, whilst knowing that there is a large cohort of people who will never choose that option, but who also deserve to die peaceful, dignified deaths in their own right, culturally appropriate deaths on country, but who are not being adequately considered or resourced. Many Aboriginal people we spoke to wanted assistance to die how they wanted, and this is where the nomenclature that the Chair spoke of was a really fascinating thing to unravel as we continued our consultations. The assistance they wanted, but not, quote, not with the needle, as they put it. They wanted pain relief that doesn't require them to die in hospital hundreds of kilometres from home. They wanted mobile palliative care teams that can come to them on country. They want to be able to practice their cultural ceremonies and have their families camp nearby as they're dying. And some communities, like the Malandari Aged Care Centre in Borroloola, are doing this beautifully, integrating bush medicine, allowing families to camp on the grounds and enabling cultural practices. But those examples are far too rare, unfortunately. Now, the committee has recommended that the NT government develop a territory-wide palliative care strategy and anticipate a 20 to 30% increase in palliative care demand following the introduction of VAD, based on what has occurred in other jurisdictions. This is essential. Voluntary assisted dying and palliative care are not competing options, they are complementary. Approximately 80% of VAD users in other states also receive palliative care. We cannot introduce voluntary assisted dying at the expense of palliative care expansion. Both must be funded and both must be accessible. I want to speak briefly to the committee's recommendation regarding prognosis. We have recommended that eligibility for voluntary assisted dying not require a specific prognosis timeframe, no 6 months or 12 months. This is a departure from the expert panel's recommendation and from most Australian jurisdictions so far, as the Chair has put out. I support this recommendation. The medical evidence we heard indicated that prognoses are extraordinarily difficult to determine with any accuracy, except at very short timeframes when someone is already actively dying. Requiring a specific prognosis can create a genuine barrier for people who are clearly dying and suffering but whose exact trajectory is unknown. Doctors told us they cannot predict with confidence whether someone will die in 6 months or 12 months or longer, and this uncertainty should not prevent someone from accessing VAD if they meet all other eligibility criteria. And as we know, this removal of the prognosis is the same in the most recent ACT legislation. And this is, I guess, one of the benefits of being one of the last ones, is that we get to look to where are things moving, how are things improving, let's take that on board. So I'm pleased to see that we've got that recommendation. The other safeguards in the legislation, the requirement for 2 independent medical assessments, a waiting period, the requirement for decision-making capacity at all stages, the review board oversight, provide robust protection without the need for arbitrary prognosis timeframe that may deny access to people who are genuinely suffering and dying. So now, Mr Deputy Speaker, I would just like to turn to the broader political landscape that surrounded this inquiry and where some of my issues lie. But first, I want to make it absolutely clear, my following critiques are not aimed at the government members of this committee. I saw all of my fellow committee members treat this inquiry with the care and seriousness that it deserves. I believe all committee members genuinely wanted to hear from people from all walks of life, all belief systems, and treated witnesses with the utmost respect. I'd also like to make it abundantly clear that the following criticism is not reflective of the work of the Chair either, whose commitment to ensuring that we heard from as many Territorians as possible, despite the impossible timeframe, was exemplary. But I do need to speak to some problems with the broader political process surrounding this inquiry. What occurred here speaks to the way this government routinely disrespects First Nations people and democratic processes. The CLP had said that VAD was not a priority for them. This inquiry proceeded because of the sustained pressure from progressive members of the crossbench. This government did not, absolutely. So we had a motion put forward by the member for Johnston on VAD. It was not a priority until that motion. Then we got an inquiry. So I commend the member for Johnston for pushing the agenda that constituents have been telling us again and again and again they want to see. I'll pick up on that interjection from the member for Honey Bay.
Order. Can the member of Johnston, member for Nightcliff, be heard in silence, please? And can we just continue? Thank you.
Thank you. We'll continue. And I'll put on the record interjections that it is apparently hilarious, but we hadn't seen it moved at all until the pressure. And I'm glad that everyone did, and pressure from groups and constituents who are writing to their local members who wanted to see it happen. So well done, everyone. And the government, it appeared, did not want to touch this issue. They were, in my assessment, or some may have been, influenced by lobby groups like the Australian Christian Lobby and were concerned about their conservative base. But when the pressure became too great to ignore, rather than embrace this issue with the seriousness it deserved, they set this inquiry up to fail. On 14th of May 2025, the Attorney-General gave us our terms of reference. We were asked to prepare a consolidated consultation paper, consult extensively with communities across the NT, particularly in remote areas, evaluate different models and safeguards, identify specific challenges for the NT, and provide drafting instructions. The deadline, end of September 2025. 4 months. 4 months to complete an inquiry in one of the most complex and sensitive policy issues we could possibly tackle. And in that 4 months, we only got 1 month to consult extensively with remote communities. I was deeply concerned from the very start that these consultations would be woefully inadequate and at worst culturally dangerous. The topic of death and dying is one of the most sensitive and difficult topics that exists. In many Aboriginal communities, even speaking about death can be considered dangerous. To attempt this kind of massive consultation in such a compressed timeframe was, in my view, unethical, and much of the feedback we got from people was that it was unheard of to have such an inquiry in such a limited timeframe, and there was the belief that it was set up to fail. Now, I put forward a motion to my committee that we ask the Attorney-General for a time extension. Unfortunately, that was voted down in the committee. The consequences of this timeframe were what I feared, that despite the absolutely heroic efforts of committee staff, as well as the committee members, who worked tirelessly and with genuine care to do the best they could, for example, some of the translated materials were not ready in time for community consultations. Most communities had no time to read the consultation paper or even begin to properly consider such a weighty topic. Many interpreters did not have sufficient time to be briefed on the complex medical, legal and ethical concepts they would need to explain. Many of them were grappling with cultural taboos around discussing death, and this was not how genuine consultation is supposed to be carried out. And the government and the Attorney-General knew that. This is not what co-design looked like. It's not best practice. Many communities refused to participate in the process, and I don't blame them. The Aboriginal Medical Services Alliance and Voluntary said in their submission that they were deeply concerned at the time frame and that the inquiry risked becoming nothing more than a box-ticking exercise. The responses we did receive, though, from the community were really down to people's incredible generosity with their time and personal stories. People showed up and shared deeply personal and often traumatic experiences with us, strangers who'd arrived in their community with barely any notice, asking intrusive questions about death and dying and about family members who had suffered. I do worry in this process that we may have perpetrated the well-worn consultation farce where colonial institutions and governments show up almost unannounced, asking incredibly intrusive and often ignorant questions of Aboriginal people who respond with far more grace than anyone deserves. And then they are promised a continuation of the dialogue only for the outsiders to leave and never be heard from again. There were moments where I was deeply uncomfortable with my own participation in this, even as I tried to push for better process. But probably one of the most things I'm most angry about is that voluntary assisted dying is the only topic this government has bothered to genuinely consult with Aboriginal people on. And you know why? Because extremely cynically, they believed that Aboriginal people would, for once, agree with their own conservative opinions on VAD. In the 12 months this government has been in power, they have made numerous legislative changes that have made enormous impacts on First Nations communities, but they have not bothered to properly consult on them. On youth justice, the government made sweeping changes, including lowering the age of criminal responsibility, changes that will disproportionately affect Aboriginal young people without adequate consultation with Aboriginal communities. Probably most shamefully, on sacred sites, the government pushed through amendments to the Aboriginal Sacred Sites Act that Aboriginal traditional owners explicitly opposed. The Northern Land Council stated the government ignored traditional owners throughout the process. Larrakia Nation specifically opposed changes that would allow development on sacred sites near Darwin waterfront, stating they never agreed to the proposal, yet the government proceeded anyway. But suddenly, when it came to voluntary assisted dying, an issue where the government hoped Aboriginal people would support them, suddenly consultation mattered. Suddenly they cared what First Nations people thought. Suddenly they were willing to send us out to remote communities to gather view. This is not genuine respect for First Nations voices. This is a cynical political manipulation, and it's absolutely shameful. To be crystal clear, I am very much in support of consultation, and I'm very grateful for the First Nations voices that managed to have a say in this inquiry. But it must be done ethically and in good faith, and this process was anything but. But here's the thing, Mr. Deputy Speaker. The CLP cynical attempt didn't work. As it turns out, what we heard from Aboriginal people was not what this government or the Australian Christian lobby wanted to hear. Yes, most Aboriginal people we spoke to didn't want VAD for themselves or their communities, but they also made it abundantly clear that they did not feel inclined to tell other people what to do with their lives. So the Conservative members of this government and bad faith actors like the Australian Christian lobby fundamentally misrepresented First Nations voices on this topic for their own benefit. They attempted to use Aboriginal people as a shield for their own ideological opposition to voluntary assisted dying. They painted First Nations communities as universally opposed to VAD being available to anyone, when the reality was far more nuanced and, frankly, far more respectful of individual autonomy than the position of those lobby groups themselves. This inquiry has lifted the veil on that manipulation. First Nations people here demonstrated more respect for personal choice and bodily autonomy than the groups who claim to speak for them, and that matters. Mr. Deputy Speaker, despite everything I've said, despite the flawed process, despite the impossible timeframe, despite the cynical political manipulation by this government, I am still glad this inquiry happened. It was difficult, but it needed to happen, because the alternative was for the NT to continue to be the only jurisdiction in Australia where people do not have the choice to access voluntary assisted dying. The report before us is imperfect. The process that created it was flawed, but the recommendations it contains will, if legislated, give Territorians rights that they should have had for the past 28 years, rights that were taken from us by federal parliament, rights that every other Australian jurisdiction has now restored. I support the implementation of voluntary assisted dying in the Northern Territory with the safeguards, cultural safety provisions and oversight mechanisms recommended in this report. I support the parallel expansion of palliative care services so that all Territorians, regardless of whether they choose voluntary assisted dying, can access dignified end-of-life care. And that is really one of the biggest, most important, I believe, takeaways of this report. I particularly support the focus on enabling Aboriginal people to finish up on country with appropriate medical support and pain relief, surrounded by family and able to practice their cultural traditions. But I also call on this government to do better, to properly resource the co-design process with Aboriginal communities that must occur before VAD is implemented, to genuinely consult with First Nations people on all legislation that affects them, not just when it suits your political purposes, to stop using First Nations people as political props, and to recognise that Aboriginal people, like all Territorians, deserve to have their voices heard genuinely and in good faith, and their choices respected. This report is a step forward, but there is much work to be done. Once again, I would like to thank all the Secretariat staff. It's hard to really put into words how much work this inquiry was. We pulled it off against all odds to the best of our abilities, and I'd like to also thank the committee staff members. I know this was difficult at times, and everyone went above and beyond to ensure that it was successful. So thank you.
Thank you, Member for Nightcliff. Member for Gwoja.
Thank you, Mr. Deputy Speaker. Mr. Speaker, I am the member for Gwoja. I am the member of the Northern Territory's most largest electorate. I am the member of the Territory's most diverse electorate. I am the member of Gwoja, a proud Aboriginal person who represents the interests of my community. Mr. Deputy Speaker, this is not an easy issue to speak on, voluntary assisted dying. It touches the very essence of life, of dignity and culture, and it challenges each of us to deeply think about compassion, choice and responsibility. On a personal level, I believe that people should have the right to choose when they leave this world. I've seen firsthand the success of voluntary assisted dying frameworks around the country and around the world. I have seen loved ones suffer through terminal illness, people in unbearable pain, carrying the heartache and sadness, longing for peace. I know that for them, voluntary assisted dying would have offered the chance to go with dignity, with respect, and on their own terms. But, Madam Speaker, while I hold these personal views, I stand here today not as an individual, but as the elected representative of the people of Gwoja. My duty in this chamber is to speak for my constituents, to represent the voices of the bush, and to make decisions with their well-being and cultural values at heart. Over recent months, I too have travelled across my electorate, the biggest electorate in the Northern Territory, the most remote electorate in the Northern Territory, and one of the most, if not the most culturally rich part of the Northern Territory, to sit with my families, my elders, my communities and my friends to talk about this deeply sensitive issue. What I have heard has been mixed, complex and deeply emotional. For many people, they have expressed support for the idea that individuals should have a say over their own health and end-of-life choices. But many have also told me that this concept, voluntary assisted dying, is difficult to translate and even hard to understand in a cultural context. For many of our mob in the bush, it is not just about language, it is about a worldview. This idea does not easily fit within our cultural ways of understanding life, death, and the role of family and kinship. If not communicated carefully, Madam Speaker, and respectfully, it risks causing distress and confusion, and in some cases could even create cultural and community unrest. Madam Speaker, I want to take this opportunity to acknowledge the enormous effort of those who have worked tirelessly in this space over many, many years. Advocates, clinicians, family members who have shared their stories, who have advocated long and hard. In particular, I want to acknowledge and thank the staff and volunteers in the palliative care units across the Northern Territory. Your work is sacred. You provide care and comfort for our loved ones. In our people's final days, you support our families through grief and loss. And too often, the palliative care amazing staff are often the only ones sitting there quietly beside our loved ones when they take their last breath. For that, I thank you sincerely. Madam Speaker, as I've said, I personally support voluntary assisted dying, but I was not elected to serve myself. I was elected to serve the people of Gwoja. And as their representative, I have to make their feelings known. While there is an understanding of personal choice, there remains a deep concern, anxiety and uncertainty about what voluntary assisted dying would mean in practice for remote communities. At this stage, we have no clear model for how it would operate in these regions. We cannot yet answer fundamental questions such as where would it be accessible? Who would be eligible? What are the safeguards and approvals? How would family, elders and kinship structures be included? Who determines who the next of kin is? These are not small details. They are central to ensuring that this process, if introduced, is safe, fair and culturally respectful. And I want to acknowledge, Madam Speaker, that the committee has done the work now to determine and bring in those particular parts and components. But out in the bush, these are questions that are still being answered every day as a result of those committee hearings. The conversation does not stop in the bush when the committee goes back to town. The conversation continues. And in the absence of information, in the absence of leadership, becomes fear. And fear rips apart our families. Fear rips apart our communities. And we cannot, Madam Speaker, let this absence, let this void be filled with fear. Communities must know. Communities need to know. the answers to these important questions. Until those questions are answered, until there is a clear and culturally appropriate model and bill that reflects the realities of remote communities, I cannot in good conscience vote in favour of voluntary assisted dying, because my communities demand to know the truth. They demand to know the answers. Madam Speaker, for those reasons, my position at this time will be to abstain. This is not a decision I have made lightly. It comes from a place of deep care and respect for my people, for my culture, and for the principle that every Territorian deserves to be heard and understood, and their decisions of this magnitude are made and respected. I want to assure my constituents, the good people of Gwoja, that I will continue to engage in conversations, to listen, to learn, and to work towards a model that truly reflects the diversity and dignity of all Territorians. Madam Speaker, the problem we have here is we have heard members speak all day in this chamber, but when we leave this chamber tonight, we are no better off than we were a week ago. There is no bill before the Parliament. I reject the assertion that the consultation was comprehensive, Madam Speaker. There are 76 remote Aboriginal communities. There are 500 homelands across the Northern Territory, places of love, of culture, of presence, of people. Effective communication and consultation is going to every single remote Aboriginal community and homeland. Sitting in the dirt, not a chair, not talking at Aboriginal people, talking with them and listening to them. That is what comprehensive consultation must look like on this issue. We cannot say that we effectively did consultation if we cannot say that we went to every single remote Aboriginal community and homeland and gave every single Territorian the opportunity to be heard. My electorate is the most remote, and my community wanted to know why they didn't get the chance to talk about this needle. That's what you have left. You have left an absence of communication. I have communities calling me saying they had a big meeting in Papunya about a needle and about dying. How come we never had that meeting? What is this meeting, Japananga? We're scared. That's what happens when you don't effectively provide enough time for effective communication and consultation. I'm not on the committee, but I have spent so much of my time on the phone and on the ground in remote communities trying to reassure people that they're not going to die. Because this government could not extend the time for consultation with remote Aboriginal Territorians, Madam Speaker. That's the reality that we live in. That's the reality that I'm faced with every day as the member for Gwoja and as a remote Aboriginal person, is having to have those conversations. Now, this government has made it clear that they're working on drafting. I would ask them to look at the comprehensive consultation that was undertaken with the Burial and Cremation Act in the Northern Territory. Get out to these remote communities, have these meetings, have extensive consultation, Madam Speaker. Have the consultation in language. Every single Aboriginal language in the Northern Territory must be communicated about this important change to the way that this works in the Northern Territory. Radio stations, Aboriginal media outlets absolutely critically need to be involved in communicating the messages. Video, audio installations, broadcasts in language, people talking about people having a say will be absolutely crucial to this moving forward, Madam Speaker, because it is absolutely integral that that happens. The burial and cremation consultation process, again, very, very comprehensive, acknowledged by the Northern Territory's 4 land councils as the most consultative piece of work that had ever happened in the Northern Territory's history with Aboriginal people. And was it perfect? No, it could have actually been better. Let's all acknowledge there's always room for improvement in everything that we do. But if we are going to have a genuine conversation around voluntary assisted dying in the Northern Territory, none of us can stand in here in good conscience and vote either way without absolutely having a guarantee that when a bill is brought in, it is sent to a legislative scrutiny committee and that there is absolutely an opportunity for every Northern Territory person, remote community, homeland, multicultural group, aged care facility, to have a say, to have an opportunity to look at what is in the bill and to provide impact and to provide feedback around their thoughts on the bill. Because I absolutely acknowledge that there are members in this chamber whose electorates you can basically walk around in 45 minutes, the boundaries. Unlike mine and the member for Mulka, who is on islands, so remote you can't even get there by a car. We ask that we are given time when a bill does come to Parliament to consult effectively with our communities. Because, Madam Speaker, this is certainly an important issue and absolutely there is a ton of work that needs to be done. I absolutely want to sincerely thank the legislative, committee, the LCAC, the Legal and Constitutional Affairs Committee, for their work. I absolutely do not envy the pressure that the Secretariat staff were under with such an unrealistic timeline to work towards and the pressures of competing views. I absolutely want to thank the Legal and Constitutional Affairs Committee Secretariat staff. Thank you for your work, your long nights, pulling this important report together. I want to absolutely acknowledge that the members on the committee did their best with the limited scope and resources and time that they had to consult with Territorians across the place. But I also want to thank my communities, because it wasn't the work of anyone in this parliament to get everyone to those meetings. My own family were the ones ringing around and dragging everyone to the meeting in Papunya because the community didn't even know the meeting was on. A flyer was just put up in one council office and no one goes to the council office. So again, if we're going to actually look at proper consultation, we absolutely need to engage Aboriginal organisations to help lead what that conversation and what that consultation looks like, Madam Speaker, because this is an important issue for everyone. I absolutely acknowledge that everyone will have a differing view. There will be people who agree, there will be people who oppose, and there will be people like myself who, in the current form, will abstain from the vote. But I think it is important, and I just wanted to take the time to reiterate around the consultation. I want to also point out that Aboriginal people, us, we're blackfellas, but we're not all the same. Our kinship and cultural structures are different. My biological mother might not have the same say that my kinship structure, hierarchy fathers have over my rights. That needs to be considered in any form of legislation. Now, the member for Mulka has been a long advocate for that, particularly in the Coroners Act and how that intersects and works. This is an opportunity to actually have a real conversation around upholding and respecting the cultural and kinship structures, because if this legislation doesn't do that, there's going to be big fights and people are going to be accused of doing things to family and people are going to get sick in our culture if this is not done properly. So this is a space that we cannot muck around with. This is a space that absolutely, when it is drafted, needs to be done around the table with senior Aboriginal leadership and elders and traditional owners to make sure that their voices, that kinship structures are enshrined, are upheld and are respected. Now, I've heard from members here today again about choice, and yes, as I've said, Aboriginal people, us as countrymen, we're not all the same. Some people might want this, some people might not want it. But it's important that those structures are put in place and that the conversation is had, because I've been putting out bushfire since that committee went to Papunya, because no one went to Kintor, no one went to Nyurupi, no one went to Docker River. Why? Because the Attorney-General wouldn't extend the consultation timelines. So the CLP have just created more fear in our remote communities because people are saying, well, how come you chose that community and not mine? I said, I don't know, that's the government's decision. They should have gone to all of the communities. That's what you do when you don't allow to get to every remote community. That's what you do when you don't go to every town, camp or Aboriginal living area in the Northern Territory. You allow for fear to creep in. You allow for misinformation to creep in. And whenever there is a bill, a draft bill, whether it's something that the Leader of the Opposition's done, whether it's taking on board the committee report, or whether it's something that the CLP government are going to bring in, I know that other people out in the community are saying, just get it done, just get it done. That's not my view, because we only get one chance to talk about this. One chance. And Aboriginal people deserve to be effectively and comprehensively consulted on this piece of legislation and the drafting of this, because it's incredibly important. And as I said, it is an issue, Madam Speaker, that absolutely touches the lives of every Territorian. It is something that we cannot muck around with. It's something that moving forward, we should no longer be who said what's happening. It's above politics. We've had the territory rights. The Commonwealth have given us back the opportunity to look at these laws and make these laws. And I want to acknowledge that, yes, the Northern Territory was the first jurisdiction to do it. And I want to just acknowledge that other jurisdictions have it and models are changing. But, you know, there are issues around telehealth and those issues as well when it comes to this very issue. So we need to make sure that we do it right. I do thank honourable members for the opportunity to contribute tonight. And again, I will remain committed to the people of Gwoja. Your view is the view that I will represent in here. I'm not here to serve myself. I'm here to serve you. I'm committed to you and making your voice be heard in this place. And I will continue to get out in the red dirt, on country, in country, talking to you, listening to you and acting for you. Thank you.
Are there any other speakers? Member for Wanguri.
Thank you, Madam Speaker. As a member of the Legal and Constitutional Affairs Committee, I rise to speak on the final report on voluntary assisted dying in the Northern Territory 2025. This report captures one of the most deeply human consultations undertaken by this Parliament. A conversation about suffering, compassion, culture and choice of how those who wish to die. Madam Speaker, earlier today, by the Chair of the Committee, Member for Fong Lim, used the words choice the finisher. When a person has advanced and progressive condition which is expected to cause death and is causing intolerable and enduring suffering that is actual or anticipated. Madam Speaker, over 4 months, our committee, consisting of the Member for Fong Lim, Member for Blain, Member for Nightcliff and the Member for Daly and myself, the Member for Wanguri, travelled thousands of kilometres across the Territory and we listened to hundreds of Territorians and reviewed thousands of pages of evidence. But, Madam Speaker, we heard from voices as far as Papunya and across to Numbulwar, and we also heard from the widow of the first person in the world to use voluntary assisted dying, the late Bob Dent. Back in our own territory, Mrs. Judy Dent and the struggles they had back then. Madam Speaker, we heard stories that were raw, emotional and grounded in territory realities, but for both for and against. Madam Speaker, this inquiry was referred by to the Legal and Constitutional Affairs Committee by the Attorney-General, and I thank her because it allowed us to do that final consultation and check in with those who did not submit any submissions in the previous 2024 report. We were asked to prepare a consolidated consultation paper, consult extensively with communities in the timeframe we were given, particularly in the remote areas. We were asked to evaluate different voluntary assisted dying models and safeguards for all Territorians, with a focus on that would be appropriate for the Northern Territory's context, and identify specific challenges associated with delivering voluntary assisted dying in the Territory. And, if the committee recommends adoption, provide drafting instructions, in which we have done. These terms of reference guided every aspect of our inquiry, from whom we spoke to how we examined the evidence, and ultimately we have formed 86 recommendations in a bipartisan approach. Now, Madam Speaker, when this was referred to the Legal and Constitutional Affairs Committee, I did get an influx of emails and phone calls from my own constituents. But every person I spoke to, I did actually specify that I wore two hats. I was going to be the member for Wanguri, and I was also on this committee, and actually separated those two hats. We heard from doctors and nurses, Aboriginal organisations, faith leaders, lawyers and families who watched their loved ones suffered. Some pleaded for legal compassion through voluntary assisted dying. Others, grounded in faith or cultural law, urged caution for opposition. Both sides spoke from love for their family, deep respect for culture, and the desire for laws that show compassion while safeguarding that trust. Madam Speaker, after examining evidence, the committee made 86 recommendations for the territory-specific model of voluntary assisted dying. We concluded that the NT should proceed with legislation, but only through a model that fits our geography, cultures and health capacity. The eligibility, adults with decision-making capacity facing intolerable suffering from advanced progressive condition expected to cause death, but no fixed prognosis. Clinical judgment should not guide timing, not arbitrary timeframes. And safeguards, 2 independent medical assessments, interpreters and cultural liaison officers, where needed, were mandatory. Cultural safety embedded as guiding principle with community co-designed Aboriginal health organisation leadership. And conscientious objection. Practitioners and institutions may decline to participate but must provide referral pathways. And as for the oversight, an independent review board to monitor every case and report to Parliament. Palliative care, also parity. VAD must complement, not replace palliative investment. Madam Speaker, culture and country shape how Territorians understand life and death. In Arnhem Land, leaders reminded us that decisions are shared through kinship, and in the Barkly and Alice Springs, health staff described fear of hospitals, echoing historical trauma. But the committee found that any assisted dying must first rebuild trust that medical care is safe, interpreters are impartial, and consent is real. Madam Speaker, for the faith leaders, Christian, Islamic, Hindu, Buddhist and others, engaged with courage and grace. Many hold a deep reverence for life and fear that voluntary assisted dying may contradict moral teachings. Yet even among opponents, there was strong support for compassion and robust palliative care. In fact, I did ask the Australian Christian lobbyist and also at our meeting in Alice Springs with the Baptist Church, and I understood that faith obviously was their underlying reasons for opposing VAD, but I did ask them would they still assist and support people in their community if they wanted to use voluntary assisted dying, and they were supportive of that. The committee affirms conscience must remain free. No practitioner or institution should be compelled to participate, but patients must have access through referrals. That dual respect for conscience and for choice is a defining strength of our approach. Madam Speaker, and the remote hearings were amongst the most powerful moments of this inquiry. In fact, I'm absolutely grateful for being able to be on this committee and to actually understand the remoteness of our territory. Being a suburban electorate seat, it gave me insight to how the whole territory needs to work together. One of the actual remote consultations, and actually it was the first one, which uncovered and how we actually communicate with our Indigenous community members. And so we actually redefined the words voluntary and assisted. We asked them if they would like their own free choice, and we asked them how they would want to be assisted in dying, which most of them would have preferred to would just withdraw from care. With that, that actually gave us insight on how their community works and how they make their decisions on withdrawing from treatment. But that also gave us insight into how we spoke to them so that we could ask if they were okay with others in the community or outside of their community. If they wanted to use voluntary assisted dying, would that harm them? And they actually confirmed that it wouldn't, and that they would be okay with someone else using it. We understood that they would probably never use it. So, Madam Speaker, for our anti-health officials, they were quite frank. Workforce shortages were brought up. Our fragile palliative care infrastructure and long distances pose serious challenges. They supported voluntary assisted dying in principle, but warned that success requires careful phasing, strong governance and investment. And this was actually one of the, also, as the Chair iterated earlier today, this report now gives us the basis to go back out into our communities to actually work with our community and ask them now how they do sit with VAD. So there is a document now that you can use and actually talk to your constituents, and if you need to ask any questions, I'm pretty sure any of the committee members would be able to assist you with that as well if you have any challenges. I'm not for or against at this stage. I will have to vote according to my electorate, but it was actually enlightening to be a part of this committee so that I could actually form some kind of understanding when I'm communicating with my community. So, Madam Speaker, despite the challenges, the majority of submissions supported voluntary assisted dying as an act of compassion and self-determination. Health professionals spoke of moral distress when unable to relieve suffering. Families even said discussing voluntary assisted dying brought peace, knowing that choice itself could ease fear. And Aboriginal leaders expressed cautious support, provided it was safe, culturally grounded and voluntary. Madam Speaker, many remote community members were against voluntary assisted dying. However, they do support others who wish to use it, albeit they would not. To the point where the committee asked, would it harm again? And they verbatim would say, we would never use it ourselves, but we want others to use it. Madam Speaker, many of these voices were referring to Territorians and urban centres who would most likely be users of the voluntary assisted dying if it becomes available. Our committee mandate was to gather evidence, not pursue ideology. We held open consultations, published interim findings, and invited expert feedback. It would be wrong to dismiss the process as partisan or biased without engaging with its substance. While members may bring forward private bills, timing and process matter, announcing legislation before full drafting or engagement with the committee's findings risk confusion and public mistrust. This inquiry exists not to delay, but to ensure the law we craft is safe, workable, and culturally grounded. Madam Speaker, assisted dying cannot be reduced to slogans or urgency. Witnesses were warned of risk, unequal access, language barriers, fragile health infrastructure, and the need for robust cultural safeguards. Faith groups asked for conscious protections, clinicians asked for training and oversight, and families pleaded for both palliative care and choice. These are not barriers. They are not the scaffolding of trust. A bill that glosses over them would fail the people it seeks to serve. And Madam Speaker, from this journey, 3 truths stand out. Choice requires trust, compassion must be practical, and respect is our compass. The final report sets out a clear course. Draft legislation guided by our 86 recommendations established a voluntary assisted dying implementation task force, fund training, interpreter programs, and cultural liaison roles, strengthen palliative care, deliver public education in first languages, and review the law at 3 years and then every 5 years through independent oversight. And in closing, Madam Speaker, our committee approached this work knowing no law will satisfy every conscience, but silence and suffering are not options. This report does not seek to end life, but to honour it by allowing Territorians to face death with dignity, in accordance with culture, faith and will. And as one submission said, we're not asking for an easy death, we're asking for a gentle one. That is the standard we must meet, a law shaped by compassion, grounded for safety and built for the territory love. And Madam Speaker, I do wish to thank the Secretariat and the team. I wish to thank the other members of the committee as well, as it was very testing with our time frame. And in fact, also one of our trips was a little bit chaotic in the air. So for those who are waiting for this legislation, I do ask you to be a little bit more patient as we are trying as best as we can to get you a bill and for those of us in our electorates to actually consult. Thank you, Madam Speaker.
Member for Daly.
Thank you, Madam Speaker. And I rise today to speak on the Legal and Constitutional Affairs Committee report into voluntary assisted dying in the Northern Territory. But firstly, I want to take a moment to recognise those who have been advocating for years. Those who have fought, those who have written, those who have spoken out publicly, and those that have been working quietly behind the scenes. The families who have shared their stories of loss and pain over decades. The doctors, nurses and carers who have seen suffering up close, and the Territorians who have had the difficult conversations about dignity, compassion and choice. Your persistence and courage have brought upon this moment, a moment that's about compassion, it's respect, it's about dignity, and it's about an individual to have the right to choose how they pass away. The committee's report reflects what many of us already know, that Territorians deserve the same rights as people in every other part of Australia. Every state now has voluntary assisted dying laws. The Northern Territory was the first to have that right, and it was the first to be taken away. It's been 30 years since the Commonwealth Government overturned the Territory's 1995 Rights of the Terminally Ill Act. Since then, we know that generations of Territorians have watched loved ones suffer, denied the right to make their own decision about the end of life. But, Madam Speaker, this report makes it clear that the time has come for the Territory to move forward. Carefully, respectfully and guided by compassion, it's not about promoting death, it's about relieving suffering. It's about giving people a choice when medicine can no longer heal or ease that pain. I want to also just acknowledge, and I know the Chair has also acknowledged, and other members that have spoken of those who do have differing views. We know it's not easy at times when we do have differing views, but I do appreciate those that have come forward around their views on whether it's faith-based or culture or personal beliefs, but those views are just as important to those that may support VAD as well. Those perspectives matter deeply, but what this debate calls for is respect. Respect for the individual and the principle that no one should impose their personal beliefs on another's most intimate decision. Madam Speaker, as lawmakers, we're entrusted with the responsibility to act. The committee has done this important work in listening to Territorians, and now, in my view, I strongly believe we need to honour that work and ensure that Territorians once again have the dignity of choice to have a choice on the way they would like to pass away. I want to thank the chairperson, Tanzil, personally. I know you put a lot of work and a lot of effort into this consultation, and that was reflected in your speech today, and I do, in the bottom of my heart, highly appreciate the speech that you did today. I think it was highly important to go through the detail by detail. It actually got myself to change a bit of the speech because I thought you went through it beautifully to talk about all the recommendations in the report, the 86 recommendations. So thank you for giving that time to put it across in the chamber, but also so it's on Hansard for people to see and those that are watching to have because it is a huge body of work. It is confusing. It can be confusing if you're looking from the inside trying to read that report, but I thought you dissected that very well. I don't agree with all of it, what you said, but that's okay. I still respect you took the time to do that. Also to Matt and Ollie, thank you from the CLP side too. I know you were there for every single minute throughout that consultation period. It took you away from your family, your electorate as well. So just appreciate your time as well on that and your constructive consideration to the consultation process itself and the sensitivities that came with that as well. To Kat as well, I know that took away from your family too, so just appreciate your time to be able to get out as much as you can with the restrictions that you had in place as well. But I think we all, in a bipartisan way, came together. We know that we were restricted with time. There was a bit of argy-bargy within the committee itself, but we did just have to get on with actually what the terms of reference allowed us to do. And I will touch on it and speak on it, what I didn't agree with. But overall, I do just want to put on the record that I support the report, hence why I didn't want to do a dissenting report as well. So firstly, I just want to acknowledge those who have spent the years advocating for dignity, choice and compassion, the families, carers, health professionals and community members who have pushed for respectful and humane end-of-life options. Their commitment has brought this issue back into the Territory conversation, and also not just the Territory conversation, the national conversation. We know it's getting a lot of airtime down south as well. So, Madam Speaker, like I said, I've got to be clear that personally, I don't believe the process in terms of the terms of reference had been, quite frankly, done in a culturally appropriate way. I thought it was quite culturally inappropriate. I've made that clear on the committee. I think that it disrespected a lot of the Northern Territory final report in 2024, but you know, that's not a reflection of the committee members. That's what we were handballed by the Attorney General and the restrictions that we had to work within to try and get out and consult with Aboriginal communities. And the reason I say that is that we were given that in May and only allowed 4 months to consult with Aboriginal Territorians. By the time the committee met, it was probably 3.5 months to 3 months. We wrote to many Aboriginal organisations, all the 4 land councils, AMSANT, but it was really hard for those organisations to actually come to a position because they have to actually meet as a board to discuss those issues, and they may not necessarily have the time to meet to be able to come to a position on that. But given that, we still went out to communities to do the public consultation, and where we could, there were some organisations we were able to meet with. There were others that we just had open public hearings. In Burunga speaks to mind, where people just rocked up and were asking, oh, what's this about? We had to explain to people what we were there for. People had to dissect that, process what voluntary assisted dying was, and then give a response how they'd felt, when it should have actually gone through a lot of the Aboriginal organisations and corporations to those elected committee members, and for the Northern Land Councils or AMSANT board members to be able to do that representation for the community. That's why they've been elected for. So, Madam Speaker, the independent expert panel, which was commissioned in 2024, I just do want to give a quick shout out to all of them, because I know some of them were quite insulted by the government sending this to the report. We know that they didn't just go down and up and down the Stewart Highway, as the Chief Minister and the Attorney General have continuously suggested. That is just factually not true. Was their process perfect? No, but either was ours. So I know many were quite upset by those remarks, and it was disrespectful to those people on the advisory committee that those remarks were made by some of our government ministers at the time. AMSANT reflected on that, Madam Speaker, in one of their submissions about it being culturally inappropriate. And I quote that AMSANT has consistently advocated for the need for well-resourced, culturally safe consultation process, particularly when engaging Aboriginal communities on complex issues such as voluntary assisted dying. While we acknowledge the committee's intention to consultation across the Northern Territory, we're concerned that the timeline and resourcing allocated may not reflect the scale or culturally complexities of the task. Consultation in remote contexts requires more than routine outreach. It depends culturally competence, establish of trusted relationships and considerable time investment. Discussions involving life, death and care at the end of life intersect deeply with cultural and spiritual protocols. These factors must be central to any consultation process. So again, just because people show up to consultation doesn't make it culturally appropriate, as outlined from AMSANT in their submission. They also suggest that the committee should adopt a strength-based lens in the process. Look, they've got a number of points there. I'm not going to speak to it in detail. It is all there in their submission, Madam Speaker. So while I may not have agreed with the whole process that I've mentioned, I do think the committee members did their best to put a pretty good report considering the restraints we had on ourselves. But I do also just want to thank many of the people that turned up and acknowledge that showed up to those public hearings. In many of the remote communities we visited, people turned up not even know what the meeting was about, yet when we explained that we were there to talk about voluntary assisted dying, which is a very sensitive and confronting topic, people were generous enough to sit with it, to process it, and to share their thoughts about how such a law might or might not fit within their cultural frameworks. I want to thank those community members for their time, their honesty and their generosity. It takes enormous courage to speak about death, spirituality and cultural practice in that way. But, Madam Speaker, that is exactly why I had concerns about this process from the very start. We asked people to engage in a conversation that speak of grief, and then we moved on. There was no structured follow-up, no wellbeing checks, or no clear cultural or emotional support offered onwards. I know at the start of those consultations, people were given a number to call, but as I've spoken many times, a lot of people in remote communities don't just ring that number to get help. It just doesn't happen. We need to be looking at supports that are in place at a local level in communities, are personal and that are culturally grounded in those communities to ensure that people have the right supports. Madam Speaker, moving on also just around palliative care, and I want to speak on this issue because it did come up a lot in a lot of our consultations. And just to make the point very clear that voluntary assisted dying cannot and must not stand alone. I think we got that pretty clearly out of these consultations. If we move forward on this issue, it must happen in conjunction with a well-resourced health system, one that supports our aged care homes, our community clinics, our hospitals, our disability services, and most importantly, our palliative care services. And I highlight this, Madam Speaker, because voluntary assisted dying is not simply about the choice of end of life, it's about how care for people throughout their life and how we support them when their time does come to an end. Madam Speaker, throughout this inquiry, one message came through again and again, especially in our remote and regional consultation care. Palliative care in the Northern Territory is stretched, under-resourced and is often inaccessible. In too many communities, there are no dedicated palliative care staff, in fact, none at all. People are being flown out at the end of their lives, leaving country, family and their culture just to receive care that others would otherwise get living close to their home. I want to also just take a moment to thank the Palliative Care Northern Territory. I'm sure many of you got the email last week about just reminding us of their submission that they'd put in. I want to thank them for their tireless advocacy and their detailed submission to the committee, and for writing to me last week to underline the importance of building proper foundations before moving ahead with voluntary assisted dying. The submission doesn't oppose choice, it just calls for compassion planning and proper resourcing. It reminds us that VAD must sit within a broader caring system, not replace it. So, Madam Speaker, the committee's report rightly calls for the NT Government to develop a comprehensive palliative care strategy, acknowledging that current services are stretched and under-resourced. That strategy must be ambitious, practical and grounded in territory realities. I just want to share a few of the key recommendations that Palliative Care NT has put forward because they show what real compassion and proper planning look like. They say wherever you live, when you are close to the end of your life, you should be able to be cared for in the place that you choose with dignity. To make that a reality, they have called for a home and community end-of-life support program, including home support and last days, care packages, return to country program with transport and carer support that doesn't rely solely on aeromedical evacuations, accessing to essential equipment for people who can't get support through NDIS aged care or territory equipment programs. They've called for adequate resourcing for specialist palliative care teams, as well for safe staffing levels for inpatient palliative care services, multidisciplinary palliative care hubs in Darwin and Alice Springs with allied health, bereavement support and nurse and educators, training and support for Aboriginal health workers as palliative care leaders, community palliative care teams that can provide responsive outreach and support to primary healthcare staff, regionally based palliative care nurses in Tennant Creek, Catherine Grove, Borroloola, and the list goes on. I don't get an extension on this, do I, Madam?
Yes, you can.
Oh, I do. Okay, no problem. I was hoping I'd get all day like Tanzil. So they have also recommended investing in palliative care champions across government and non-government sectors and establishing a yearly NT palliative care conference to share territory-specific knowledge. Madam Speaker, that's not just bureaucracy, that's building capacity, dignity and care close to home. They've also called for proper support for families because families are at the heart of the end-of-life care. That means program funding for respite options, practical care support, bereavement and counselling services. They've urged that all of this must be culturally safe, which I think all of us agree. I know everyone here that's spoken on it today has mentioned that it needs to be culturally safe, recommending the development of a centre of excellence in culturally safety in the end-of-life care. This will allow Aboriginal and Torres Strait Islander peoples to receive care that aligns with their beliefs, values and connection to country. Madam Speaker, I will just briefly come to the end. Look, I know I've kind of gone over the deficiencies of what's gone on, but I do, again, I don't want to take that away from the report itself. I do think within the time frame that we were given, we couldn't have done any more. You know, we had 1 month literally out on the road, and you know, I admit I couldn't be at all of them. I've got other responsibilities with my shadow portfolios, 11, plus a huge electorate, like many Bush members. So it is difficult to balance that out as most urban members, no disrespect, but can get home most nights after a day of work, as we're lucky to be home 1 night a week with the work that we do. But that's not taking away our urban members' work that they do. And that's a responsibility that I'm honoured to have. But in saying this, you know, I'm sure many of you know, once a bill comes forward, if a bill comes forward, I will be supporting voluntary assisted dying. I do believe that we can resource palliative care properly. That was outlined in my speech just then. I do believe the consultations that we did see, while I would have preferred to have a physical bill in front of me so we could answer specific questions and concerns to an actual bill, I do believe that most people we spoke to out in the bush you know, were comfortable with the right for other people to have that choice. And that's what this is about. It's about choice. It's about dignity for families. It's about a person's right to be able to pass away with dignity. But also not just that person, the individual, it's for their families. It's for their friends that have seen their family members and friends suffer for months on end, sometimes years on end, which on that I want to thank Sharon Cramp Olivia from Bino in my electorate, who only wrote to me this morning urging and hoping that I would be voting for voluntary assisted dying. And I do just want to read out her story, and for those in here, just acknowledge it may be sensitive. It does talk of suicide. So Sharon wrote to me about her mum, Elizabeth Ann Holmes, a story of a beautiful lady that did not have the choice to access euthanasia. The Northern Territory is now the only state or territory in Australia that has not passed laws for euthanasia. My mum, Elizabeth Ann Holmes, broke her back when she was 53. She battled breast cancer for 12 years and had 2 hip replacements, one that dislocated itself early in 2007. She had a terrific career. She worked in a bank, she raised money in the Miss Australia quest, worked as a model, worked in retail, worked as a diversionary secretariat for a prominent insurance company, was a Justice of the Peace for many years, and also worked as a volunteer Lifeline counsellor for 18 years. And most importantly, Mum was a devoted and dedicated wife and mother. Mum kept an extremely detailed diary which explains in details the decision she was faced with before she took her own life in September 22nd, 2017. Mum was 77 years old when she died. Her story and diary were tabled in the Northern Territory Parliament on November 23rd, 2027 by Sandra Nelson MLA. My mum was a strong believer in euthanasia and would have definitely accessed it if it was available at that time she ended her life. The day Mum died, a letter was found on her dining table, and I quote, "To everyone I love, especially Wayne, Sharon and Wendy, I was so looking forward to my life after my 2 hip surgeries. I have not been able to walk or drive for years. For the first time after the 2nd operation, and I knew my life was ruined, my dream of training into Melbourne to visit my son and grandkids, and also to Adelaide to catch the Garn, to see Shaz and Spud out of Darwin, and my first trip to Wen and Dave's home, and my granddogs. Now I cannot even walk Katie. Katie is her dog, or her grand-dog, as she refers. I thought, okay, if I could not walk, I will swim, but I cannot do that as well. My grade 4 breast cancer has progressed and has broken through the skin and will infect people and become infected myself. I've had 24 years of pain. I'm not going to burden my children and friends and have palliative care. What a farce that is, because there is no option in New South Wales. I chose euthanasia. At least I could still drive, but I'm not capable of doing that. Never had an accident in 60 years. I've lost my confidence in driving. I've no independence. My licence has been cancelled. I have to pay to keep my garden, house and dog plus maintenance. I watch TV, I read, I do crosswords. I've become a hermit with a dog called Katie, my saviour. I have nothing to look forward to but pain and indignity. We all should be able to choose when we die. So with great courage and no cowardness, I go to God. An act of love. Please cremate Katie as she can come with me. Love, Mum." Madam Speaker, it's stories like this will be why I'll be voting on voluntary assisted dying if it comes before the Parliament in this term, which has been suggested by the government. We need to ensure that people like Elizabeth are given that opportunity to die with dignity, to ensure that people like Sharon the daughter of Elizabeth, are able to see their mother die with dignity and have that choice. But also the choice to be able to choose that also, it takes away that anxiety for a lot of families and the person going through that suffering. So I would urge everyone on both sides, my own team, on the other side, the crossbench members, really to consider this deeply, because there are people that go through intolerable suffering, and that's not okay, and people should have that choice to be able to end their life. Thank you, Madam Speaker.
Chief Minister.
Thank you very much, Madam Speaker, and I too would like to rise to speak to the debate today. And I'd like to start by thanking the committee for their significant and hard work. This has been a really important process to us as a government, and I'm not going to enter into the cynical political rhetoric of some of those opposite, but what I will say is that this has always been a topic, and I've been around a lot longer than those who choose to throw stones at me, Madam Speaker, that we have always had a very consistent position on. And so we have always said that this is something that needs to be highly consulted on right across the Northern Territory, in as many remote communities as possible. It needs to be done respectfully and comprehensively and in a way that has integrity, that people can trust that process. That has always been something we have talked about, and this debate has come up many times during my more than a decade in this chamber, Madam Speaker. And so on coming to government, I made it very clear, because there were some loud calls right from the start about whether VAD would be coming through, and I made it very clear as part of our year of action, certainty and security, to not raise the expectation of our community and play politics with them on an issue that is deeply important to many and deeply hurtful and difficult to many as well. We made it very clear we had clear priorities. This was not an election commitment. This was not an election promise or anything even close to that. And we proceeded with the regulatory reform we have been doing across a range of areas, across crime, across the economy, across lifestyle. And huge gains have been made and swathes of work done. It allowed us then to be able to get the Legal and Constitutional Affairs Committee to move into this consultation process. And we deliberately picked the LCAC so that it was a bipartisan committee of the Parliament with that legal mindset and framework to be able to go and do the consultation, go and test the veracity of the report that was done under Labor, and provide really clear guidelines. We asked the committee to come back with drafting instructions, which may or may not be unprecedented. It is certainly not common. And we did that very deliberately because we wanted the chamber, the Parliament, the Assembly, and in turn Territorians to have confidence in and engagement in the outcome. And from all of the contributions I've heard today, Mr. Deputy Speaker, I am confident that that has what has been achieved. And that is quite special. It is quite remarkable, because what we have is a very diverse group of representatives and political parties coming together to reach one consensus view around a way forward, which is very important for a government on an issue like this. And while some members opposite want to somehow compare this legislation to other legislation which was taken to a general election and relates to matters couldn't be further from this topic, is ridiculous. This is different and deserves to be treated differently, and we have seen that play out in parliaments around the country and on topics in this parliament, in fact, Madam Speaker, and certainly there are other debates I can reflect on and remember where this same type of process and careful respect has been afforded. And so what we have now is a very significant body of work, a very significant body of work. And because it has been done in the way it has been done, in the extensive way it has been done, it gives us as a government great confidence to move forward, which is why the Attorney-General is moving to the drafting process, and I pick up on some of the comments by others. This bill will be brought back to the Parliament this term. There is absolutely no doubt about that. The work is starting because we have a product we can work with. We have confidence in something that everyone can get behind. There would be nothing worse than to play on the emotions and the heartstrings and the hope and aspirations of our community to bring some botched up piece of legislation into this Parliament that does not have the consensus of Territorians or the room. And imagine if a party or an opposition leader was to bring a bill into the Parliament and it was to fail. We talk about sensitivity and the impact on people. Those are all impacts and considerations for a government. And so now we have confidence, we have something that has been pulled together by the diversest range of representatives from the diversest range of people of the Northern Territory. It provides a platform to be able to prepare the legislation to be modelled from. It gives us great confidence, and the member for Fong Lim, as chair, went through extensively each of the considerations and decision points that they reached, which gives anyone the opportunity to better understand it, certainly not just members of Parliament, but members of the community. And then we've had the nice overlay of members of the committee adding their unique perspectives. So it is very well worked through and covered and comprehensive. And what I've heard from each and every one of them is that this isn't straightforward. So for the people who would like to see this rushed, and there's certainly been many calls in the government's direction to this needs to be done faster, this needs to be done quicker, what I'm hearing today is the exact opposite. And in fact, there is now a very clear understanding amongst members of Parliament and in turn the community that this is not something to be rushed. But there is many and varied layers well beyond the actual substantive part of the rights of the terminally ill. For example, the member Fong Lim went through criminal provisions. I mean, most people would absolutely not turn their mind, nor care about it, quite honestly. But that's our job. That's where we come in. We have to do these things. And so, yes, I appreciate the urgency for many, but there is a very, very legitimate process we have to go through. Everyone has talked very affectionately about palliative care, and I don't think anyone in this room has ever heard a bad word said about the team at palliative care. They are just amazing. And everyone has a very significant understanding of the work that needs to be done to support dignity at end of life across a range of deliverables. And ways to deliver palliative care. And so again, that is a nuance. What we're hearing today is that palliative care requires a lot of work to be done to be able to proceed with VAD. And so these things are not isolated. They are not straightforward mechanics. This is not a mechanical process. The cultural considerations, the religious considerations, with the conscientious objections and all of those things, that has been very extensively considered well beyond what we've seen in the past. And so it is a very important body of work, and I commend everyone for being involved. What we've also heard then is that implementation post-bill takes a significant amount of time, and what I see is consensus in the Assembly, again, from all parties represented, that too is important. And so I certainly hope from my perspective that we continue to see this level of respectful debate and public commentary on these issues, because no one gains from inflating this into a political issue. It is now in train. We now have a roadmap we are all able to get behind. And so it's about making sure then that detailed work is done, that everyone is out in their communities, consulting with their communities. I note it's conscience votes for both Labor and CLP members. And so again, those processes are upon, that responsibility is upon MLAs to go and do that important work. And the result will be brought back into this chamber for that important analysis and obviously vote. And so I commend the committee. I thank everyone who has contributed, all of the Territorians who put forward their views, in no matter what manner or shape that was, it was important. And as the member for Fong Lim said, all of it was read, all of it was considered. I'd like to thank all of the obviously, there's a lot of work goes into this, well beyond the 5 members of the committee. There's the committee staff and all of the additional supports that have to wrap around with it. But this has been a very important process at the right time for a new government, and I'm not interested in the politicking on this. There is a process to go through on an issue that deserves and commands respect, and the CLP government is affording that respect by very virtue of the process that we are all in this chamber celebrating today.
Thank you, Chief Minister. Member for Mulka.
Thank you, Deputy Chair, or Deputy Speaker rather. I'd like to thank the committee and committee's staff for their work. This is a very large report that considers many important parts of the VAD story. There is also much discussion of a cross-cultural issue, and many Aboriginal voices are included in the report. I'd like to note that the committee did not come to the Mulka electorate or consult with Yolngu or Balanda committees of Northern Eastern Arnhem Land as part of this consultation process, and I am not sure why this is a decision made or was made. I am also not sure that the process of arriving in the community for one conversation is enough for such a complex cross-cultural topic. I also note that the committee had legal experts supporting this process, but they did not have a cultural advisors guiding the process. Mr. Deputy Speaker, the committee has recommended that a VAD legislation be drafted for Parliament, and the government have said they will introduce a bill early next year, that will create a pathway for a VAD. It is very important that a draft bill be made available for further consultations, because it is critical that the bill is appropriate for the cultural diversity of the Northern Territory. We must not lose sight of the unique makeup of the Northern Territory and the many cultures that live in the NT. The end of everyone's life and ceremonies at the time of their death and following their death is one of the last remaining areas where Yolngu our way, still defines what happens. Even when someone passes away in hospital, the hospitals understand that our ceremonies will be part of the process. When they still have a strong autonomy and decision-making power in the death of the burial of our people, and when When someone has been diagnosed by the doctor with a life-ending disease, we may not rely on the information as certain. We have seen people live for a lot longer than they were told, and we have seen people live when they are told they would die. When they are told when they would die. Sorry, my grandson is one of these people. Family came to Darwin when the life support was turned off, and we performed ceremony, and it was not his time to go. When we perform a ceremony for those who are sick and dying, it is a time when we are singing, and they singing them home to their country and their ancestors. I remember my grandfather dying, and songs are about, is it time for him to go, or can he be healed to stay? And singing for his totem is a healing process that may heal him to stay, or may help to create a pathway to go, especially in a peaceful way. There are elders there singing with the hope of healing him. In this process, someone may become better, or it may be there a time to go. We don't know, and we don't want to be the decision makers about that. Araluen Robyn doesn't have a pathway for ending your own life. While culture shifts and changes, voluntary assistance dying is not something that is comfortable for our people. And today, with an increased disease and death in our communities, death can be a time of confusion, blame, and fear. We have gone from being fit and healthy warriors with strong connection to country, health, diet, strong bodies, and strong minds, to people who often don't live in our ancestral countries, eat takeaway foods because we cannot hunt, and have a disease that we have not known before. We have the highest rates of avoidable deaths in the country, and disease such as rheumatic heart disease, diabetes, cancer, and strokes illnesses and ideas that have only been introduced in the last 5 decades. Through our cultural lens, when someone appears well and then suddenly dies, it is suspicious, and we do not trust how that person has died. Western medicine may explain that it was a heart attack or a stroke, but we do not have the perspective by itself. We have two cultural perspectives running at the same time. I am not here to say that one culture is right and one culture is wrong, but we need to understand that there are significant differences in the way illness and deaths may be viewed across entry communities. We want to, we have so many deaths happening in our communities. There is so much grief and sadness since the dry season began. I have been moving from one funeral to the next. Sadly, for my family, the body of one of my younger brothers have been sent to Darwin today. He died unexpectedly, and on the weekend, and I arrived at the Parliament House today because I have been driving through the night to get here, and and when I leave this Parliament next month, I will travel to 𝙏𝙀𝙈𝙀𝙀 for the funeral of another young brother, someone who I am very close to, who I grew up with, who also died suddenly after being flown to Darwin Hospital, and we will hold their funerals together. We are experiencing many deaths of the time. The people have fear for the clinic, of traveling to Darwin and to hospital, because we know when that happens, sometimes the person only comes home from their funeral. Say that again. The person only comes back for their funeral. When we have blame and suspicion when someone dies suddenly and unexpectedly. Mr. Deputy Speaker, every single time the government makes a law or policy, there should be a check and balances to see whether it is in infringement on our rights and local decision making and self-determination. And in this decision today, I am calling for the same thing. What is right for one community may not be right for the next. There is a risk that the introduction of a VAD in Yolngu communities will create fear, suspicion, and blame. Everyone I have spoken to who have said we don't want this for us or for our people, and I can see that written in the report today. So there are strong words from Alison Anderson, and in Papunya, she says, if people outside of us want it, they can have it, but not for us. But it is not for us, and I cannot stress that enough. And this is and what I am saying. This doesn't sit comfortably beside your room, but I am not saying that VAD is wrong, or VAD is wrong, or you can't do it. I am saying it doesn't fit easily with our culture. But I don't want to speak for the other clans or communities or cultures. If some people want this, when that is for them to make the choice. So this is where I believe this government needs to show that they can still do the breadth of the NT community. I can see that the committee have understood that the idea of VAD will be different across all of our communities, and there have been many different responses. I am pleased to see that drafting instructions does allow instructions or objections for a VAD, so that Aboriginal health centres do not have to provide VAD if they do not believe it is appropriate, and if the community do not want it. This is good to have options available for community health centres, but the health centres are not local governance for our communities. The clan leaders and elders are the governance of our communities. Elders, leaders, and representatives of all clans also need to be included in decision-making processes, because this is the way that we do businesses on our land. The real people that are elders and leaders out there, not people who are handpicked. Having VAD available in our communities may create problems, and we need to be able to have decision-making power about these problems. Already in the committee report, we have, and we can see some of these problems outlined. The example, it is possible that many Aboriginal interpreters and Aboriginal health workers may not want to participate in VAD discussions because it is not culturally appropriate. There is also a quote from the nurse stating The problem in community remotes is a perception that it is a white man's medication. We have come to kill people, so they will stand up against this because of their understanding that the nurse and
Member for Mulka, could you pause? Point of order, member for Arafura.
43, could I request an extension of time?
The question is, the member have an extension of time? All those in favour say aye. To the contrary, no. The ayes have it. Please continue, member for Mulka.
Thank you, Madam Speaker. And Madam Speaker, if a doctor is a nurse who offers to patients, they may become known as people who can kill and systems kill people. This theme comes out through the report many times. Many of the health professionals have identified that need to have trust and remote patients so that they will attend the clinic, take their medication, and feel safe to do so. Madam Speaker, there is also one issue raised by the report that highlights cross-cultural differences. Decision-making in Yolngu culture and in many Aboriginal culture is undertaken not just by an individual but by the broader family as well. The report talks about protection of the patient to ensure that they are being cured by family into the decision about V.A.D. This is important, but it must not come at the expense of limiting Aboriginal decision making. The drafting instructions have stated that the patient can request family members to be involved in the decision making if they voluntarily request it. But they may not know to do this and to ask and push for their cultural rights. I have come across this issue. This very area, for example, after in education or education for children protection, the workers meet with mom and dad, but they need to have much bigger meetings that include grandparents, aunties, and uncles, sometimes clan leaders, or a Yingiya who is a caretaker. must be there to make their decisions. This requirements a cross-cultural. This requires cross-cultural capacity on the part of the work that know how to bring all the family together to make sure all the right people are included in the process. Because otherwise conflict may occur if the right people have not been included. Madam Speaker, there need to be the trust and understanding that our systems work too. Governments and their departments have failed to trust Aboriginal people and our systems, and they always think that sorry, say that again. And they always think that they know what is best. When proper consultation hasn't happened, we can see the outcomes, and around us right now, lots of people in jail and people of early deaths and poverty. Our communities have our own laws and customs when it comes to the end of life, and we must be decision makers, and it comes so they become such significant laws. Madam Speaker, I also note that the comments of palliative care are at this described as woefully insufficient. The report outlines the decision of an expected increase in people accessing palliative care and many palliative care, which means that funding must include by 30%. This is very important for all of our communities. When people may not want to go for the voluntary assistant or V.A.D, but still want to die at home with dignity, and this bill should not be included without the funding commitment to palliative care and dying peacefully on country. Madam Speaker, it is very important that the diversity of the NT is understood. We are not the same as any other jurisdiction in Australia, and laws designed for the NT must reflect this. These drafting instructions do not go far enough in the protection for First Nations people's rights to self-determination. This is a change. This is a change I would like to see to any draft bill that comes forward, while the VAD law may bring welcome relief to some people, we need to make sure that that it is not cause that it does not cause any damage to others. These parties in the chamber need to stop arguing about who's correct. We want the parties to work together to bring good laws for everyone. It is not about playing games. It is about saving our lives. Thank you.
Thank you. Are there any other speakers? Member for Blain? Member for Arafura.
Thank you, Madam Speaker. I rise to contribute to this ministerial report. Before I begin, I would like to thank the Legal and Constitutional Affairs Committee and its chair, Member for Fong Lim, for the hard work travelling across the countryside, into territory, and bringing this subject, this taboo subject, to the communities. Madam Speaker, I must admit this topic is a difficult one for me, being Indigenous and also coming from a Catholic community and the Tiwi people. We have very strong Catholic presence on the Tiwi Island. I too travel around for ceremonial purposes and joined the member for Mulka out his way. I've got a personal experience with V.A.D. With my father's best friend passing earlier this year, and I went on that journey with my dad, and because his best friend chose to end his life with V.A.D. It wasn't the decision and the journey took about, and the discussion took about 4 months, because I was down there in January and I attended his funeral in April. There was no talk about it in January, but so my dad took him in under his wing at his place for 3 months, from February till the end of April. It all came about when there was cancer in the bone that happened, like it was a year before, and so Dad took him in, and the processes that took place, the legalities and the procedures, the discussions with family. It's a long process. So like I said, 3 months from when he made up his mind to when he chose to take the medication, or the medication on the day. On the day in April, in March, late March, my dad's best friend, he had prostate cancer that moved to the backbone, right to the spine. So on the day, he's living with my dad. He couldn't go to the toilet himself anymore, and he was a man with dignity, a man who worked all his life and supported his community, his family. So that process, my dad sat through, and it took from 10 a.m. in the morning till about 5 o'clock in the evening for that whole process to from start to finish. From taking the first vial, there's 3 sets, so I don't know how that'll look here, but so in saying that, I support this, but the key word here is voluntary. The issues that I face is my cultural obligation and my cultural representation. See, when we pass into the dream time, our story doesn't, as Indigenous people, does not end. Death is a part of life with us. So the responsibility of our journey goes to our Jungai and our family. This is where I spoke about it's a self decision, like personal decision for the individual. This is where it's complex amongst Indigenous culture, because everyone in Indigenous culture belong to different clan groups, different songlines. People are responsible for you, and that comes with the Dreamtime sort of journey as well. So it's a very complex issue, and also that Christian aspect that I've got. I think we need to definitely go out and do all the engagement we can. Education, engagement. It's definitely a scary topic, and people in Arnhem Land have no idea about this option or what's happening in interstate. And that's why I commend the committee for going out and starting that discussion. I can't imagine how you would have started this conversation when people came and sat down at the table or in their meetings. It must have been hard. Nobody likes talking about it, you know. But in the Western concept, I think it's definitely a option that needs to be undertaken or looked at, you know. So torn isn't the word, but it's definitely something that we need as an option for people who are really ill, as long as there's proper procedures, strict rules and guidelines in it. But it definitely doesn't match up to the cultural aspect of our community, especially in West Arnhem, Tiwi Islands, where other family members have responsibility for you, for your songlines, for your children, for your dreaming, and it's all about carrying you back to your country. I just want to finish up just around everyone deserves to die with dignity, but they need to provide a clear, strong, engagement, reassurances, and also what the member for Daly spoke about, also the facilities, the facilities out in our communities, and the engagement. It needs to happen. So I will support this, but thank you for listening.
No more speakers? Member for Johnston.
Thank you, Madam Speaker. So, Madam Speaker, here we are after 30 years, and I want to start off by sharing with the chamber what a person who I'll refer to as A said to me this morning. They rang me and they asked me to say in this chamber, it feels like we're finally getting closer, but I've run out of time for all this talk. Come on, everyone in this room. You people who have control over this intimate personal thing in my life which does not affect any of you. Come on. Let me make a choice which will not harm any of you. And Gavin and Belinda and Steve-O and many, many others suffering from terminal illnesses said to me, tell those people to come and talk to me before they make any decision. And please, I beg you, tell them to hurry up. So to all of you, to A, to Gavin, Belinda and Steve-O, and many others who I know are watching today, some of whom wanted to come into the chamber to hear what people were talking about today, but couldn't because they're too unwell and are watching online. I will pass your messages on. I have passed your messages on. From the moment I became the independent member for Johnston, community members raised voluntary assisted dying with me. In my second week in the electorate office, Maureen walked in and she said to me, "Don't bother coming back here if you don't do something about voluntary assisted dying." That was the beginning, and since then, the calls, the emails and the conversations haven't stopped. And at the beginning of this term of Parliament, we heard from the Chief Minister in the media and in this chamber that VAD was not a priority for the CLP, even though it was so clearly a priority for so many people in the Northern Territory. And in response to this, I moved a motion in May to implement the recommendations of the Voluntary Assisted Dying Report, Independent Expert Report, Advisory Panel Report, sorry. And I'm proud to say that in response to my motion advocating for VAD in the Northern Territory, the CLP government chose to move forward and take action, referring this issue to the LCAC, reflecting the overwhelming will of the people of the Northern Territory, and that is why we're here today. This shows what can be achieved when independent community-elected representatives like me listen to the community and bring the community's issues to the floor of our Parliament, so that even when political parties won't listen to what matters to people, like with VAD, community voices can be brought into the lawmaking process and Parliament can work together in the best interests of the community. So I am proud that I have raised this important issue in the chamber, and I'm grateful to the government and to the opposition for committing to this vital matter that will make a real difference to the lives of so many. Madam Speaker, I often speak about Parliament working together to create good laws for the Northern Territory, and this is exactly what I mean. And I echo the member for Fong Lim saying that the hope is now that we will all work together. Let's not waste the work that has been done over and over again. I was also really encouraged at the beginning of this process that the government seemed to have taken on board the concerns that have been raised throughout their term regarding the lack of consultation in the drafting of bills that have been brought to this Parliament. And we've heard in this chamber about the sometimes Herculean efforts of the committee and staff to conduct this consultation, and the significant ethical concerns of conducting a consultation on such a complex issue in such a truncated time frame. We also heard the harm that inadequate consultation can cause on such complex issues. Everyone in this chamber has heard about the problems when we don't do consultation properly, when we don't do it ethically. And we must make sure that from now on, as we develop this law and other laws, we have real and not rubber-stamped gammon consultation. So this consultation was deeply imperfect, but it demonstrated a commitment to listening to Aboriginal people. This should be the standard for all legislation in this Parliament, and it has been absent from every other bill this government has passed that directly impacts on Aboriginal people, on their sacred sites, on their water rights, on youth justice, on our environment. So I look forward to seeing that same commitment reflected in other policy areas and other bills that come before this House. We know that there's a lot of theory in this debate, but it's not just a theoretical debate. It's not just about politics. It's about real people and real families and real suffering. It's about terminally ill Territorians who are asking us, pleading with us, to give them back a basic right, the right to die with dignity and on their own terms. Madam Speaker, this report represents more than policy recommendations or legal frameworks. I know because I've heard from many people that it represents hope for Territorians who've been waiting far too long for this right to be restored. I want to share the voices of 3 Territorians who've asked me to speak on their behalf tonight. The first is Belinda, who I don't know but came up to me outside Woolworths one day to tell me her story. Belinda is living with stage 4 breast cancer. She said to me, "I want to have the same equity of access that other people in other states have, to voluntarily exercise that right if I choose. I was here when the Northern Territory passed the Euthanasia Bill in the 1990s, and I was so proud that we were leading the world. That was repealed by people who didn't live here is a travesty that needs to be corrected. We need to allow terminally ill people and their loved ones to be spared the experience of an agonising death or witnessing someone's agonising death. I fervently hope we could take our place amongst the more humane jurisdictions that already have this legislation. Belinda told me simply, I want to know that VAD is there if I need it. And then there's Gavin, who I know some of you in this chamber have met. I talked about Gavin in this parliament in May, and he came to see me at the markets this weekend. He's a wonderful man who's lived in the Northern Territory for more than 50 years. He's facing a terminal cancer diagnosis and has been told that he will have a very painful death. He wants to die on his own terms in this place to which he has contributed so much. When I asked Gavin if there was anything he wanted to share with us in this chamber, his answer was simple. He said, it is simple. It's kindness and compassion. Kindness and compassion. That's what Gavin is asking for, not complex legal arguments, not political debates, just basic human kindness and compassion at the end of his life. And then there's Steve-O, who I also had the privilege of meeting recently. Steve-O's facing a terminal illness, and he spoke to me with remarkable clarity about what voluntary assisted dying means to him. He said, I don't want to die, but I'm ready to die. I want you to tell people that I have a lethal dose of medication left over from when I was at home. Anytime I could choose to take those pills, but that would be suicide, and I am against that. Madam Speaker, these words cut to the heart of why we're here. Steve-O doesn't want to die by suicide. He doesn't want to die alone, in fear, or in a way that brings shame or trauma to his family. He wants to die with dignity and with his loved ones around him under proper medical care and on his own terms. That is not suicide, that is compassion. And the committee's report explicitly states that VAD is not suicide and that this will be clearly reflected in the legislation. Steve-O spoke to me about religion, and he spoke to me about mercy. He said mercy, which is at the heart of so many religions, is about do unto others as you would have them do unto you. There's no need to fear death if you are able to make the choice, to have the opportunity to say goodbye properly to the people that love and care for you, to be able to say, he was a great man who died with dignity under his own steam. There is great inner peace you can find from having your own choice. He asked me to think about a soldier in the field on his last legs, all shot up, with injuries he can't recover from. You know you're going to die, and you ask your mate to please leave you with a gun and a bullet. In that moment, Steve-O said, we would understand mercy, we would understand choice, we would understand dignity. Why, he asked, can we not extend that same understanding to Territorians dying at home? Steve-O described his illness as a monster growing inside him. He said, the only way to defeat it is to die. That is how I win. Right now, I am living like a prisoner with the glass of water just out of reach. The fear is not in the pain, but in hanging on too long. Having this in my body is something I can only defeat by dying. Then I win the battle, and I defeat the monster. Madam Speaker, Steve-O is not giving up. He is not depressed. He is facing his reality with courage and asking us for one thing, the right to choose when enough is enough, the right to defeat the monster on his own terms, the right to win his final battle with dignity. And then there is A, who this morning reminded me that the people who have control over this intimate personal thing in his life, the people it does not affect, are making him wait. He's asking for a choice that will not harm any of us. And as he said, he has run out of time for all of this talk. Belinda, Gavin, A and Steve-O are not alone. The committee heard from people, and we heard today, all across the Northern Territory. It consulted in remote and regional communities. It heard from families who've watched loved ones suffer. It heard from health professionals. It heard from people who also had concerns about this bill. And it developed a framework that addressed those concerns with strong safeguards while ensuring access for those who need it. So that brings me to what we're speaking about today, the Legal and Constitutional Affairs Committee's report on voluntary assisted dying. We know we still have a way to go. The law needs to be drafted, to be consulted on, to be debated and to be voted on. So yes, we are moving forward and we do need to do it as clearly and carefully as we can. But I want to first of all express my great thanks to the committee members and the incredibly hard-working committee staff for their thorough and careful work in consulting with Territorians across our vast territory on this critical issue. The 254 or 320, including the drafting instructions page report, aims to be comprehensive and thoughtful and respectful of the unique nature of the Northern Territory. We've heard about the 86 recommendations and how they've been developed in conjunction with legal advice. We know that it represents months of consultation, listening and careful consideration of how to implement VAD safely and equitably in the conditions of the Northern Territory. And I also thank the Chair for going through the report in such detail this morning and this afternoon, and for other committee members adding to that explanation and providing more context for the report, highlighting the issues that they had wrestled with and their conclusions and their recommendations. The report charts a clear path forward, one that's uniquely suited to our territory while drawing on the experience of every other Australian jurisdiction that has successfully implemented VAD. It charts a path which attempts to balance people's right to diet with dignity, with cultural safety, with resource implications, and with access to appropriate other care. Madam Speaker, we need to be clear about what comes next. In this chamber, we need to see the actual proposed legislation before we debate and vote on it, because detail is fundamentally important in a bill like this. And we must ensure that the drafting of the law truly reflects the spirit and the substance of these recommendations. We need to make sure that Aboriginal voices are deeply and properly listened to, not just consulted with, but genuinely heard and responded to. The committee has recommended co-design with Aboriginal people, and this must be meaningful and ongoing. Not in the way that this committee worked, despite their best efforts. The deeply problematic way that we have heard was inadequate and caused harm. We need to listen to and work with leaders, including the leaders in this chamber, when they speak on behalf of their communities, who bring invaluable perspectives to how this law will impact on their people. And we know we need to make sure that this law truly addresses the specifics of the Northern Territory, our remoteness, our health challenges and our cultural complexities. We know and we've heard that this cannot just be a copy and paste job from another jurisdiction, and the committee has gladly recognised this, but we must hold the government to account to ensure that the final legislation reflects these unique circumstances. We know that every other state and territory has implemented safe, compassionate, voluntary assisted dying laws, and this report shows how we can do the same in a way that's uniquely suited to us, and I greatly look forward to seeing the legislation when it's drafted. Madam Speaker, as Belinda reminded us, we were once world leaders in this space. We led with courage and compassion in the 1990s under a CLP government. That right was taken away by people who didn't live here and who didn't represent us. Now we have the opportunity to restore it and to once again take our place amongst all the other humane jurisdictions in Australia and give Territorians the same rights as every other Australian. We know this committee has worked hard, they've listened, they've consulted to the best of their ability, they've developed a comprehensive framework and they've provided a clear pathway forward, but we must walk it carefully, thoughtfully, and we must walk it together. For Belinda, who remembers when we led the world, for Gavin, who asked simply for kindness and compassion, for Steve-O, who wants to defeat the monster on his own terms, and for A, who has run out of time for talk. For all the Territorians watching who can't be here because they are too unwell, this is for you. In the end, is what Gavin said, kindness and compassion. We know this committee has done hard work with care and consultation, and I agree with the member for Mulka when he says, this bill will bring welcome relief to some, but we need to also make sure that it does not cause damage. We need to work together to make good laws for everyone. We must carry that same spirit of the work of the committee and the spirit of working together for all Territorians into the drafting of the legislation and the bringing of it into this chamber. We know that people are waiting. We know that people are suffering. We must get this right and we must do it without delay. Thank you, Madam Speaker.
Member for Blain.
Thank you, Madam Speaker. What a lot to cover off on. What a lot to cover off on. So, I'd like to begin my contribution today by summarising the phrase that really captured the inquiry for those members of the LCAC. Help and choice to finish up well. So, as we went out to community and we consulted and we talked to Territorians, that was the phrase that kept coming back because I think, as the member for Fong Lim said in his contribution, when we went out and we said, oh, VAD, at first people said, oh, VAD, that sounds like bad. Are you talking about something bad? And we said, no, voluntary assisted dying. And they said, well, what's that? And then we had to explain it. And they said, oh, so like help to finish up. Yeah, and you've got to have choice. And we ended up landing on help and choice to finish up well. And I would have liked that to be the subtitle of the report. I'd like to start by saying thank you to the committee members, thank you to the chair for his power of work and late nights and weekends, reading everything. I'd probably say that he's probably the member of the committee who read the most of the submissions, if not all of them. I did my best. I think, I know the member for Wanguri made her way through pretty much all of the written submissions. I got through as many as I could, but not all of them, I'm sorry to say. There's over 400, and some of them were quite lengthy. Thank you to the member for Nightcliff. Thank you to the member for Daly. I think it was a very interesting process, being on a bipartisan committee investigating such a weighty topic, but we all pulled together and we delivered. Thank you to the Secretariat. We gave them an impossible task and they did it. So, I hope that in years to come they'll look back on this inquiry and just, be proud that they were a part of this report that will lead to the last, hopefully lead to the last jurisdiction in Australia legislating VAD. Thank you to all the people who made submissions, gave us their time, invited us to their communities and shared their stories to us. It was incredibly heartwarming, the communities that we went to, where people were willing to talk to us and share incredibly personal stories, incredibly personal things about themselves, and we really appreciate that. And I'd also like to thank the Bush members who facilitated us going out into their electorates. Member for Arnhem, member for Berkeley, and the member for Gwoja, without whom I think we probably would have faced a bit more difficulty getting out bush. So I thank you for your assistance in helping us to go out and connecting us with people who wanted to share their stories. So, themes of the report. So really, it comes down to voluntary, choice, and holding opposing views in tension. So VAD wouldn't work if it wasn't voluntary. If there was any compulsion to it, it would be anathema. But because it's something that the people who want to use it voluntarily choose it, and everyone else who doesn't want to use it doesn't have to. It doesn't have to bother anyone except for the people who are directly affected, who are suffering. I'm just conscious that I only have a limited amount of time. So another tension that was held in the report was the timeline. We were constantly caught in the tension between needing more time to really do justice to the topic, and I think we all would have loved to have more time to write a more fulsome report and consult more broadly, but at the same time we were bombarded with people who were saying, just get it done, just get it done. And the evidence before us was that there would be a significant implementation period once the legislation was passed. So there was no... so I hear the contribution of the other members today, and we did have a lot of robust discussions in committee about the timeline, but the longer that we took on the committee, the longer it would take and the more that people would suffer without being able to access VAD. So we did the best report we could in the time we had. And from my experience, I don't think any of the recommendations would have changed. I think we probably would have just gone to more places and talked to more people and had more transcripts. The testimony that we received was broadly consistent everywhere we went, and I'll get to that in a sec. Another point that was held in tension was people who opposed VAD on moral grounds versus the people who were suffering who wanted it. So the people who it directly impacted wanted VAD, and some people who I'll come to later were opposed to it for all, and we needed to hold that in tension and weigh up the options. Conscientious objection. One of the topics that we really wrestled with on the committee was the right of people to not participate in VAD, so that to prevent them from forcing them to offend their conscience, to make sure there were strong protections for people to not participate in VAD if they didn't want to, and I'll come to that later. So our recommendations. So we stood in the shadow of the 2024 report, and in my opinion, it was appropriate for this committee to re-examine their recommendations, given that that report was commissioned by a previous assembly, and it is this assembly here that will be legislating VAD. So it was completely appropriate to re-examine that report and to give that work to a committee to examine, to inquire, and to report back. And we substantiated some of their findings, and we also departed from some of their findings as well. And I think on balance, the end result will be much better for the work of this committee. So we recommended that the NT legislate VAD in a way that respects our unique context, demographics, and geography. So what would VAD look like in the NT if the report was legislated as it stands? So you would have a centralised navigator service, which are the people who are able to connect you with health practitioners and guide you through the process. Importantly, they are not medical practitioners themselves. They can't sign off on anything. They are just navigators. They are able to go into conscientiously objecting organisations when health practitioners are not. You would have a centralised accreditation service. Any health practitioner who wanted to participate in VAD would need to be accredited by NT Health according to policies drawn up by the CEO, and that accreditation would need to be centralised. There would also be a centralised pharmacy, because substances involved are extremely dangerous if misused, so they need to be carefully controlled. Where it would be a decentralised service delivery by the doctors who are already treating people. So if you're suffering from a terminal illness and you have your local GP and your specialist who's coordinating your chemo and your treatment, they could potentially be the doctors who sign off on your VAD consultations, which we thought was appropriate because they would be the doctors that you would be dealing with the most. We didn't want a fly-in, fly-out service where some bloke that you don't, or some person that you don't know, you haven't had anything to do with, and they're a full-time VAD person, and they just fly in, and you have to go through your whole illness and treatment all over again and re-traumatise someone who's already suffering. We didn't think that was appropriate. And we also, I'll come to this in a bit, but we also didn't want to take doctors away from treating people and saving lives and to put them full-time and I'll try to put this nicely, in delivering a VAD service that will result in the ending of life. We are not so well off in the Territory that we can afford to take doctors away from saving lives for that. So we very strongly landed on a decentralised service of delivery in terms of the health practitioners who will be signing off. That VAD in the Territory would be justiciable. So there's a whole bunch of things around eligibility and the process. And if there's a problem in that process, people have the right to appeal to the tribunal and to appeal a decision from that tribunal to the Supreme Court. So there's an appropriate oversight of the courts of the process. There's a review board to monitor each and every application of V.A.D. and to report on the process and advise the coroner if need be. The review board is a fairly standard practice around the rest of the country, and it's notably a feature that was absent from the original Rights of the Terminally Ill Act, and potentially could be one of the features that was so objectionable the federal government chose to override our rights. Eligibility. If it was legislated according to the report, who would be able to use V.A.D.? You must be at least 18 years old. Children are excluded. You must be of sound mind, able to give informed consent. And that has some other consequences. You must be suffering and dying of a disease that is progressive, incurable, and terminal. There are a lot of arguments against V.A.D. that go into the slippery slope argument about, oh, well, you know, there's places overseas where this happens and that happens. And so for us, a red line that we drew in terms of the committee and the report was that you had to have a terminal illness. Now, at the same time, we didn't discriminate against disability. So you can access V.A.D. if you have a disability. For example, now that could be mental, it could be physical, it could be neurological, but it cannot be your terminal diagnosis. And the disability must not be so extreme as to remove your ability to give informed consent. So that was, there were a number of submissions that spoke to that, and the key principle that we stuck to was that a person had to be able to give informed consent. And if they could, then disability should not be a reason for them to not be able to access VAD. Similarly, mental illness, we did receive some testimony, but unfortunately it'll probably be redacted in the final version. We did receive a submission that mental illness should be considered, but the committee could not accept that because it's not a terminal prognosis by itself, as it undermines informed consent. Now, we did receive a number of submissions around neurological diseases like dementia and Alzheimer's, and similarly the committee drew a red line around those for the same reason that they undermine informed consent. So we decided that neurological diseases such as dementia and Alzheimer's cannot be the prognosis, as by the time there's a diagnosis of a terminal nature, then the patient is likely no longer of a sound mind. The flow would be, if someone wanted to access V.A.D., they would likely have a discussion with their doctor. They may have a discussion with the VAD Navigator service. They would make a formal written request. They would have 2 doctors sign off on that request. There's a cooling off period in there. And once that process is done, the administration would either be at home by themselves, and that's our preferred model. Our preferred model, and it's quite popular in other states, would be that if someone was accessing VAD, they would not do it at a health facility. They would do it at another location, likely their home, surrounded by their loved ones, where they could, say everything that needs to be said, celebrate in a way that's appropriate to them, and then administer the substance and pass away in peace. The other alternative was administration by a doctor, which is medically preferred because you have better control over the substance, but that brings in complications around the location, which I'll get to in a sec. Cultural safety was a very important thing that came up in our consultation, and I'll get to the reasons for the points I'm about to make, but we recommended that VAD primarily not occur in health facilities. So that means clinics, hospitals. We recommend that at least initially it occur elsewhere. And the reason for that is cultural safety around Indigenous peoples. So there were a lot of issues of blame, misappropriation of blame, misunderstanding of causes of death, and there was a lot of concern that if there were health practitioners who participated in VAD in a health facility and people came to know that and misunderstood the circumstances, that blame might be attributed and then the safety of those practitioners might be in doubt. So for the avoidance of all doubt, doctors who participate in VAD probably would need to be firewalled off from serving on communities or in areas where people who might be threatened in terms of cultural safety would be treated. So what did we find? So the member for Arafura made a good point. How on earth do we get people talking about this sensitive topic? So each session would start with a standard welcome and a briefing, and then we would say, well, tell us about healthcare in this community. Tell us, what's the clinic like? What happens when people get sick? Which will lead into a discussion about healthcare, and if people get sick, they have to be medi-flighted out. And from there, we generally transition into, well, what does finishing up look like on community? When people finish up, what does that look like? And there would be discussions around that. And they would say, well, what does it look like to finish up well? And then we'd introduce V.A.D. and then ask them what they thought about it. Now, the consistent evidence that we found across, I would say, all the communities we went to was that the evidence was that people said, not for us, but if other people want to use it, that's their choice. And that was a really important finding for the committee, that if someone in Palmerston or Wanguri or Fanny Bay or Breitling or Araluen, if someone that they didn't know, they weren't connected to, wanted to use VAD, that wouldn't offend the sensibilities of people in community. They were very clear that it wasn't appropriate in their culture and they had no desire to use it themselves. But if someone elsewhere in the territory who they didn't know and wasn't connected to them wanted to use it, then that was their choice. And we come back to VAD being voluntary, being choice-driven, focus on the people, allowing the people who need it and want it to have it, and other people not needing to be bothered by it. There was a lot of findings about the importance of finishing up on country and returning to country. Pretty much everywhere we went, people said that when they were getting towards the end times and they knew that they were going to be finishing up, they really, really wanted to go back to their country, their community or their homelands and finish up there. Now that introduces a lot of difficulties around transport, but also withdrawal from treatment. We heard a lot of evidence around withdrawing from treatment, and that was a new thing for a lot of us on the committee, the idea that people would voluntarily withdraw from treatment to return home to the place that they know and love and where their loved ones are, knowing that it would likely result in their end.
Extension. Member for Karama.
Madam Speaker, can I seek an extension for the Speaker, please?
Is an extension granted? All those in favour say aye. To the contrary,
Thank
no.
you, everyone.
An extension is granted. Please
All right.
continue, Member for Blain.
Okay. And withdrawal from treatment was often brought up, that when people were facing the end for example, people in end-stage renal failure, when dialysis wasn't working, they would voluntarily withdraw from treatment, come home, go out on, well, the preference was that they would come home, go on country, and all the family would come in, and everyone would come together, and then, you know, and ideally, the ideal situation would be if they had a clinic nearby or health professionals who could give them pain relief and somewhere comfortable to lie, and then all the culturally appropriate things would happen, and then they would pass away in due time as a result of their illness. That was consistently reported as something that was very important to people on community. Another finding we made, and I personally will admit that as someone who grew up in the Territory around Indigenous people, I didn't realise the extent of this until this inquiry. The extent to which kinship decision-making by consensus is so important. The role of the Dhe'ung'ai. I thank the member for Mulka who brought up before, and the member for Arafura who also mentioned the Dhe'ung'ai. That was mentioned many times in Numbulwar and Nuka, and there were similar concepts communicated to us in Tennant Creek and Papanya. Health facilities, when we received evidence from medical staff, they said that they worked hard to promote themselves as places of healing, not death. Because although death does happen there, if people think that, you know, going to Katherine Hospital or Alice Springs Hospital or Tennant Creek Hospital from a community, if they think people die there, then that will cause hesitancy in accessing health services. So they work hard to promote themselves as places of healing. What else did we find? Well, we had many, many touching, heartfelt stories of people's loved ones in their final times. Too many to share here. The written submissions, there was an incredible variety of written submissions. Some detailed, some one-liner, for and against both NT and interstate. When the committee weighed those written submissions, we held the submissions of Territorians to a higher weight than the submissions of people from interstate. And the weight was definitely on the side of people wanting to see VAD happen. A lot of people, what we found throughout the inquiry was there are a lot of people who are passionate to see VAD in the NT. There are a lot of people who would not use VAD themselves, but their conscience is not offended if someone else where in the Territory uses it. There are a few people who believe that no one at all should have VAD, and we really only received one submission to that effect. On balance, the rest of the submissions were either enthusiastically in favour or that their conscience would not be offended if people were able to access it. So, one interesting thing, in our written evidence, testimonial and personal anecdote, we found that people who had a personal experience of a loved one passing away and suffering in the sort of circumstances that VAD is designed to address, people who had a personal experience with a loved one going through that generally changed their minds and were supportive of VAD. And we had a few pieces of evidence where someone was initially opposed, went through that experience and then changed their mind and subsequently supported V.A.D. So that was a valuable piece of evidence in deciding to support the recommendation to legislate VAD. We had evidence given to the committee that statistically about 1% of deaths in a state would use V.A.D. There's about 1,200 deaths a year as a ballpark in the NT. We have a 30% roughly Indigenous population. The evidence was that they would probably not choose to use V.A.D. So of 800 people, about 1% of that is 8. The evidence that we had from other jurisdictions was that there's somewhat a funnel. So if of 10 people who start the process for VAD, roughly a third will pull out, a third will pass away from the illness, and a third will continue through. So we're looking at about 8 people a year who might use VAD in a fully fledged functioning system. So that drove a lot of our decision making. The NT cannot afford to have a large, bureaucratic, centralised, expensive VAD apparatus. We wanted to have a simple, lightweight model that imposes the minimum cost while allowing access to the people who really need it. The 2024 did a great job surveying the urban centres, and we accepted their recommendation that the majority of people in urban centres wanted VAD. Then the focus became of the people not consulted, would VAD offend their conscience to the point that it should continue to be excluded? So that was the focus of our remote consultation. Where we departed from the 2024 report. So we recommended a decentralised community model as opposed to the centralised model. And that's primarily because we could not, in good conscience, recommend taking doctors away from saving lives to administer VAD for 8 people a year. So we wanted a model where people could use the doctors that were already treating them. We recommended no timeline, which is basically because of the difficulty of prognosis of time of death. We don't want doctors fudging their prognoses. We felt that the requirement that the person be genuinely dying and suffering was enough of a protection for someone who actually wanted to access VAD. So we didn't see a need for a timeline. However, because of the no timeline, we introduced a residency requirement. So I implore my colleagues, when a bill comes to the House, if a time frame to death is introduced, then we should remove the NT residency requirement, given that all other jurisdictions currently have VAD. And it was only there to prevent VAD tourism. Conscientious objection. I won't be able to do this credit. One of the revolutionary things that we introduced was we pushed conscientious objection to its limits so that organisations have the right to object. This was a combination of the ability for Indigenous communities via their health organisations to be able to put their hand on their heart and say, we are a VAD-free zone. There's no VAD happening here if they choose to opt out of VAD. And also, we received evidence from ARCs who come under Uniting Care that their board would not accept VAD on their premises, and so we supported their right to be able to opt out of VAD. And we have a number of protections in the report. I'll try and go faster. We introduced video authorisation for people who physically aren't able to sign. The review board, there were some internal discussions about whether the CHO should be the chair, but I'll leave to the government the best composition of the review board, so long as it has its powers to fulfil its function. There were some things we could have fleshed out more. The member for Gwoja said that we should have consulted with everyone. I think he confused consultation with education. So in the first interim report, we wrote to everyone. And for the record, for Hansard, I'm holding up multiple pages from the first interim report, and you can go and have a look. We wrote to everyone, all the land councils, AMSANT, health organisations, everyone we could find. We wrote to them all and said, please make a submission. We'd like to come out and talk to you. Please, can we come? And we went to the places who agreed. So we would have loved to go to all those places that the member for Gwoja named, but they didn't accept to have us come, and that's their right. So we didn't go. It's not because we didn't want to. We had time. We had spare capacity. They didn't want us to come, so we didn't go. So things that didn't make it into the report. Interstate specialists will need to be accredited as NT VAD practitioners so that locums and people travelling interstate for care will be able to use those specialists for their sign-off. We had evidence from the Alice Springs palliative care team that doctors have a bias towards treatment, even in the face of terminal illness, and that it would be a culture shift for them to consider recommending withdrawal from treatment. We should have recommended that NT Health take a more holistic view of end of life and consider updating training around end of life discussions to ensure that patients are more aware of that option. I'll skip forward to my wrap-up. The objections of the few who think that no one should access VAD and the large number of people who personally don't want it should not prevent the small number of people who are suffering directly from accessing the service. In many areas, I believe that if we ban access to a service, we create black markets in the thing that is banned. We should have a careful, controlled, compassionate, well-regulated option so that dignity can be maintained at end of life. My personal vote on this bill will be determined by the response of my electorate. Some in my electorate are deeply opposed to VAD, but so far I've been overwhelmed by the people reaching out to say they support VAD and they want me to vote for it. Thank you.
Leader of the Opposition.
Madam Speaker, and I do thank the government for allowing the opportunity for all members of the Parliament to speak to this very important report. I know that originally there was the speak of this particular topic not being a priority in this term, and I'm sure that the pressure of clearly hearing from directly the community in it being an important issue for all members of Parliament to consider. I do thank the government for the opportunity today, but also that acknowledge that they have listened to the community and have decided to take some action, which is welcomed from our team, as we've spoken already about this from my teammates, Madam Speaker. We know that the CLP government has finally realised that Territorians do deserve the same end-of-life options as other Australians. I've listened very carefully to all of the contributions today in the House. Interesting, of course, noting when people have changed their original decisions or thoughts on this particular topic to completely to the other deciding to something that's completely different to what they originally entered in thinking around the debate. So I thank members for their honesty. I think it shows Territorians that we can all learn and grow in the roles and the responsibilities we have to represent the people of the Northern Territory in this very important place of the Northern Territory Parliament. We know that some Territorians have been fighting and continue to fight since 1995 to maintain this right that was the first in the world recognised. And we've heard the 30 years, Mr Deputy Speaker, that's how long Territorians have continued to wait to access this choice. So it is an important time to not just listen, but to act. Mr Deputy Speaker, this is about giving Territorians the right to choose what end-of-life care should look like for them. Because right now, as we know, many contributors to the debate on this report have highlighted the Northern Territory is the only jurisdiction in Australia without this choice. It is an incredibly personal decision for every single person, depending on their circumstances, their beliefs, their values, family considerations, their cultural background, and many other factors. And it is not for everyone, and that is fair enough. It is about providing an option for those who may wish to take it. And it is hard to believe that we are the only jurisdiction in the country without this option, when once upon a time, as we all know, the Northern Territory was a global pioneer when it came to voluntary assisted dying, formerly referred to as euthanasia. And we've heard the very detailed background by the member for Fong Lim today in his contribution as the chair of the committee, and thank him for being so robust in that work, because this is such an important issue for the Territory. Mr Deputy Speaker, it was the proud political legacy of the then CLP Chief Minister Marshall Perrin, who believed so strongly in the rights of Territorians to voluntarily end their life if they choose, that he brought forward a private member's bill, the Rights of the Terminally Ill Act. He was a politician of maturity and principles, who recognised the importance of giving Territorians this final crucial bit of control over their own lives. Mr Perrin is still a passionate advocate all these years later. And only 4 people enduring terminal illnesses used the law in the Territory to end their lives before the federal government stepped in, intervened and overturned the Territory's legislation in 1997. Territorians have since seen every other jurisdiction introduce their own voluntary assisted dying legislation in support of terminally ill people in their jurisdictions to make their choice, their own choice, about ending their lives. Mr. Deputy Speaker, it took until 2022 for the Australian Parliament to pass Restoring Rights, Territory Rights Bill, allowing both the Northern Territory and the Australian Capital Territory to legislate, should they choose to, on voluntary assisted dying once again. Not only just 3 years ago, Mr. Deputy Speaker. It was largely thanks to the strong advocacy of the member for Solomon, Luke Gosling, the member for Yingiya, Marion Scrimgeour, the NT Labor Senator, Mullandiri McCarthy, and I acknowledge the former CLP Northern Territory Senator, Sam McMahon. The 4 federal members of the Northern Territory did what everyone wants this parliament to do now, to work in a bipartisan way for the benefit of the Territory. That advocacy, Mr. Deputy Speaker, that hard work paid off when the former Labor government was able to recommence a conversation with the Northern Territory community about voluntary assisted dying. So, Mr. Deputy Speaker, it is quite disrespectful that earlier today, in the question time, the Chief Minister took a whack at me as the Leader of the Opposition and said, "What did I do with my time? Why are you just bringing it up now?" Well, I was the former Attorney General of the former Labor government, and I worked with the ACT Attorney General at the time, Mr. Deputy Speaker, in pushing for that restoration of the Territory Rights Bill. Then we did see that come to fruition when, as I said, at the end of 2022, the rights for both ACT and the Northern Territory were restored when it comes to the ability to legislate on this very important topic for Territorians in both the 2 jurisdictions. So I did spend my time advocating in my former role. It wasn't just a suddenly I've started to do it as the Leader of the Opposition. This is many years in the making, Mr. Deputy Speaker. Our former Labor government did introduce the independent expert panel, which was appointed to be led by co-chairs Duncan McConnell and Vicky O'Halloran, who did an incredible job of consulting with many, many individuals and organisations and councils across the Northern Territory before delivering their well-considered report in July of 2024. It was incredibly disheartening to see that this work was cast aside come the new government of the CLP, and that V.A.D. was openly said it was not going to be a priority on behalf of Territorians. That did break the hearts of many Territorians, Mr. Deputy Speaker, but thankfully Territorians continued to fight on, and they have continued to advocate for restoring voluntary assisted dying legislation here in the Territory, and they have done so for 3 decades, Mr. Deputy Speaker. Eventually, the CLP government has been forced to do something, and they initially chose to try and further delay any introduction of a bill around voluntary assisted dying by sending it to the Legal and Constitutional Affairs Committee, LCAC, as we all use the acronym, to try and get a rushed and very limited consultation process out the door. And in doing so, the CLP have denied Territorians the ability to contribute and engage across many places that, unfortunately, due to the time restrictions, were unable to provide their input into this very important report that was commissioned by the Attorney General, Marie-Clare Boothby. But the report has been brought back, and I recognise with all of the comments and the contributions the huge amount of work that has been undertaken by committee members and the committee secretariat within the Department of Legislative Assembly, and I thank all of those committee members and of course the DLA staff for their phenomenal work in producing the report that has been tabled today. The work around consultation and some of the gaps have already been spoken about, so I will not repeat those failures. But in meaning no disrespect at this point, Mr. Deputy Speaker, because I know that work has been meaningful and it has provided some of the same insights as the independent report that was tabled in 2024 by the independent expert panel, Mr. Deputy Speaker. And unfortunately, because of these very similar findings, it seems to me, looking from the outside, that the work of the LCAC was set up initially to fail, and thank goodness it didn't, Mr. Deputy Speaker. And that is a very cynical point that I must point out, Mr. Deputy Speaker, that it did look like a political ploy of the CLP to ignore that very comprehensive independent report from a year ago that was freely, openly and readily available to all members of Parliament, but particularly to the government, to try and delay and to further prolong this important issue. And as I said last time, speaking about voluntary assisted dying in the House, Mr. Deputy Speaker, and this feeble attempt to delay this important issue for Territorians, there has been a lack of leadership by the government on this very issue. And it is no doubt that Territorians have been able to observe this quite openly. But the weight of community pressure has succeeded, and well done to every Territorian who has made their voice heard on this very critical matter, regardless of if you were for or against voluntary assisted dying personally. This is such an important issue to listen to the voices of Territorians. So thank you, Territorians, you have done it. You have forced the CLP government to act on this critical issue that matters to you. Mr. Deputy Speaker, in May this year, when it looked like the CLP government was going to continue to delay the consideration of voluntary assisted dying, I made the commitment, the public commitment, Mr. Deputy Speaker, that I would begin drafting a private member's bill on behalf of Territorians. And that is exactly what I did, Mr. Deputy Speaker. And at the time, it is because I had no faith that the CLP government was going to come through and do this work themselves. So I set about and engaged an independent drafter to be able to produce a draft bill on voluntary assisted dying. Like other Territorians, I have been pleased, pleasantly surprised actually, but pleased nonetheless, when the CLP government did agree to begin drafting legislation when the report was publicly spoken about by the Chair. But I did remain, and I continue, unfortunately, remain sceptical without knowing a definite time frame from the government of how much this is a priority for them. They certainly have not openly spoken about a definitive time frame, and reminding Territorians that the government does control the legislative agenda of the Parliament. So it is up to the government to provide that detail and when their bill will be ready. The good news is, Mr. Deputy Speaker, I have done some of that hard work for them, commissioned and finalised a draft voluntary assisted dying bill that I believe is fit for purpose for the Northern Territory. I did release that draft bill to the community yesterday for consideration and sent it directly to the Chief Minister, Leah Finocchiaro, and the Attorney General, Marie-Clare Boothby, for their consideration to work, Mr. Deputy Speaker. I have offered it to them in good faith to use for the basis of the government's bill, that they have the resources to consult with widely on the words, and we do know this place, words do matter. In this place, it absolutely does. Every single word and every placement of that word matters when it comes to territory law. And it is a draft bill, Mr. Deputy Speaker. It may require a few minor tweaks depending on community feedback, expert advice from each of the government departments, which of course I do not have access to as an opposition member, at the work that provides a very strong basis to move forward together as a parliament, not as the CLP, not as the Labor team, not as a crossbench, but together as a parliament. And I have happily handed it over to the government, Mr. Deputy Speaker, and I have done so on the basis that this means the CLP government can now move quickly in providing a fulsome bill with all of the government resources behind it to provide that to the Parliament. So, Mr. Deputy Speaker, the audacity of the Chief Minister to say that this complex and professional piece of work that an expert independent drafter is the back of a beer coaster is absolutely not a reflection of what leadership should be, and it has shown the true colours of the CLP leader, the Chief Minister, Finocchiaro. When it comes to the true meaning of bipartisan support and work, we know that Territorians do not want to see politicians fighting about an issue or a topic that is so above and beyond politics. So why not be able to swallow maybe a little bit of pride to say, actually, there could be some merit in it. The opposition leader has put forward a constructive way for the parliament to move forward on this issue without the politics there, not the red versus the orange or any of that crap, putting together something that is going to be meaningful and lead the way and actually make a difference for Territorians in an issue and a subject that deserves and demands respect when we're talking about the dignity of Territorians and their end-of-life choice. Mr Deputy Speaker, the bill can be introduced and brought before the House before the end of the year for that very important conscious vote. And this is work that has taken several months to provide. This is work that has been done by an expert drafter, an independent drafter, because unfortunately wasn't able to access a drafter within the Territory and through the Parliamentary Council here because I'm not a government member. We have spent our own budget to produce this. It hasn't been a free, pro bono project. We have actually budgeted for this process, Mr Deputy Speaker. That's how invested have been into this process. So to dismiss this work is absolutely disrespectful, and it disrespects the wishes and the values and the principles that have been brought forward for years and years and years by Territorians on this issue. Mr Deputy Speaker, Territory Labor has offered a bipartisan approach to this critical issue. We have prepared this very important work, provided it to government. I don't even know when that has ever happened, and there's, Madam Speaker's been in the House longer than I. I'm not sure if that's ever happened. Has a private member's bill ever been gifted to the government so they can just get along with the job? We don't think so. So this is a measure of extreme difference, a very unique situation in the Northern Territory Parliament, where we want to see the government, the opposition, the crossbenchers work together, get on with the job and provide that very important final bill to the Parliament. Mr Deputy Speaker, as I've spoken about publicly and in this place, there are people in the community who hold strong views against voluntary assisted dying. And that is absolutely fine. It is their prerogative, and I do respect their view. Some of those people are my constituents of Arnhem. Some of them live in the electorates of my Labor colleagues. Some hold these views on faith-based grounds, some hold them on cultural grounds, some hold them on both. But sometimes you do have to push to make decisions that are in the interests and align with the views of the whole of the Northern Territory. Whether you personally are supportive of VAD, whether you fear pushback from the people who might normally support you on other issues, this goes bigger and beyond us as an individual. This goes to what we can provide the very people we represent, Territorians, to have that choice. And remember, it is about choice, which currently, regardless of your views on voluntary assisted dying, Mr Deputy Speaker, the Northern Territory, nobody has that choice. So sometimes you do need to push through what's hard and challenging to make sure what comes out is right. Voluntary assisted dying is not something that everyone in our community supports, and they may never do so ever. But an overwhelming majority of Territorians do support the right of choice. And this is a significant number, 80%, which we found, Mr Deputy Speaker, who would like to see in the Northern Territory that choice for either themselves, for their loved ones, in ending their lives with dignity when the time is right, if they are eligible to do so under some very strict criteria. It is about providing Territorians, fellow Territorians, those who represent in this place, with that choice, should they choose to follow and do so. Mr Deputy Speaker, Territorians have made representations over many, many years to end their own suffering on their own terms, to be able to make a choice that has dignity and compassion at its heart. It is incumbent on us, Mr Deputy Speaker, in this chamber to respect that we are able to bring forward these laws to the Northern Territory Parliament, and we should do so on this matter as quickly as possible for the very sake and the dignity of those who we represent here in the Territory, Mr Deputy Speaker. It is the right thing to do, and it is time to do it.
Thank you, Leader of the Opposition. Member for Araluen.
Thank you, Mr Deputy Speaker. And I too would like to contribute to this important debate this evening on the final report of voluntary assisted dying in the Northern Territory. This report, of course, was first made public on the 30th of September by the Legal and Constitutional Affairs Parliamentary Committee. And this was a report that was requested by the Northern Territory Attorney-General on the 14th of May to inquire into the final report into voluntary assisted dying in the Northern Territory from 2024. That report was commissioned by the former Labor Northern Territory government, and it was a panel which was described as an expert panel to provide that 2024 report into voluntary assisted dying. I'd firstly like to acknowledge the work of the Legal and Constitutional Affairs Committee. It was obviously a huge task, and it was undertaken with a great deal of integrity and expertise, and I commend them for what was a huge report, or what is a huge report, and of significant depth, and you know, the collaboration and the consultation was a credit to you. I will, however, say that there's been a lot of comments about how difficult it was, and it was a strain on everyone, and it took a lot of time, and the pressure was enormous. And I take that on board, but having been around this place for a long time, I'm also very aware that parliamentary committees are meant to be like that. It's a piece of work that has a time frame, and it's meant to be a fast and concise and productive piece of research or an inquiry that's meant to put those involved, the members of parliament involved, under duress to produce something of significance. And they are significant. Every parliamentary report that is brought to this chamber is extremely significant and essential to the decisions we make in this chamber. So although it might have burnt you all out and made you feel miserable at times because of the pressure and the sacrifices you had to make, don't think for a minute that it's not valued, because it is. And this will go into the history books forever, and the governments are already committed to use that as a basis for legislation that they will bring to Parliament at some point. That was made clear by the Deputy Chief Minister the day after it was made public. So good on you. And the other thing about these processes is that they're taking place right across the country, if not the world. There's parliamentary committees travelling far and wide doing this sort of work for parliaments around the globe. I remember going to different events and joining up with parliamentary committee members from the Australian Senate and the Australian upper house and lower house and different jurisdictions. This is the work of a parliament and a democracy, and it is so incredibly important. So just take note of that. And by the sounds of it, you had an incredible experience. I mean, going to those communities, I was feeling some FOMO because, you know, you had access to information and people that I haven't sat down with and talked to forever or for many years. So such a valuable piece of work, and I think that's what we've heard today, that it has been valued. But the previous report into VAD from 2024, commissioned by the former government, that was a valuable process too, entirely different. But now what we have are two reports that can inform us about how to proceed. And I guess some of the comments I wanted to make tonight is about some of the differences between the two reports and some things that specifically don't sit with me, because I'm aware that now the work will be undertaken to put this legislation together. So now is the time to get in the ear of the government and hopefully influence some of these decisions that they will be making around models that they'll adopt and how they'll proceed. So I think it's really important that people have engaged in this debate here tonight and today, because now is the time to influence the Chief Minister and the Attorney General and the Cabinet and the CLP wing around how they proceed. You know, discussing death is culturally sensitive to all of us, and I don't mean to take away the importance it is to Aboriginal people, because it is in a very unique way. But I found myself listening to the debate today thinking death is culturally sensitive to me, and it's culturally sensitive to people who are listening tonight. It's about our values, it's about our life, because it always ends in death. It's about all those beliefs and spiritual inclinations or leanings that we have. It's a mix of so many deep ingredients of our whole existence, and you know, to some extent, I feel like what I'm going to say tonight is trivialising or could be seen as trivialising the significance of death. But believe you me, over the last 20 years of my life, I know death. And I've experienced death in many shapes and forms. So I don't mean to do that. But, you know, when you play God and bring something like VAD, voluntary assisted dying, to a bunch of people like us who are normal, average citizens who've been elected to represent a group of people that don't necessarily have great expertise in this area, then to legislate, to create laws, you're going to get that sort of rawness and that crudeness around some topics like death, which a lot of people have a difficult time talking about at the best of times. So yes, I'm just conscious of that. But yes, this is a very culturally sensitive issue for all of us, and it's one reason why it doesn't sit well with me, this whole issue or concept of voluntary assisted dying, because we are just legislators, we're just average people, and there's a certain amount of playing God, from my perspective, involved in this whole issue. But I will say, put it on the record again, I will support voluntary assisted dying for all the reasons that a lot of you have mentioned tonight. It is about personal choice, and it is about kindness and compassion, and the fact that it's voluntary makes it a little more easy to digest. But does it sit with me completely? No, it doesn't, and I will outline some of the issues I have with some of the recommendations in this report now. Probably one of the strange things that I can't quite get my head around is the fact that this report states that VAD is not assisted suicide. I'm left feeling a little bit confused by that, or a whole lot confused, to be honest. I looked up the definition of what suicide is, and by any definition, it is the act of intentionally causing one's own death. And many health and legal authorities, such as the WHO, the World Health Organization, use a definition which says it's the deliberate act of ending one's own life. So to say that voluntary assisted dying is not assisting in someone's suicide just doesn't stack up. Voluntary assisted dying is technically assisted suicide. And I can let that go to some extent because for people who use VAD, and the member for Johnston gave a good example of someone in her life that cannot get their head around the fact that it's suicide, but can live with VAD, I can accept that. But we have to be very clear here. We're legislators. We can't change the narrative and the definitions of things just because it makes life easier or more palatable for some people. VAD, voluntary assisted dying, is technically assisting people to suicide. I don't have a problem with people suiciding. I don't like it. It causes untold grief to people who are left behind. But I don't mind. I don't have a problem with people deciding to end their own life. I think it's fair enough. If people have come to that point in life for a whole range of reasons, then that's okay with me. But where I have a problem is governments taking a role, an interventionist role, in assisting people to suicide. That just doesn't quite sit with me. I can accept it and I will support it at the end of the day. But I want some honesty and integrity in this conversation. And I think that this recommendation of the LCAC report saying, redefining VAD as not being assisted suicide is just not being truthful. It's not being correct. I'll move on. I do think that the voluntary assisted dying must be a standalone service. I think for all the reasons we've heard tonight, there's too much confusion, there's too much lack of information, there's too much fear and misunderstanding around voluntary assisted dying for it not to be a standalone service. I think to connect it to any health service directly would be just a fundamental flaw and error forever. We are the Northern Territory. We have a significant proportion of Aboriginal people, and we know from the Aboriginal members of Parliament here tonight that they acknowledge that there is a lot of misunderstanding or just lack of information within Aboriginal communities about this. So in the first place, VAD has to be a standalone service. The other thing that absolutely floored me, and the member for Fong Lim talked about it earlier today, the committee determined that VA deaths should not be treated as reportable deaths. Instead, the review board will record all VA-related deaths and refer only serious cases of non-compliance or complications to the coroner. For death certificates, the committee recommends listing the underlying illness as the cause of death. You can't do that. If someone is using voluntary assisted dying to end their life, then you cannot put another reason for death on the death certificate. That is unethical. It is not true. It is misleading, and you just can't do that. I'm surprised that the LCAC has come up with this recommendation for all the right, nice reasons. It might protect people. It might, by not saying that they died through assisted suicide or voluntary assisted dying, it might not affect their ability to access their superannuation or their insurance. Those are very commendable reasons for not telling the truth, but by forging or not providing the truth, that is a legal issue. You cannot do that, and I cannot see how you would use that as a recommendation for your legislation going forward. You've talked about using a decentralised model, and I've heard a further explanation of what you actually meant. The member for Blain gave a good explanation just before, but in the first place, it has to be a centralised model. The expertise required for a voluntary assisted dying service is so specialised, so rare to find. We can't get paediatricians, we can't get podiatrists, we can't get specialists in a whole range of areas, as if we're going to have enough people with expertise in VAD to provide a high-quality decentralised service in the Northern Territory. It is just not possible. So I support the expert panel from 2024 when they recommend a centralised service. But I get the fact that at the end of the actual service delivery has to be decentralised, but the structures, which are kind of the way it's described within the report, are more centralised for the most part, but yet you've called it a decentralised service model. So I have concerns around that. My view is that given the small number of people that will access VAD, and we've heard from the member for Blain tonight, he's told us that there'll be around 8 people a year, and the enormous cost of setting this up, my view has always been, and this goes back to when the consultation was, goes back some time, that we should be outsourcing this. We should be contacting the Queensland government and the South Australian government, possibly the WA government, and talking to them about using their expertise, their service delivery, and flying people in at a fee for service. As simple as that. I think that would just circumvent so many problems, and it would be far cheaper. And as our population grows, that I know the governments, former governments, present governments, live in hope that our population grows, then perhaps we can revisit setting up our own services, VAD services in the future. But for the short to medium term, I think outsourcing this whole the delivery of VAD in the NT should be considered. Palliative care. I've been around for many years, and I remember palliative care being first set up in the Northern Territory, and it wasn't that long ago. It was only about 20 years ago. So there was life and death before palliative care. And it's interesting to talk about, hear about the concern that it's not resourced properly. It's funny how over time more and more services evolve and come about and pop up, and you think you can't live with any of these things, and then there's something else that pops up. I'm not articulating this very well, but palliative care has been an incredible feature of our health system for a relatively short period of time. And I think it has to be properly resourced. You know, if you can't fund health services, I question the rationale for providing death services and our ability to provide those death services equitably across the Northern Territory. When you live in Papunya, which is where one of the communities that the LCAC went, I dare say that their health services would be very thin on the ground. How on earth do we provide a death service to people living in remote communities? Those sort of equity issues and accessibility issues need to be considered in this too. Realistically, I mean, you know, it's a challenge just to provide health services, let alone VAD services. And of course, the prognosis timeframe for a person to be eligible for VAD, I think, is essential. This is a government service. As much as we'd like it, it's about providing a service within a budget. If you've got an open end to people subscribing and signing up for VAD, then you've got you will need a much bigger service than what.
Sorry. I move that the member for Araluen be granted an extension of time to be able to suitably conclude her remarks.
Is leave granted? No.
Thank you. Gosh, time flies, doesn't it? Yes, so I am against not having a time frame there, because it's just good governance. You need boundaries, you need to be able to plan and cost a service. If you've got this open end to anyone who's been diagnosed with a terminal illness at any stage, then I think you're going to have a much, much bigger service than what Territorians can afford. I was talking to a colleague the other day, and he talked about a Liberal perspective when it comes to voluntary assisted dying. And I agreed with him. I think from a Liberal perspective, voluntary assisted dying is fundamentally about personal freedom and autonomy. Liberal ideology values the right of individuals to make decisions about their own lives, including the manner and timing of their death when faced with unbearable suffering. At the same time, liberalism recognised the need for safeguards to protect vulnerable people, ensuring that any decision to access assisted dying is fully voluntary, informed and free from coercion. And I thank my colleague for drawing this to my attention, because this is exactly where I'm coming from. And the Liberal ideology also talks about limited state interference in the private lives of people. And that is of a concern to me, that as a government we're inserting ourselves in things that we possibly don't need to insert ourselves in. But having said that, I will support V.A.D. because, like a lot of people have said, why should Territorians not have the same rights as other Australians? But let's get it right. Let's make sure that it's a model that we can afford, that is fit for purpose, that is kind and compassionate, that provides people a choice, but is realistic and isn't an overkill, that is just right for us. We can measure ourselves off all the jurisdictions in Australia, but we are so small, and the numbers that will come through are so small. Let's just take a big deep breath and as the Chief Minister said, let's get it right for us. Take some extra time if necessary. God forbid, we've all taken some time. The opposition leader, she's taken some time to get her bill together. I think it's only fair that this relatively new government of 12 months take their time to get the legislation right and honour Territorians by having a good service. Thank you.
Thank you, Member for Araluen. Attorney General.
Thank you, Mr Deputy Speaker. And I rise to acknowledge the final report of the Legal and Constitutional Affairs Committee into the voluntary assisted dying in the Northern Territory. And the committee tabled its final report obviously this morning, and we've had a nice, very deep discussion about that right through today and the evening. And of course, this follows two earlier interim reports in July and September this year. And this final report represents the culmination of months of consultation, careful consideration and significant work across the Territory. And I want to acknowledge that this is a very important and very serious discussion that not only have we had in this chamber today and tonight, but that has been had across the Territory for a very long time now. And I do thank everybody for respectfully contributing to the debate. You know, it's obviously been a long day, and it's quite heavy for people to talk about death, because death is very, very serious. And I take on board the member for Araluen talking about how difficult it is for most people to discuss this topic. But I do want to also just be really clear with Territorians that and really pick up on some of the things that I heard from the Leader of the Opposition this evening about her draft bill that she put forward to the Chief Minister and myself yesterday, and she was out in the media talking about it yesterday. And I want to be clear that that draft bill has been drafted by the Leader of the Opposition over the last 6 months. I think she said May was when she first started working on it, based on policy work which she has created herself. She has not done the full process of going out and listening to Territorians. She hasn't spoken to the Department of Health when it comes to doing policy work. And she would know, being a former Attorney General, that that work is quite detailed, it's quite in depth, it does take time, which is why we have decided that, you know, I as Attorney General will use the government resources to be able to draft the bill based on all of the work that's been done. And I guess that's the point, that I tasked the committee to do this important work, to be able to dig really deep down on Territorians' views and what they really thought, especially going out to those communities, but to make sure that they did consider policy for us to decide and consider as a government. I think that was really important that the committee did that. So the idea and that she's clinging to, which is all the politics of this argument that she's put forward about, you know, how she's forced us into making this decision and to rush this and, you know, just get on with it. I just don't buy any of that. Then there's this other idea that she was talking about, espousing this idea that the report that Labor commissioned that was done in 2024 was ignored by government, and it was also ignored by the committee, which is actually not true, because very specifically in the letter that I first wrote to the committee asking for them to do this work, stated, like, I request that the LCAC undertake an inquiry into the voluntary assisted dying in the Northern Territory final report 2024. Like, it specifically says that in the letter. So I just wanted to correct the record of that information that the Leader of the Opposition was espousing, because it's just not true. The other thing I heard throughout the day, which was very confusing and a little bit frustrating, because I heard it time and time again, was this complaint by certain members that we haven't done VAD fast enough. So that was part of it. Like, in one hand, they're saying you haven't done it fast enough, hurry up. I mean, the Leader of the Opposition's trying to push us into it by putting forward her own, just to move us along to make it faster. But then at the same time, I heard a number of times today that there wasn't enough time to finish the work that had to be done. So there was a real contradiction in sometimes the same speaker would say those two things as polar opposites. So really confusing. And I just want to make the point, this is a very serious discussion, which we've always said should be a broad, deep conversation with all Territorians, as many as possible, and that's exactly what the work has been done. So, Madam Speaker, yes, you're back. Madam Speaker, the Northern Territory was the first place in Australia to legalise voluntary assisted dying almost 30 years ago under the Rights of the Terminally Ill Act 1995, and that law was later overturned by the Commonwealth, removing the Territory's rights to make its own decisions on this issue. After more than 2 decades, that right was restored in 2022. This was a significant moment for the Northern Territory, as we again had the option to shape our own laws, and now on this deeply personal matter, it does actually count. I thank the committee for the extensive work that they have undertaken, and I recognise, as well as the other Cabinet colleagues, the time, the care and dedication that went into this process, particularly the effort to visit remote and regional communities. It was just as important that Territorians across our vast jurisdiction had that opportunity to be heard, because we believe that consultation on this important issue in remote areas is critical, and be part of that law reform process for the Northern Territory. Madam Speaker, I want to formally acknowledge the Chair, Dr Tanzil Rahman MLA, Member for Fong Lim, and the Deputy Chair, Mr Matthew Kerle MLA, Member for Blain. I also thank committee members Mrs Oly Carlson MLA, Member for Wanguri, Mr Dheran Young MLA, Member for Daly, Kat McNamara MLA, Member for Nightcliff. The committee approached this work with seriousness and respect for the people of the Northern Territory. The committee was also well supported by the Secretariat and advisors, and I thank Dr Carolyn Williams, Kate Helmy, 𝙏𝙄𝙈𝙀𝙎𝙏𝘼𝙈𝙋𝙎, Kalen James Eichen and Kim Coucher for their professionalism and dedication. And I also acknowledge the expert advisors who provided guidance and insight, Professor Ben White, Dr. Madeline Archer, Catherine Walker, Dr. Katrine Del Villa, Denisha Tyler and Dr. 𝙏𝙬𝙈𝙀𝙎𝙏𝘼𝙈 Lambley. Their collective expert helped ensure the report is thorough and well informed. Madam Speaker, voluntary assisted dying is one of the most sensitive and complex matters that any parliament can consider. It raises deep ethical, moral and personal questions that affect every Territorian differently. Many people support the right to choose, and many others, including faith-based and cultural groups, hold strong and sincere concerns. As a government and as individual members of this Assembly, we must approach this debate with respect and compassion for all viewpoints. I am aware that some have questioned the time that we've taken to approach, the approach that we've taken to reach this point, and it is important to be clear about the history. Like I said, voluntary assisted dying was briefly legal in the Northern Territory under the Rights of the Terminally Ill Act 1995. That law was overturned by the Commonwealth in 1997, and for more than 2 decades the Territory was prohibited from making its own laws on this issue. The Commonwealth only restored that right to the Territory in 2022. The former Labor government delivered its report just shy of the election in 2024, despite not being an election commitment for the CLP government, and noting the significant public interest in this issue. We recognise that it's too important to leave unfinished. Of course, like I said, we asked the Legal and Constitutional Affairs Committee to undertake the comprehensive consultation and review that has now been completed. However, it is fair to say that progress on this issue could have occurred much earlier under the previous government, but we have ensured that it's now moving forward with structure, with transparency and respect for the community. And as the Attorney-General, I, of course, respectfully ask that the committee report back to me by the end of September to ensure progress on this, which then did happen, and we are tabling this report today. So, Madam Speaker, it is our intention to introduce a bill early next year. This timeline allows every member of this Assembly the opportunity to consult with their communities before the debate takes place, and as you highlighted yourself, talk to us about what you feel about with the report, so that feedback is well and truly heard by government. When the bill is presented, members will be free to exercise a conscious vote. That means each of us will vote in accordance with our own beliefs and the views of the people we represent. Madam Speaker, the drafting of legislation will draw on the committee's recommendations and lessons from other jurisdictions. It will also reflect the unique circumstances of the Northern Territory, including the importance of cultural safety and access in remote areas. And once the draft bill is available, there'll be further opportunity for members and Territorians to provide feedback before the debate begins. This will ensure that any future legislation is clear, safe and grounded in compassion and community expectations. The voices of Territorians are at the heart of this process, and I encourage all members to speak with their constituents in the months ahead. And these conversations will help ensure that when we come to debate and decide on this legislation, we do so with a clear understanding of the community's values and expectations. The committee's work has been detailed and respectful. It provides a foundation for informed debate in this Assembly, and so on behalf of the CLP Finocchiaro government, I again thank the committee, its secretariat, the expert advisors and all the Territorians who took part in the consultations. This issue touches life, death, faith and compassion. And our responsibility now is to consider it carefully and respectfully, guided by the voices of the Territorians that we serve. We will continue this work thoughtfully and with respect of all perspectives as we prepare to bring forward legislation into the new year. And I just want to summarise and finish by saying that it was the CLP who brought VAD to Territorians, and that was 30 years ago, and it will be the CLP that brings VAD back for Territorians some 30 years later. Thank you, Madam Speaker.
If there are no other speakers, the question is... Oh, sorry, Member for Drysdale.
Thank you, Madam Speaker. My contribution will be extremely brief. It's just to reflect on, I'd just like as we move forward, there's been commentary today on a range of things. I would like to say to all peers on all sides, and I would just like that we respect all groups, including faith groups, equally as we continue with this conversation until the vote is put. I don't think we should be targeting any single faith group throughout this, or putting a culture or a faith or any other belief system above another as we go through. So I would just ask, I'm not here to do any naming or anything, for all of us to just, I think we all appreciate the sensitivities of this topic, and if we could just go through to the end of the debate respectful of all equally. Thank you.